আগে অনেকদিন আগে যখন ধরে গেছিল চারটি থেকে বাইপাস করে এরা তুরন তাল তেল তেল করতে ছবি হয় ছবি উঠে এসছে এবারে 3 নম্বর ওয়ার্ল্ড ওয়ার লাগে তো বিশ্বযুদ্ধ হলে সব পৃথিবী গল্প শেষ প্রথমে লাগাভাবে শুটিং করছিল আফগানিস্তানের সঙ্গে আফগানিস্তানের আর্মি আর যেটা হচ্ছে তালিবান অ্যাকশন লেগেছে
এই এগুলো তোমরা বুঝেছো মানে
Good afternoon, everybody. We are going to begin the main conference of this update in cardiovascular disease to 2021. To begin with, we will have two topics in hypertension, and to take you through this conference, initially let me hand it over to my colleague, Dr. Soumitra Ray. Soumitra, you start.
Yeah. Thank you, Professor Guho. Now our main scientific program, academic program is starting after the very exciting case presentation and quiz over last 2 days. We hope that this will create as much excitement as the last two episodes. So we are first riding with hypertension. So we have coined some fancy name for those, whatever those mean. So riding with hypertension, the first we're starting with a debate. In monitoring and management of blood pressure beyond office BP, ABPM is essential. Now, I hand over the session to the chairpersons, Dr. Arup Das Vishwas and Dr. Raja Rai. And in an European and American style, we are not introducing anybody because if anybody wants, he can self-introduce. But as we usually say, we know each other. In this gathering, we know each other. I think all India level, we know each other. So it's better to start straight away. Arupda and Rajada, the session is yours. I just request everybody to stick to time. It's a power-packed program. Please stick to time.
But we have lost 4 minutes by this time. Dr. Rai, it is over to you.
Without wasting any time, I would request the speakers basically to start the ball rolling. The first speaker is Dr. Mani, I think.
Dr. Somnath Mukherjee.
Oh, Dr. Somnath. Okay.
So, am I audible?
Yeah.
Yes.
Good afternoon, respected teachers and my colleagues. My today's topic of debate is in monitoring and management of blood pressure, out of office blood pressure, ABPM is essential. And my senior colleague will speak about no, home blood pressure monitoring is good enough.
Sir, sorry to
please,
can you
please
go
put it on the slideshow. Thank you.
Okay. So, despite the advancement of the treatment, the global burden of hypertension remains pretty high. The burden is, in 2010, in Global Burden of Disease Study, it is reported it as a leading risk factor, and 9.4 million deaths are every year are there. Sir, actually, Jignesh sir, in my right side screen, can I stop the videos?
Yes, you can.
Just hiding, okay?
Yes.
Thank you. So based on office blood pressure, the global prevalence of hypertension was estimated to be 1.13 billion in 2015, which is expected to be increased by 15 to 20% by 2025, reaching close to 1.5 billion. The overall prevalence of hypertension in adults is around 30 to 45%, with a prevalence of more than 60% in people aged more than 60 years. Now, what is the role and position of the out-of-office blood pressure measurement like ABPM and HBPM? It is recommended in 2018 guideline, ESH guideline, that out-of-office blood pressure measurement with ABPM and or HBPM is recommended if logistically and economically feasible. So why the office blood pressure is in back foot nowadays? Hypertension guidelines have taken research evidences from clinical trials where office blood pressure was considered and they converted into recommendations, but office blood pressure measured during clinical trials and in reality practice differs, like there is inertia to reach blood pressure goal at the level of patient and also provider. There is lack of time, lack of training and retraining. There is inability to diagnose white coat hypertension and masked hypertension. Both out-of-office blood pressure measurements methods are better in reflecting cardiovascular outcome and LV mass. Few points about ABPM. ABPM provides the average of blood pressure recordings over a defined period like 24 hours. The device is typically programmed to record blood pressure at 15 to 30 minute intervals, and average blood pressure values are usually provided for daytime, nighttime, and 24-hour average. 40 to 60 measurements per day are there. Automated measurements are there. ABPM obtains BP measurements in a variety of conditions. ABPM obtains nocturnal measurements also. Recent advances have also been made to avoid nighttime discomfort of cough inflation, where sympathetic overactivity might increase night BP. Two salient points of HBPM. HBPM home blood pressure is the average of all BP recording performed with a semi-automatic validated BP monitors for at least 3 days and preferably 6 to 7 consecutive days before each clinic visit, with reading in the morning and the evening taken in a quiet room after 5 minutes of rest, with the patient seated with their back and arms supported. 2 measurements should be taken at each measurement sessions, performed 1 to 2 minutes apart. And compared with office blood pressure, HBPM provides more reproducible BP data and is more closely related to hypertension-mediated organ damage, particularly LVH. Regarding the definition in these methods, ABPM has 24-hour average definition more than 130/80 blood pressure, daytime average more than 135/85, and nighttime average more than 120/70. And for HBPM, it is more than 135/85. Few important points about home blood pressure monitoring, where 1 to 2 measurements per week or months are required for long-term follow-up. And in ambulatory blood pressure monitoring, at least 20 valid daytime and 7 nighttime BP recordings are needed. If less, the test should be repeated. Now, why the ABPM gained its popularity nowadays? ABPM has predictive superiority. It refines risk stratification in both hypertensive as well as general population. Greater number of reading is there, absence of digit preference and observer bias, better predictor of hypertension-mediated organ damage than office blood pressure. Furthermore, it has a more sensitive risk predictor than office blood pressure of severe outcomes such as coronary, morbid or fatal events and stroke, reduction of white coat effect, unmasking of masked hypertension, and measurement of nocturnal BP. Few points regarding white coat hypertension. It refers to untreated condition in which BP is elevated in the office but normal when measured by ABPM, HBPM or both. Prevalence is around 30 to 40%. More common with increasing age, women and non-smokers. And it is not so innocent, as having increased long-term risk of CV events reported in recent studies, especially in older patients. Both ABPM and HBPM are recommended to confirm white coat hypertension because the CV risk appears to be lower, close to sustained high normotension, in those in whom both ABPM and HBPM are normal. In masked hypertension, it refers to untreated patients in whom BP is normal in the office but elevated when measured by HBPM or ABPM. True normotension means both are normal. Sustained hypertension means both are high. Risk of CV event is substantially greater in masked hypertension compared to normotension and close to or greater than of sustained hypertension, and increased risk of CV and renal events in diabetes, especially when night BP is elevated. So night BP is an important thing. Importance of night BP in Mark in 1964 first described that importance, that elevation of basal blood pressure following sedation was an accurate marker for adverse health outcome. IDACO database revealed nighttime BP compared to daytime is a better predictor of CV complication. Isolated daytime and isolated nighttime hypertension both predicted adverse CV outcomes, but standardized condition during sleep, supine position and absence of movement probably explains why the nighttime BP is the most accurate prognostic marker. More importance, recognized reasons of nocturnal BP dipping are sleep disturbance, OSA, obesity, high salt intake in salt-sensitive subjects, orthostatic hypotension, autonomic dysfunction, CKD, diabetic neuropathy, old age, and paradoxically, if there is extreme dipping, there may be increased risk of the patients, but there are limited data to support this point. So there are few advantages of ABPM like nighttime recording, white coat hypertension and masked hypertension identification, and it is a stronger prognostic factor with very few disadvantages like expensive one and can be uncomfortable. Comfort is gained nowadays with recent advances. HBPM, it is cheap and widely available. Measurement can be done in home setting, but with certain advantages like only static BP is available. Potential for measurement error is there. No nocturnal recording. Now there is confusion regarding the competition of ABPM with HBPM. Average HBPM and daytime ABPM appear to have similar normalcy threshold, similar reproducibility, similar diagnostic accuracy for white coat hypertension and mast hypertension, and similar prognostic value, with all these features being superior to office BP. But these two methods are not interchangeable. In Pamela and Ohasama, two population outcome studies concluded that these two methods should be regarded as complementary. Regarding the variability point, ABPM provides short-term variability, HBPM day-to-day variability, office BP provides long-term variability, but the relevance of this variability metric in predicting CV outcome is still inconclusive. Issue of reproducibility, Guo et al. Found that morning BP, irrespective of the assessment methods and definition, was generally reproducible and significantly associated with vascular indices. Morning blood pressure might be preferred in this case. As there is no proper study for this issue regarding ABPM, we cannot conclude from the available documents till date. Now, regarding the hypertension-mediated organ damage, Brigiotis et al. Compared HBPM and ABPM and office BP using meta-analysis to predict the outcome of HMOD, and it included LV mass index, urinary albumin excretion rate, EGFR, carotid artery IMT, and pulse wave velocity. HBPM became comparable to ABPM as a correlate to LVMI. Both were better than office BP. But after this discussion also, can HBPM replace the ABPM? This is the main topic of discussion today. Now, home blood pressure monitoring does not allow easy recording of night blood pressure. Isolated nocturnal hypertension, which confers equal risk of daytime hypertension, can only be diagnosed straightforward by ABPM till date. ABPM is better for diagnosing hypotension, particularly in elderly, where postprandial and postural hypotension are common due to impaired ANS and attenuated baroreceptor reflex. Carotid atherosclerosis was associated with HBPM in Japanese, but in the same cohort, ABPM was a stronger predictor of cerebrovascular disease. HBPM misses the high-risk diagnosis of MH and sustained hypertension in over 25% of patients in few trials also. So, a big no of the question, answer is the big no of the question that can HBPM replace ABPM. Few points regarding role of ABPM as a treatment guide. Though ESC gave considerable attention in diagnostic role, but relatively less words in treatment role in initiating and following the efficacy of treatment. Concluding message from Spanish study, they compared casual BP measurement with ABPM, and there is led to reduction of proportion of older subject recommended for hypertension treatment, and a substantial increase in the proportion of those whose hypertension was controlled. Follow-up with ABPM in case of hypertension mediated organ damage like diabetes, it seems reasonable to repeat ABPM at 3 to 6 weeks to determine adequate BP reduction. Also, excessive lowering of BP, particularly night blood pressure, can be avoided, and once controlled, 6 monthly or annual ABPM is prudent. Now, regarding the cost effectiveness of ABPM, those who are in favor of HBPM due to its cost of ABPM, initially it was thought to reduce the cost of antihypertensive treatment in white coat hypertension with ABPM use, but nowadays the benefit extended in reducing cost of managing complications also. Krakow analyzed the potential saving of 3 to 14% for cost of care of hypertension and 10 to 23% reduction in treatment days when ABPM is incorporated. In 2011, Lobibon et al. Suggested that ABPM was the most cost-effective strategy for diagnosing hypertension in women and men of all ages and resulted in more quality of life adjusted life years for women and for men older than 50 years. Now, last but not the least, what world says. In Chinese 2019 ESH-ESC 2018 and Australian guideline, both modalities are preferred, home BP and ABPM. But in NICE guideline 2019 and ACCIH guideline 2017, ABPM is preferred, and in Canadian guideline, actually both are preferred. So from this discussion, we can say that still now ABPM is quintessential for monitoring and management of the blood pressure when office blood pressure is concerned. Thank you for your patient hearing.
Thank you, Somnath, for nice presentation, and you have finished in time. So now may I invite Dr. Siddhartha Mani to speak. Your time is also 12 minutes. Your time starts now.
Good afternoon, sir. Thank you, respected chairpersons, my co-speakers, and my sincere thanks to Dr. Shantanu sir for inviting me in this warm-up debate. So while I share my screen, I must say, just a minute. Is my screen visible?
No.
Okay.
Yeah, now it is okay.
Okay, sir. So my colleague has very wisely coined ABPM and HBPM as complementary rather than bringing in a competition between the two. And he has spent only one slide in establishing ABPM's superiority over HBPM. That is helpful for me. So, and my decent role is to establish HBPM as good enough. I need not establish the superiority of HBPM. We already know the huge burden of hypertension over Southeast Asian countries. We know that it is underdiagnosed and undertreated, and it adds a lot to the burden of cardiovascular disease, being one of the most powerful modifiable risk factors. And these are the big list of do's and don'ts in the BP measurement. We need to look after how much before the patient has taken a meal.
Just mute yourself, please.
Others, except the speaker. Others,
Please mute
keep their
yourself.
mic mute. All mute yourself.
Okay, so there is a big list of do's and don'ts in the BP measurement, and I believe that most of you go meticulously about these measuring steps. But my sincere apologies that in busy schedule, I personally probably do not stick to all these BP measurement parameters which needs to be checked before checking blood pressure in my patient. So I believe that there are a lot of drawbacks in the office BP measurement, and there is many scope of error and bias. So that is why we came to know about the entities like white coat hypertension, like mast hypertension, and there we felt the need of out of the office BP measurements. Now, this ambulatory blood pressure monitoring was no doubt a very interesting and important tool which the BP of the patient at different activities, at different times of the day, at different levels of emotional activities, physical activities, and accordingly every 15 minutes or 30 minutes they keep on measuring the blood pressure and gives us a recording, a graph over the 24 hours. But obviously there are certain doubts about ABPM. The very practical doubts which comes to the mind of the clinician and the patient at the very beginning is the availability in the primary care setting, particularly the cost, the patient discomfort, whether it is disturbing work or sleep of the patient, and whether there can be loss or error in the data due to technical issues. Then we came to know about a very interesting thing, that is the home blood pressure monitoring, which is just measuring the blood pressure of the patient by patient himself or herself, or the person who is looking after the patient, which is done at the home just twice a day, 2 readings a day. And at each time, there has to be 2 separate readings taken at 1 minute interval. The first reading should be taken in the morning within 1 hour of waking, after urination and before breakfast and drug intake. And the second reading or the last reading should be taken at the evening before going to bed. And this has to be done. Different bodies, different countries, they recommend different number of measurements, but overall it is followed that at least 3 or 4 measurements has to be taken, preferably or ideally 7, that is for 7 days. Some bodies, some countries, they ask for discarding the first day measurement and do an average of the last few days measurement, or sometimes we consider all of them. So this is just a 7-day period of measuring the blood pressure twice a day. And if we ask our patients to follow some basic instructions, I think that they follow it more meticulously than we do in our busy OPDs. So before going into the argument any further, let us see the verdict. For a clinician, the ultimate verdict is given by the patients. And this is a clear-cut data from the patients regarding the patient preference for ambulatory or home blood pressure monitoring, which shows that 82% patients reports a positive overall opinion for HBPM compared to 63% for ABPM. And among the patient population, 60% chose HBPM for their next BP evaluation. There has been moderate to severe discomfort for using ABPM reported by 55% of the patients, and severe restriction of their daily activities by 30%, which is compared to 13 and 7% only for HBPM, and the result is quite significantly different. So what is this home blood pressure monitoring? Measuring the BP by automated oscillometric device. And this is used to give improved diagnostic accuracy. This is an out-of-office BP measurement structure which can strongly predict the cardiovascular outcomes like coronary artery disease, stroke, or even mortality. And it has been reflected that every 10 millimeter increase in home blood pressure monitoring, that causes an increase of the hazard ratio by 1.17 to 1.23 in most of the studies, and even further in some meta-analysis. What are the indications of HBPM? Any patient with hypertension, rule out white coat or masked hypertension, evaluation of resistant hypertension, evaluation of the medication-related hypotensive symptoms. This is very important because many of our patients, they come to us and they blame our medicine that after taking this medicine, I am having giddiness, I am having tendency of blackout, I am having tendency to fall. And they try to stop this medication or convince us that yes, this is being caused by the medicine. And their HBPM can very accurately tell us, or even tell patient that say, after taking the medication, your BP is not falling, and this is not due to the hypotensive symptom. We can evaluate the midterm day-by-day BP variability. We can evaluate the seasonal variability because as my colleague was saying about the nocturnal and daytime BP variability, there also is a prediction that summer versus winter BP variability, they can also predict the CV mortality. More the variability, or if there is an inverse relation like BP increasing during summer and decreasing during winter, these patients, they show even more CV events. So these are certain things which can be very easily monitored by HBPM, and ABPM, with ABPM it is not possible. An improvement of patient's adherence to treatment, obviously, if the patient can measure his BP every day, there is beautiful adherence to his treatment and BP follow-up. So what are the advantages of HBPM? We can take multiple readings over an extended period of time, not even for 7 days. The patient can do it every day if he wants. We can avoid white coat effect. It is reproducible. It is predicting CV mortality and morbidity much better than office blood pressure. And it can diagnose white coat and masked hypertension. It helps the patient to better understand the management. Tele-monitoring is possible. The patient can report to the clinician about his BP variability in a very short time, and as I said, to detect the BP variability. Obviously, it is not all good about my child. It also has some disadvantages, like there may be some inaccuracy in the measurement procedure, cuff placement. There may be some inaccuracies, technical errors in the devices. There is lack of nocturnal recording because during sleep patient cannot measure. So obviously there are certain limitations, but overall this engages the patient in his blood pressure management to a much greater extent than ABPM does. It increases the clinician confidence also in the blood pressure recordings and measurement because we can follow up his blood pressure day by day. And so the lifestyle changes, the lifestyle adherences, everything improves, and that gives better control of the out-of-office BP. So now we have to look about the accuracy. If you look about the accuracy of the measurement of this home blood pressure, you can say that although there are some divergences of the measurements, most of the measurements club towards the normal office BP line. So there is less chance of accuracy. And if you compare ambulatory versus home in different substrates or stratum, you can see that detection of white coat or masked hypertension, both ambulatory and home, appears similar in efficacy. Assessment of the nighttime BP or the early morning surge is something where ABPM scores a little bit over HBPM because during sleep it can measure the BP as well. But I have a concern that if every 13 minutes the cuff gets inflated in ABPM, that may disturb the patient's sleep as well. And we do not exactly know that every time if the sleep breaks, how much that increases or that affects the BP monitoring in the patient. The other parameters like measurement of the morning hypertension, effect of the antihypertensive drugs, improving patient's compliance, patient's control rate, I think, and data also shows that HBPM is scoring over ambulatory blood pressure monitoring. And obviously, there is more availability, less cost, and more reproducibility of the HBPM data. And accordingly, seeing all these good effects of HBPM, 2017 hypertension practice guidelines, they considered self-measurement BP, that is HBPM, to be a more practical approach than ABPM, particularly for patients taking antihypertensive medications. And I will not go into the details of the guidelines, but wherever the standard guidelines has mentioned ABPM, they have equally mentioned HBPM. They have never given an age, given ABPM an age over HBPM. Everywhere it was mentioned for a mask hypertension, white coat hypertension, everywhere that either HBPM or ABPM should be followed. So it is not one over the other. There is good corresponding values. We know, we are sure about the corresponding values of the office BP and how much that will correspond to the home blood pressure monitoring. So there is also no doubt regarding what should be the home blood pressure measurement. Accordingly, we have set our diagnostic thresholds. Mostly it is more than 135 by 85. We have set our cutoffs, the target BP levels, and everything is very specific and well defined with HBPM. There has been a lot many studies with HBPM, and each of these studies show that the hazard ratio of CV events, mortality, hospitalizations, that is being well reflected by the HBPM monitoring. Every one standard deviation of the HBPM is giving 1.2, 1.3 hazard ratio for the CV events. So there should not be any doubt that HBPM do not reflect properly the hazard of cardiovascular events. It properly and efficiently reflects. And if you compare home versus office BP, you can see these meta-analysis also, they showed that hazard ratio is quite comparably increased by HBPM and office blood pressure monitoring. So there are even recent devices which uses thermosensitive monitoring for hypertension in the home blood pressure setting, home blood pressure monitoring setting. So there are improved techniques, improved machines coming up, which will give more accurate blood pressure. And if you look at the association between home blood pressure and stroke risk, in the JHOP study also, the home blood pressure monitoring was very efficiently reflecting the increased stroke risk. This is a very interesting slide. If in the upper panel, you can see that the patients were measured by ABPM and the patients defined as nocturnal hypertensive and nocturnal normotensive. The CV risk, the CAD or the stroke risk was measured. And same thing was done with HBPM. So HBPM defined nocturnal hypertensive versus HBPM defined nocturnal normotensive. You see the curves are diverging more with HBPM. That means HBPM is more efficiently reflecting the increased hazard risk for CV disease, coronary disease, or stroke in the nocturnal hypertensive. So the justification of measuring nocturnal hypertension better with ABPM falls with this data. The risk of stroke, if you calculate the multiple risk factor classification also, there also the home blood pressure is very efficiently reflecting the increased risk of stroke or the increased hazard ratios for MACE, major cardiac events, with home blood pressure monitoring only. If you look at the masked hypertensives and if you stratify them in masked hypertension patients with optimal office BP, with high office BP, with normal office BP, in all these subgroups, again, HBPM is efficiently reflecting the increased hazard ratio and it is comparable to the office blood pressure measurements. So just I mean to stress that office blood pressure measurement and home blood pressure measurements, they are giving exactly similar picture in identifying the risk of
Dr.
stroke.
Mani, please wind up.
Yeah, I just finished, sir. So if you compare now the diagnostic accuracy of home versus ambulatory blood pressure monitoring, you can see the sensitivity, the comparability, the agreement. You look at the agreement column, it is more than 85% agreement in all the different stratum between ABPM and HBPM. And recent study that showed surprisingly that HBPM demonstrated better reliability or the best reliability and strongest association with LV mass index, which is an important predictor. So HBPM not only provides a predictive measurement of BP, but also offers the opportunity to move hypertension management out of the doctor's office, thereby empowering patients for a greater role in self-managing their health. So thank you so much.
Thank you, Dr. Mani. Both the speakers have done very well. Basically, it is a debate. So it goes to who can prove his worth better, which speaker did better. So I think there is a chat box. If the participants like, they can vote for either Dr. Mani or Dr. Somnath. Overall, just to summarize, I'll take 2 minutes because the time has been already crossed, but we started 4 minutes late. That's why if we think about the vastness of our population, and so many people remain undetected, perhaps both the methods are not suitable for the remote parts of the and poorer community of the country. But even if we have to compare between the two methods, they are basically complementary. Majority of the things, as Dr. Mani showed, could be done by the HBPM, but at times, particularly to show the evidence of nocturnal dip, over dip, under dip, etc., ABPM may be necessary, or tendency to fall while awaking from the sleep due to hypotension caused by chronotherapy or some other problem may be revealed by ABPM better. So these are basically complementary. So for day-to-day basis and for better monitoring, we can do with HBPM. In fact, in my practice, I do it. Now, in certain cases, additional 24-hour ABPM may be necessary. Perhaps when the better, smarter devices come out, which can do both 24 hours monitoring as well as long-term monitoring, like the wristband or something, and when they are standardized, validated, without flaws, with epidemiological basis, perhaps they will be the answer. So if Dr. Rai has to say something, he can say there is no time for rebuttal or battle. So that's why I just hand over to Dr. Rai for his final comments. You can put your votes in the chat box. Nobody has done it. Yes, Dr. Rai, please.
Thank you, Arubda. Just a comment that I reiterate with Dr. Mani that this procedure, the ABPM, is pretty uncomfortable, and the patient has, a lot of patients have told me that it was quite every half an hour it gets inflated, and it does affect the sleep rhythm. So how does it affect the nocturnal blood pressure? I really do not know that thing we need to be. But otherwise, both are complementary to each other, and obviously for the ease of measuring the blood pressure, I think ABPM in this part of the world has got an edge over the ambulatory blood pressure disease. So with this note, Arudha, can we just conclude this session?
I think yes, you can.
Both the speakers for their excellent.
Both have done very well. So just give them the compliments and wind up.
Thank you both the chairpersons and both the speakers, the debaters rather. It was a fantastic debate, definitely. But both are very mild people, not so aggressive to fight.
No, it didn't seem a debate. It seemed a presentation, you say.
Yeah. Our next session is due now, which is a much sought after session. The chairpersons are Dr. H.K. Chopra and Dr. Shouru Mukherjee. Nobody really needs an introduction. Only my submission is that Dr. Chopra is one of the most accomplished cardiologists in India and across the world. And Dr. Shouru Mukherjee is a very senior professor. So the stage is yours, sir.
Thank you very much, Dr. Sumitra Ray. At the outset, I express my gratitude to Dr. Santanu Gua and Sumitra Ray for giving me this opportunity. This subject is very new, and the speaker is not new. The speaker is a very accomplished person. We call him as an Indian world father of hypertension. And the subject is very new. It has not been tapped, but it has lot of potential to reduce the decline of cognition if you control the hypertension very effectively. I'm sure he's going to throw, Dr. Venkat Ram is going to throw light on this subject, new arena, new management, new modalities, new protocol. I think all these things will be discussed. Ladies and gentlemen, I present to you Dr. C. Venkata S. Ram for his most prestigious presentation of this session. Dr. Ram, sir.
Thank you, HK. At the outset, ladies and gentlemen, let me thank Dr. Santanu Guha again thinking of me. This has become an annual ritual that I adhere to, and it's really a privilege to participate in this particular meeting. I have always mentioned to him, and I say it publicly, it is one of the best CME meetings in India, and it's my privilege. And before coming to the meeting, I got a call from Dr. H.K. Chopra's wife that unless I wear a shirt that is pink in color, like H.K. Chopra's jacket, I will not be allowed to participate in the Zoom meeting. And I could not disappoint Dr. Guha. So I found a shirt finally, which was required from the Chopra family for me to wear. And I hope that it is displaying the color, same thing myself and Dr. H.K. Chopra. Let me start sharing the screen, and then I will start the session. Ladies and gentlemen, this is an important topic for all of us. Because this is something that we don't think about it. When we think about high blood pressure, as you heard from the previous speakers, you think about vascular disease, you think about heart disease, you think about heart failure, you think about proteinuria, you think about CKD, you think about dialysis, you think about end-stage renal disease, but we don't really think about dementia and connect it to high blood pressure. In fact, dementia is one of the most serious complications of high blood pressure, very important complications of high blood pressure. Dementia, by definition, is progressive loss of intellectual function. A lot of times we assume that dementia is a natural component of aging process. In fact, none of the aging studies have shown that dementia is connected to aging. In fact, it's very interesting. A few studies have shown that with aging, the cognitive function improves, does not decrease. So, ladies and gentlemen, we should forget the notion of relationship that aging is associated with dementia. But dementia is generally in the elderly is due to vascular dysfunction, also known as vascular dementia. So let me share with you now the relationship between elevated blood pressure and the onset of dementia, and what can be done to improve cognitive function in our patients with high blood pressure. It has been shown that once the patient develops stroke, there is a very high risk of dementia in people who recover from stroke. And stroke is the only complication that is directly related to high blood pressure. Because in patients with coronary artery disease, there are multiple reasons. In patients with chronic kidney disease, there are multiple reasons. There is only one complication that is completely attributable to high blood pressure, and that is stroke. And in patients who develop stroke, dementia is an important consequence of a stroke. Ladies and gentlemen, dementia and high blood pressure is not a new topic. It's a topic that we're discussing, but this has been known for a long time. You see, this is in a very old study in late 60s showing that hypertensive levels of blood pressure are associated with intellectual loss. So this has been demonstrated before we had CT scan, before we had MRI, actually before we had neurology as a designated specialty. So, ladies and gentlemen, the observation of linking cognitive function to blood pressure has been known to physiologists for a long period of time. Now, we are going to see an increasing number of people with dementia over the next several years. And much of these occurs in the elderly population, but not because of age, but because elderly people have high blood pressure, and if it is not controlled, it contributes to dementia. Now you will see that in next few years, ladies and gentlemen, there is going to be a 300% increase in dementia in China and Asia. So basically 90% of cases of dementia in the next 2 decades will come from India and from China, and we need to do something about it. One of the things that occurs in patients with hypertension, if they undergo brain imaging, they have what is known as white matter lesions. And this is a radiological term when there is accumulation of amyloid material and when there is ischemic mass multiple. They just call it as white matter lesions because this is affecting mainly white matter. But when you see white matter lesion, ladies and gentlemen, it is an extremely serious finding. It is not a benign finding. It indicates there is a structural damage to the brain for a number of reasons. The principal contributor of white matter lesions is high blood pressure. And this is a study that was done looking at white matter lesions and the risk of dementia. You will notice the more number of white matter lesions a person has, there is a higher risk of dementia. The fewer white matter lesions we have, there is a lesser risk of dementia. So, Mr. Chairman, ladies and gentlemen, I have so far shown relationship between blood pressure and white matter lesions. Now I have shown you the relationship between white matter lesions and dementia. So I'm going to link this pathophysiologically, just like the Cox postulates. I'm going to link the blood pressure to dementia and the pathways by which dementia occurs. Hypertension is very strongly linked to brain lesions, which are white matter lesions. So if there is a report that comes white matter lesion, it is not a benign finding. It is not something that one should actually ignore because it is a portender for the onset and progression of dementia. Now, I have shown you this earlier, that in most countries, the dementia incidence will increase after the age 75, and Asia is not an exception. Asia also will continue to see a significant increase in patients who are diagnosed with dementia. A number of years from 1970s to now have shown with follow-up, and some of the studies have been followed for about 30 years. And you will notice every single study with high blood pressure has shown that it is associated with cognitive decline, it is associated with dementia, and many people are misdiagnosed with Alzheimer's disease. What happens in Alzheimer's disease is somebody has dementia, we call it Alzheimer's disease. So basically it is vascular dementia rather than typical Alzheimer's disease. So ladies and gentlemen, this is only a segment of studies that have confirmed a relationship between the diagnosis of hypertension and onset of cognitive dysfunction. Now, higher the blood pressure, greater is the risk of cognitive dysfunction. This is a slide showing the relationship between cognitive dysfunction, mild blood pressure, green, moderate, orange, severe hypertension, blue. You will notice at every level of blood pressure, higher the blood pressure, greater is the diagnosis of dementia. Let me now turn to the pathophysiology of high blood pressure and dementia. What happens with chronic hypertension, uncontrolled hypertension? People can develop stroke, you can develop cerebral vessel disease. Most importantly, ladies and gentlemen, you accumulate what is known as beta amyloid. There is accumulation of beta amyloid, and the short form of beta amyloid is not BA, but AB. That's one way to remember. It's just reverse. Whenever there is accumulation of beta amyloid, there is a structural damage to the brain. As a result, there is a protein dysmetabolism in the brain, resulting in the patches of beta amyloid in the brain. And the presence of beta amyloid is really a MRI marker of onset and progression of dementia. So what happens is with chronic hypertension uncontrolled, they develop a beta amyloid accumulation, which is a marker like troponin for ischemic heart disease. It is a marker of dementia. Now let me show you. This is a very nice demonstration that chronic hypertension disturbs the pathophysiology of vascular function in the brain. And whenever this vascular dysfunction occurs, there is accumulation of beta amyloid. In fact, they use the word here, synaptic toxicity. That means synapses are toxic and they're not able to connect. When they don't connect, there is no neurotransmission. So ladies and gentlemen, high blood pressure leading to beta amyloid accumulation, leading to synaptic dysfunction causes disturbances in neurotransmission. And one of the manifestations of disturbances in neurotransmission is loss of intellectual function, also known as dementia. So let me summarize this part of my talk about pathophysiology. High blood pressure leads to stroke, which may lead to dementia. High blood pressure leads to cerebral atrophy, which may lead to dementia. Hypertension leads to white matter lesions, which may lead to dementia. So high blood pressure can cause dementia by two mechanisms. Number one, it causes dementia directly without causing stroke. But it can also cause dementia through causation of stroke. You saw that the presence of stroke causes dementia. So high blood pressure causes cerebral dysfunction directly or through causing stroke, both mechanisms. So let me summarize the pathophysiology that high blood pressure is associated with lacunar infarcts. That means any lesion in the brain that is less than 20 millimeters in size. White matter lesions, microinfarcts, any lesion in the brain that is less than 1 millimeter in size. And high blood pressure can also cause Alzheimer's disease. All these four components can contribute to onset of cognitive impairment or dementia. Now, let me make some final remarks on what we can do about it. This is a very recent article that looked at 209 studies. Ladies and gentlemen, that is a lot of number of studies to look at. They have shown that a blood pressure systolic greater than 130 is associated with a 34% increase in cognitive impairment. Not 5%, not 8%. Blood pressure greater than 130 is associated with a cognitive impairment by 34%. Myself and Dr. Chopra have written an editorial in circulation 3 years ago why the blood pressure should be less than 130, and now you see the reason is that it increases the cognitive impairment by 34%. But when there is darkness, there is also light. When there is night, daytime ultimately occurs. It has been shown that antihypertensive therapy, namely blood pressure reduction, may prevent the risk of dementia. These are the earlier studies looking at the association between antihypertensive drugs and dementia. As you notice, all these studies have shown that chronic antihypertensive therapy decreases the risk of dementia. So dementia can occur, but the risk of dementia decreases with chronic antihypertensive drugs. This is another set of studies, older versus new. All of them demonstrate favoring treatment as opposed to placebo. So antihypertensive therapy in comparison to placebo, namely uncontrolled hypertension, has been shown to decrease the incidence of dementia significantly, really significantly. Let me show you a very important study. This is a study where there is an overall risk of dementia is 2.3, but uncontrolled hypertension, the risk is through 3.4. But when you treat hypertension, the risk goes down to 1.9. So, ladies and gentlemen, very beautiful study demonstrating that uncontrolled hypertension leads to dementia. Controlling hypertension decreases risk of dementia. This is a study goes under acronym MOSES, where elderly patients were treated for high blood pressure. You will notice systolic blood pressure was treated, it came down. Diastolic blood pressure was also treated, it came down. But when the blood pressure improved at the end of the study, the cognitive function also increased. Very beautiful demonstration that there is a reciprocal relationship between blood pressure and cerebral function. In this particular study, where systolic and diastolic blood pressure went down, there is improvement in cognitive function in your patients. What is the relationship between the magnitude of blood pressure reduction and cognitive impairment quantitatively? Greater the blood pressure drop, greater is the cognitive impairment. You will notice when you drop the systolic blood pressure by 40 millimeters, there is a tremendous improvement in cognitive function. When you drop it less, there is some improvement, but not as improvement as a robust drop in blood pressure. Namely, when you reduce the blood pressure significantly, there is a maximum benefit. Whereas if you leave the blood pressure uncontrolled, 140, 150, 160, you don't see much improvement. So there is a quantitative relationship between the quantity of blood pressure reduction and the quantity of cognitive improvement. And finally, very important study that all of you are familiar with, SPRINT. In SPRINT, they also studied people who were more than 75 years of age. The blood pressure was either 120 or 140. You will notice that in patients 75 or over, there was a significant improvement in morbidity and mortality at blood pressure at 120 compared to 140 systolic. But they studied cognitive function. What they noted was the cognitive decline was arrested when systolic blood pressure was close to 120, namely intensive treatment shown in the red color. You will notice the progression of dementia was significantly attenuated or reversed when the blood pressure was reduced to 120. So, ladies and gentlemen, don't abandon patients over the 75 years of age or more, because we're going to get there, all of us. Don't abandon them. Don't make them as orphans, because when you treat hypertension, not only you decrease cardiovascular morbidity and mortality, but SPRINT has demonstrated that you actually improve their cognitive function. So what they have shown is that when you reduce the blood pressure in the aging population, you actually improve all degrees of dementia. And that is what they have shown in the SPRINT study, a wonderful study to demonstrate that older people should not be neglected. Don't put them away. Arey buddha ho gaya, buddhi ho gaye, usko chodo. Not all this stuff, please, because we are also getting there. So, ladies and gentlemen and panelists, let me conclude. Dementia is a dangerous complication of hypertension. Aggressive blood pressure control decreases the chance of developing dementia. Aggressive blood pressure control improves the cognitive function. So one important hypertension is to preserve cognitive function. And lastly, this is my last slide. Normal brain aging might decrease our multitasking, but it does not decrease memory, skills, and knowledge, which are stable. And in fact, NIH, Centers for Disease Control is NIH, has actually said that these things improve with aging. So dementias are not inevitable part of the aging process, nor with normal brain aging, we retain skills and knowledge learned through our lives, so they don't decline. And this is something that I got a communication from one of our managing director's granddaughter, namely Dr. Pratap Reddy's granddaughter. She has sent me this other day, just a pure coincidence. I really was surprised that I got this communication from her. Very beautiful communication. Take care of your mind, your body will thank you. Take care of your body, your mind will thank you. Very beautiful. So, Mr. Chairman, ladies and gentlemen, and Dr. Santanu Guha, let me thank you for allowing me to participate. And in the time that was allocated to me, I connected the blood pressure to cognitive dysfunction, not only by level of blood pressure, but also the pathophysiology of multiple mechanisms by which dementia can occur. I showed you the studies where they have shown treatment of hypertension favors improvement in dementia. And I show you a series of studies coming to the same conclusion, ending with SPRINT, which also showed. So, ladies and gentlemen, there is no reason to despair. We can prevent dementia in the population by controlling hypertension aggressively. Don't say chalta hai, chalta hai, chalta hai. Chalta kuch chalta nahi, marta hai, chalta nahi. So you don't say that. So you prevent dementia, but somebody has dementia, don't abandon them to a senior's home or somebody, don't abandon them to a caretaker. The studies have shown that treatment of hypertension actually improves the cognitive dysfunction. So there is despair, there is hope, but we always favor hope over despair. With those remarks, Mr. Chairman, ladies and gentlemen, and Dr. Santanu Guha, Bhishma Pitamaha's father, Santanu. So with those remarks, I'll conclude. Thank you very much for this opportunity.
Thank you very much, Dr. Venkat Ram sir, for a beautiful and most lucid presentation. I think your message was very, very clear. And the cutoff parameter of the systolic blood pressure is a real information and a message for everyone. At any cost, our systolic blood pressure should not go beyond 130. And you've shown a very beautiful data. I think it is a mind-boggling. We have to consider not only in ourselves, but also in our patients, that we must make sure that the blood pressure does not go beyond 130. Dr. Venkat Ram has also given one more very important message, that dementia is not inevitable. Very important sentence. I don't know from where he chooses all this, but this is a very important sentence. We have to take care of ourselves. Ye nahi bolna chalta hai chodo. Chalta nahi marta hai. Hindi also speaks very well. I think this is a very important message. And the way he described the pathophysiology, that it is the beta amyloid which get deposited, and the white score, which of MRI, is very important. I just only one small question, Dr. Venkat. You use the word Alzheimer's or pre-Alzheimer's in one of your slides. Is there any distinction between the Alzheimer and the dementia, or there is any biochemical markers we can say, or there is no, or there is a very thin margin between the pre-Alzheimer's or Alzheimer's and dementia? We'd like to have your opinion, sir.
I know we're running out. One of the complications of high blood pressure, forget what I talked about is vascular dementia. But Alzheimer's is an independent entity, and there is a high prevalence of Alzheimer's in patients with hypertension. And they always mention hypertension is a risk factor for Alzheimer's. But many of these patients with Alzheimer's are misclassified as Alzheimer's. They actually have vascular dementia. We call that Alzheimer's because, sorry to say, it's a very convenient term. Very convenient term. We say that so that we can conclude the matter. But actually, many cases of Alzheimer's are due to vascular dementia. Now, what can happen? Of course, you can get Alzheimer's without hypertension. But one of the things that is common both in Alzheimer's and in vascular dementia is the deposition of beta amyloid. Both of them have beta amyloid. Only thing is those microinfarcts, less than 1 millimeter in size, and lacunar infarcts. All of us are used to using this term, lacunar infarcts. The lesions less than 20 millimeters, they are more common in vascular dementia, hypertension, but you don't see them in Alzheimer's.
Thank you very much, Dr. Venkat Ram. I think I just give my tribute for a beautiful presentation. Is there any questions or suggestions or comments from anyone else before we close the session? Dr. Santanu, Sumitra Ray, or anybody else?
Just one comment, sir.
Can I ask you a question, sir, Dr. Ram?
Sure. Sir.
Yeah, the brain is a neuroplastic organ, and the short-term, long-term memory depends on neurochemical changes in the short term. In the long term, there is neuroplasticity, the structural changes occur. By improving the cognitive power of human being, can you change the blood pressure?
No idea. You're saying the reverse. Just like obstructive, what you're saying is by treating obstructive sleep apnea, the blood pressure goes down.
Yeah.
So basically, you're giving the same analogy. I have no idea. I never thought of it. I'm sorry, I'm using the word never thought in this context.
Yoga and pranayam can certainly reduce blood pressure. So mind has got something to do with blood pressure, definitely. What I want to say to conclude is that both Dr. Chopra and Dr. Ram have proven themselves in their life that with age, memory, knowledge, and skill can increase. And they can still wear pink shirts in their 70s. So that itself proves the subject beyond any doubt. So thank you very much to all of you, as well as Dr. Shouro Mukherjee.
We are competing and our shirt and jacket will go on till 90 years of age. Thank you.
Thank you, Dr. Ram and Dr. Chopra. For the sake of time, we need to move to the next subject. It is related to This is related to the lungs. What is new in the management of pulmonary hypertension? As Dr. Kajol Ganguly is there. Dr. Kajol Ganguly, you are there. And Dr. Ramakrishnan. Ramakrishnan may only be there because he was very busy with the quiz till 12 noon. So may I request Dr. Shouro Mukherjee and Dr. P.K. Hajra to chair the session. Shouro, you remain as a chairperson, and Dr. Hajra, you please take over. And the speaker is Dr. Arindam Pandey. What is new in the management of pulmonary hypertension? Arindam, please.
Thank you, sir. Thank you very much for giving me the opportunity to speak in this August forum. And I was seeing fantastic program which is going on. So the topic which I have been allocated is what is new in the management of pulmonary hypertension. And time is 15 minutes. I'll try to finish even before. Okay. So basically, if we see that there have been different classifications of pulmonary hypertension, but one of the three definitions which actually suits very well for the management purpose is the pre-capillary pulmonary hypertension, isolated post-capillary pulmonary hypertension, and combined type. So how do we differentiate? In pre-capillary pulmonary hypertension, the pulmonary artery wedge pressure will be less, so it will be lesser than equal to 15. At the same time, the mean pulmonary artery pressure will be more than 20 and PVR will be also high. Now, isolated post-capillary pulmonary arterial hypertension is not very common, but here the PVR is going to be less, but the mean pulmonary artery pressure as well as pulmonary artery wedge pressure will be high. And in combined type, where both post-capillary and pre-capillary derangement and pathophysiology is there, here everything is going to be high, both PVR, pulmonary artery wedge pressure, and mean pulmonary artery pressure. So for our practical purpose, we should concern very much about the pre-capillary pulmonary hypertension, which is the commonest form of idiopathic pulmonary arterial hypertension, and all our effort to treat the pulmonary arterial hypertension is to treat this subset only. Now PAH, now the recent concept is to have something called directed therapies. To understand directed therapy, now there are three gross current therapy targets. One of the target is endothelin pathway, second is nitric oxide pathway, and third is prostacyclin pathway. So endothelin pathway, it works to endothelin 1 receptor. So we do have endothelin receptor A and B, and we can block them. And there are multiple agents starting from bosentan, ambisentan, and recently macitentan, which works through this pathway. Second is the age-old nitric oxide pathway, where L-arginine plays a very vital role, and nitric oxide, as we all know, cyclic guanylate cyclase is very important to generate cyclic GMP. So cyclic GMP, cyclic guanylate cyclase stimulator is one of the latest innovation in the therapy of pulmonary arterial hypertension. Dr. P.K. Hajra is also there as a chairperson. He will be very excited about Vericiguat, but we do have older molecule, which initially was actually evaluated in pulmonary arterial hypertension treatment only. Then we do have phosphodiesterase inhibitor, which are actually sildenafil, later on tadalafil, which is the longer acting version of it and lesser side effect. All those things are also playing very important vital role in the therapy of this condition. Now, prostacyclin pathway mostly reserved for very advanced situation, because initially all the molecules were parenteral. So there are prostacyclin derivative. Now, recent developments are from parenteral IV to subcutaneous. Now they are available in inhalational form as well as oral form. And there is a new development in the form of IP receptor agonist, Selexipag, which has probably changed the whole therapeutic armamentarium of this condition, because that is wonderful molecule and extremely effective, which is also available in our country as well. So briefly, I'll go through all of them. Now, this is the just elaborated version of the last slide. I'll skip this. So basically, the therapy of this condition, the trials and all research, if we just date back, it started from 1960s. So at the initial part, there were empirical treatment, mostly vasodilators were used. Then in 1980s, oral anticoagulants was found to be very, very effective. And now till date also, this has become a standard of care in this condition. All majority of the patients are actually receiving some form of oral anticoagulant. Then in 1995, the prostacyclin era started, initially IV epoprostenol, then in 2001, bosentan, 2002, treprostinil, which emerged as a subcutaneous therapy, followed by IV treprostinil, iloprost, later on inhalational iloprost, and sildenafil. It was available in 2005, 2007, ambrisentan, then 2009. Tadalafil, another phosphodiesterase inhibitor, and treprostinil now it was available in inhalational form, 2010. Thermostable form of epoprostenol, a prostacyclin derivative, was available. Then Rayashiagat, the initial trial was very encouraging. I'll briefly show that trial, 2013, and macitentan and treprostinil oral. So first time oral prostacyclin derivative was available, 2013. And the latest established therapy in this particular situation is Selexipag, which was available 2015. So these are the different classes of drug which are available for treatment, mostly the prostacyclin derivative, initially IV infusion followed by inhalation, iloprost, treprostinil is available in all the form, oral, inhalation, and subcutaneous as well as IV. Prostacyclin receptor agonist, the latest development, Selexipag, oral. It is supposed to be started at a dose of 200 microgram twice daily, and gradually we try to build up the dose up to 1600 microgram per day. And then there are endothelin receptor antagonists in the form of bosentan, ambrisentan, macitentan. All of them are oral. Bosentan had important limitation in the form of hepatotoxicity, which was taken care of by the further generation endothelin receptor antagonist. Phosphodiesterase 5 inhibitor, probably the cheapest one to treat this condition. Sildenafil, widely available. Tadalafil, little costlier, but yes, it is also widely available, and we use them very often. And both of them are available oral, and sildenafil IV injection is also available. Soluble cyclic GMP stimulator, Rayashiagat, was evaluated and found to be very effective, and so oral formulation. So if you look at the timeline of the different studies and trials, so initially all the trials, say for example the trial with bosentan, breathe 1, and ambrisentan, ARIS 1, ARIS 2, all of them actually were shorter studies. Basically they tried to improve the quality of life of the patient, to improve the 6-minute walking distance, and those were the primary outcome. And short duration studies were actually performed. Gradually, initially the studies used to be 32 patients, 200, 150, this kind of small study and small follow-up. Later on, when we got more important and more effective molecule in the form of macitentan, first time in Seraphine trial, it included 742 patients, and we can see the primary endpoint also changed. The trials become larger, longer study period, and basically event-driven outcomes. So they tried to look whether the survival benefit is there with the newer molecule. There had been The largest trial in this situation was with Selexipac in the form of Griffon trial, which included more than 1,000 patient as in was evaluated. Then the era of combination therapy. The first landmark trial was Ambition trial, which combined ambrisentan with tadalafil. That was also relatively a larger study with longer follow-up period, and it was also an event-driven trial. So what it indicates that probably we are getting more effective molecule for treatment of this very, very lethal and fatal disease. Now, coming to the important adverse event. Now, we all know endothelin receptor antagonist fluid retention is important adverse effect. Anemia and abnormal LFT with bosentan, which is well known. They are not tested in pregnant ladies. Phosphodiesterase inhibitor, headache is important. Nasal congestion and GERD, which is not a very important side effect. Prostanoids, headache, and very typical side effects of jaw pain and bone pain, particularly if you're using intravenous formulation. Flushing can also be there, and line infection and cough if you're using inhaled form or injectable form. Those are additional adverse effects because they need to take it for a longer period of time. They might be discharged home and they are taking it at home. So this side effects becomes important. Now, soluble guanylate cyclase ricin can cause headache, symptomatic hypotension, syncope, dyspepsia, some peripheral edema, and they are also not tried in pregnant ladies. Now, if we look at the flow chart, how should try to treat the algorithm, then World Symposium of Pulmonary Hypertension 2018 is the latest guideline, and first thing we should do to treat this kind of patient is to check the vasoreactivity, whether the pulmonary arterial hypertension is vasoreactive. If it is vasoreactive, then yes, most important treatment is calcium channel blocker, but the dose of calcium channel blocker which is supposed to be given many a time is not tolerated by the patient, but if they tolerate, then it works very fantastically. Now, if it is not vasoreactive, then we need to assess whether the patient is having low risk, intermediate risk, and high risk, because this is very important. Say, for example, a patient who is having right ventricular dysfunction, which is not responding with diuretic therapy, and the functional class of the patient is very advanced, then this is a patient who is actually very high risk patient, and we should initiate combination therapy from the very beginning, including injectable formulation of prostacyclin. Otherwise, in some of the patients, probably we can try monotherapy. So monotherapy is not altogether obsolete, though the fashion nowadays is to start combination therapy from the very beginning, either double drug. I'll show you some trials with triple drug combination from the very beginning as well. So there are group of patients who can respond with monotherapy, say for example long-term stable patient, say, or in group of patients where combination therapy is unavailable or contraindicated, those kind of patients. And there are some other conditions where monotherapy can actually be tried. Now, there is something called worsening pulmonary arterial hypertension and disease progression. So any patient, when treated with initial therapy, if he doesn't respond or he progresses to the next functional class, then we'll consider the treatment to be failure, and we should try to add on modern therapy or other, next stage therapy. Say, for example, lung transplantation, balloon atrial septostomy, and hospitalization and in-hospital treatment, intravenous treatment, those kind of situation actually arises. Now, basically, my job is to discuss about the newer discoveries and newer avenues in this very deadly situation. So one of the new research actually is concentrated in the field of metabolic basis of pulmonary arterial hypertension. So just I'll briefly touch upon the insight from the NHLBI pulmonary vascular disease phenomics, which is also commonly known as PVDomics study. So this is a worldwide network where actually different phenotypes of the disease, idiopathic pulmonary arterial hypertension, actually are being analyzed. And why they're doing so? Because the global metabolite group comparison, they actually try to evaluate different protein, nucleotide, and lipid, and they actually classify the patient in different clusters, and these clusters may not be similar to the WHO or World Symposium of Pulmonary Arterial Hypertension cluster. There are 30 top-ranking biochemicals in the importance plot suggested by key differences. So they analyze the amino acid metabolism, lipid metabolism, nucleotide metabolism, and by that different parameters after analysis, they differentiate the patients into different clusters from cluster 1 to cluster 6. They also take consideration important clinical marker in the form of distance walk from 6-meter walking test, DLCO, RA pressure, mean pulmonary arterial pressure, cardiac output, cardiac index, and PCWP. And why they are doing it? Because this PV-domics, they uses deep clinical and panomic phenotyping to identify novel subphenotypes of pulmonary vascular disease, regardless of the World Symposium of Pulmonary Hypertension clinical classification. And preliminary metabolic data from this actually reveals that novel metabolic amino acid and lipid cluster that are not defined by the existing group or hemodynamics are there, and they can actually get benefit by targeted therapy of different kinds. So regarding the management, what is new? Yes, there has been correlation between gut pathology and its rescue by angiotensin converting E2 enzyme in hypoxia-induced pulmonary hypertension. So it was found that there has been a link in between ACE2 overexpression for this hypoxia which is there in gut, and this in future can be one of the target for therapy of this condition. So that is also important. Upfront combination therapy, I already mentioned that from the very beginning, in very high-risk group of patients, combining 2 molecules or 3 molecules from the very beginning is showing very encouraging data. And upfront triple therapy has been evaluated. It started way back in 2014, initial trial. Data shows that if we combine the recovery of the RV function is far better compared to single therapy or combination with 2 therapy. And so this kind of effort is continuing. They are actually trying to find out what are the molecules which we should combine from the very beginning, and they are actually analyzing data. This is another trial where ambition plus subcutaneous treprostinil, that means ambrisentan plus tadalafil plus subcutaneous treprostinil was used in very sick patient, class 4 symptomatic patient or class 3 very high risk feature patients. And what was the result? Result was actually very encouraging. All the parameters were statistically found to be better, starting from right atrial pressure, mean pulmonary arterial pressure, and the functional class of the patient actually improved in this 24-month follow-up. But the problem is all these trials are very small size trial. We cannot conclude that we should offer this combination, triple or double combination to all the patients. But so far, whatever data we are having in very sick patient, particularly high-risk patient, if we combine multiple therapy, the benefit is evident. This is another very recent data. 2020 publication of Triton triple therapy, 247 patients, and this found that combining triple therapy in a very sick patient actually is far superior compared to the single therapy or combination 2 therapy. Now, what is the consensus regarding this multi-pronged approach from the very beginning? ACC/AHA guideline recommend that intravenous or subcutaneous treprostinil as second or third line therapy in patients that are considered low risk, while IV eprostenol and treprostinil are considered first line in high risk. So if the patient is high risk, we should go for injectable form, multiple medication from the very beginning. Similarly, 2015 ESC guideline and 2019 World Symposium on Pulmonary Arterial Hypertension gives similar recommendation that IV prostacyclin should be initial therapy in WHO Group 1 functional class 4 patients only. So that is the consensus. Now, another very important new molecule I'd rather say is the sotatercept for the treatment of this condition. This actually bone mineral protein, there is a disbalance in the growth promoting and growth inhibitory mechanism, and what this molecule does, it actually restores this derangement, and this is a very novel treatment. The trial came up in the name of Pulsar trial, and this showed that both the doses, this is available in subcutaneous form, 0.3 milligram per kg and 0.7 milligram per kg, and the result, the Pulsar trial showed that, this is a very important trial, showed both the doses actually is statistically superior compared to conventional background therapy. So all the patients were optimally treated as per the current guideline. On top of that, this new molecule showed benefit. Now, replace study I already mentioned. This is the study where the molecule Riaciagat was tried. So one group continued with phosphodiesterase inhibitor. Another group, the phosphodiesterase inhibitor was replaced with this new molecule. And what was found, patients where in primary endpoint were met was far superior in the Riaciagat group, and it was statistically significant with a p-value of 0.0007. So this molecule also probably opening a very new avenue, and this is available oral. So this can be a very important therapy in this particular condition. Now, inhaled treprostinil in this particular situation has also arisen, and the trial with inhaled treprostinil was also found to improve the functional as well as the hard endpoint of the patient. Now, another very important, new avenue of treating this condition is the pulmonary artery denervation. Dr. P.K. Hajra might be interested. So the denervation is, shifting base from renal artery to pulmonary artery. So the patient who actually undergone pulmonary thromboendarterectomy, this group of patient was chosen, and one of the arm, the conventional oral therapy and IV therapy was continued. Another arm, they subjected the patient with denervation therapy, and what was found, the denervation, we can see the gap in between the clear separation. So pulmonary artery denervation is another very new novel therapy which is probably coming in a big way. Initial trial result is very promising. It reduced the pulmonary vascular resistance in a significant way. So other trials to note is
the time is up.
Please
this is
conclude.
probably my last slide, sir. Co-op trial that evaluated transcatheter mitral valve repair, that also showed by curing mitral regurgitation, probably PA pressure can be improved. And I think I should stop here. This is the last slide. Yes. So we need to find out the COVID-19 related pulmonary arterial hypertension, how they behave. I think I should stop. Thank you, sir.
Brilliant.
Thank
I would
you.
say a brilliant talk by Dr. Pandey. Exceptional talk, class 1 talk. Now, I think the story is still evolving over time, and you ended up with COVID-19, and some of these patients do need lung transplantations, and it is possible in our country. The first line of therapy in any pulmonary hypertension, you have to rule out secondary causes, and you have to give continuous oxygen therapy, ambulatory therapy, which is available, affordable, and attractive, and sometimes a combination. And he has highlighted the pneumotherapy, a device therapy. Only one thing he has not mentioned, and I do have some cases of pulmonary angioplasty. You have to do the CT angio, then you have to do the FFR of the pulmonary artery, smaller branches, and you have to treat them by balloon angioplasty, not by stent. Sequentially, the segmental and subsegmental branches of the pulmonary artery. Sometimes the combinations. Be aware of the side effects like hypotension. Another therapy in the field of diabetes, like SGLT2 inhibitors, are quite promising in the treatment of pulmonary hypertension. But he has exposed a new horizon, a new kind of polypharmacy in pulmonary hypertension. Thank you very much, and over to Dr. Guho and Dr. Shoji.
Thank you, Arindam. That was a very lucid lecture, though there's a lot of informations, and you don't really have a take home from that. Now, one question I want to ask you, in patients with Eisenmenger, so that is the commonest problem that we face. So what is the drug of choice in such cases? What is the drug of choice to treat the pulmonary hypertension?
That drug of choice, I mentioned that treatment of choice is heart-lung transplantation. You also know that, Eisenmenger. If you really want to cure the disease, you need to transplant both heart as well as lung, because the vasculature, there is obliterative pulmonary arterial hypertension. But apart from that, now all the studies are indicating that whatever therapy we are offering to idiopathic pulmonary arterial hypertension, we should offer them to this Eisenmenger syndrome patient, and they actually benefit. They benefit, and we should offer all the available. As per the functional class, we should see what class the patient is. If they are at a higher class, say for example, very sick class 3 or class 4 patient, WHO, we should start with IV or oral prostacyclin derivative, along with the other conventional therapy in the form of ambrisentan, bosentan, whatever, and phosphodiesterase inhibitor. And also we do have selexipag nowadays. Selexipag is available, is marketed by some company in India as well. We should offer. All of them can be offered to this group of patients.
Yes.
Shoulder, just
Hello?
conclude.
Can I ask
so I
question?
think,
Kajal, 1 minute.
Can I ask?
Yes, sir.
Sure. One question.
Sure. Yes. Arindam, UCD cannot be used with phosphodiesterase inhibitor.
Yes,
so what
that has
should be
to be.
first line drug? That is the ERA plus
Don't share the screen now. I will tell you.
Plus UCD.
Yes, sir. As you got the replace trial clearly shown, you need to stop. And one of the arm they continued with phosphodiesterase inhibitor, and the arm where the riociguat was evaluated, the phosphodiesterase has to be discontinued, because if they are used together, there can be potential risk of serious hypotension.
Right.
Exactly. A
So
very
it should not
serious hypotension does take place. So these two should not be used together.
Right.
Another thing, what Shodo asked, bosentan is very often used in combination with a phosphodiesterase 5 inhibitors in patients with Eisenmengers. If bosentan is not tolerated, ambrisentan, but you have rightly said that any drug which are used in primary idiopathic hypertension can be used in Eisenmenger syndrome as well.
Right.
I think we are running short of time. Thank you, Arindam. Thank you, Prakash and Shodo. The next session is current management strategies in the treatment of pulmonary embolism. To chair the session, we have Dr. Kajol Ganguly and Dr. Soumitra Ghosh. And to speak on this subject, we have Dr. Dipankar Ghosostira. Dipankar, please start sharing your screen.
And thank you, sir, for having me here. I hope I am audible and my slides are visible.
Yes.
I'm going to talk on current management strategies in the treatment of pulmonary embolism. Case of 41-year-old male with no significant past medical history and who suddenly presents with in the emergency with shortness of breath after a syncopal event. The only remarkable findings on clinical examination are he is hypotensive with a blood pressure around 84/49 and having tachycardia, and the oxygen saturation is around 92%. So these kind of findings and this kind of presentation, you have to think of pulmonary embolism. And it is extremely difficult to diagnose at times. Now, it's basically a clot in the venous circulation which has migrated to the lungs. Now, the most common thing to migrate are thrombus, but apart from it, it could be air, fat, amniotic fluid, or septic embolism or tumor embolism. One must not forget what we learned in our old school days in pathology, the virtuous triad, that circulatory stasis, endothelial injury, and the hypercoagulable state. They conglomerate to form thrombosis, most likely in the venous system, and that leads to formation of pulmonary embolism. So the risk factors are either major trauma, surgery, in which the lower limb fractures, they are paralyzed, the patient is bedridden, different types of cancer, estrogen-containing oral contraceptive pills, having blood transfusion or erythropoiesis stimulating agent, then the temporary pacemaker insertion lines, and finally thrombophilic disorders like factor V urine mutation, protein C deficiency, or protein S deficiency. And in current scenario, we must not forget COVID infection, which by and large is now the most common cause of pulmonary embolism in our clinics. Now, majority of the patients, they present with dyspnea, chest pain, or pre-syncopal-like symptoms. There is maybe signs of hemodynamic instability in the form of hypotension, shock, or there may be history of cardiac arrest also. 40% of the patients do not have any predisposing factors, and that makes this diagnosis extremely difficult. Hypoxemia is frequent, and hypocapnia may also be present. So there are certain scoring systems in which helps us to diagnose pulmonary embolism, and most of the scoring system, they include all the risk factors that I have discussed before. So the more the score, the more the probability of having PE.
Now, ECG, you may get a sinus tachycardia with RV strain pattern, and S1Q3, T3 is also a hallmark of pulmonary embolism. Echo findings are very important, and you get an enlarged right ventricle. In whatever view you see, there is an enlarged right ventricle, and the RV basal movement is compromised with scarring of the apex, which is known as the McConnell sign. And often you get a flattened septum on all features of RV volume overload. And a very important sign is the 60-60 sign, in which the pulmonary acceleration time is less than 60 milliseconds, which is suggestive of like in pulmonary hypertension. But the PA pressure never exceeds 60 millimeter of mercury. So the pulmonary artery pressures are elevated, that is more than 30, but less than 60. And the acceleration times are reduced, which is known as the 60-60 sign. You can even detect a mobile right atrial thrombus also. And the TASPE and the systolic tissue Doppler, the systolic excursion of the tricuspid valve, all are reduced in pulmonary embolism. The chest X-ray may show focal oligemia, suggestive of the Westermarck sign. There may be enlarged right descending pulmonary artery, which is known as the Palla sign, and Fleischner sign, which is the dilated main pulmonary artery. And very rarely you may also get a Hampton's hump, which is a peripheral wedge-shaped opacification lateral to the pleural surface, adjacent to the pleural surface, suggestive of some form of pulmonary infarction or a peripheral pulmonary embolism. Lower limb venous Doppler may reveal the thrombus, but this is again a rare finding. One important test one can do with less radiation is the VQ scan, and there is a defect in the perfusion with normal lung ventilation. So this is again suggestive of pulmonary embolism. But however, nowadays, most common investigation that is done is CT pulmonary angiography. You can straight away go for a CT pulmonary angiography, and it will demonstrate the thrombus in the major vessels or also in the subsegmental vessels. Gold standard always has been pulmonary angiography, but it is difficult to perform because cath labs are not always readily available, or the patient is too unstable to take it up on table. Now, one important point is that both CT pulmonary angiography as well as the pulmonary angiography, they come at a cost of high radiation exposure, which is sometimes maybe detrimental in pregnant patients or in young female patients. So a VQ scan offers the advantage that it can also detect pulmonary embolism with much less radiation. The other tests one can do are the D-dimer measurement. Now the age, limited D-dimer values are coming up. So as you age more than 50, you add 10 microgram to the levels, age into 10 microgram. So that is also there. Now, what has been seen to be most correlated with pulmonary embolism with high mortality is the features of RV dysfunction in the echo and a raised troponin. So these are certain scoring again to show that the pulmonary embolism severity index, or commonly known as the PACE score. Again, the higher the score, the higher the chance of mortality. Bottom line message is that we divide pulmonary embolism patients as low risk, intermediate risk, and high risk. The high risk patient will have hemodynamic instability, and they will have high PACE scores. They will have features of RV dysfunction, and they will have elevated cardiac troponin or the other markers levels. Now, so basically, the high risk patient, they have got massive pulmonary embolism. The thrombus is in the main vessel, so there is a huge thrombus burden. The intermediate ones are the submassive ones, and the mild ones are the minor or the non-massive ones. Now, treatment of massive pulmonary embolism is going for systemic thrombolytic therapy, and that's got a class 1 indication. And one must use unfractionated heparin as the anticoagulation, and then go with the thrombolytic agents. And surgical pulmonary embolectomy has also got a class 1 indication. Now, our job, which is the percutaneous catheter directed treatment, has got a class 2A indication, and I will be talking in detail about these procedures later on. Of course, one must make the patient hemodynamically stable by giving inotropic support in the form of NORAD or robutamine. And some patients might require ECMO, but the prognosis are extremely guarded. Now, the recommendations again, for the other types or the intermediate types of pulmonary embolism is that you go for low molecular weight heparin, that is anticoagulation preferentially by low molecular weight heparin, which is class 1 indication. Also, you can use fondaparinux, and you can also straight away start with the oral anticoagulation in the form of NOAC, which has also got a class 1 indication. Now, one must be careful that when you are using a vitamin K antagonist, as in cases of, say, prosthetic valve with pulmonary embolism, or the patient is receiving vitamin K antagonist for some other reason, then one needs to cover or do an overlapping parenteral anticoagulation when starting with vitamin K antagonist, as in any other case. Now, NOACs are not recommended in patients with severe renal impairment or during pregnancy and lactation, and in patients like who require a lot of high dose anticoagulation, like in APLA or valvular heart disease. In these kind of conditions, NOACs are contraindicated. Now, for submassive, of course, one can, if the low molecular weight heparins fail to improve the patient hemodynamically, then one may go for rescue thrombolytic therapy, which has got a class 1 indication. Now, as an alternative to rescue thrombolytic therapy, surgical embolectomy or catheter-directed treatment can also be taken up, which is got a 2A indication. Now, one does not recommend, and this I should be very clear about it, that one should not do thrombolysis in intermediate group or in mild pulmonary embolism. That's a class 3 indication. So the volume status should also be taken care of, and the inotropic supports, like I discussed before. Now, among the low molecular weight heparins, the most common agents that we use is enoxaparin, and it has got a twice daily dosage. Fondaparinux can also be used, and the dosage varies with the body weight. Among the thrombolytic agent, we commonly use streptokinase. The dosage is 2.5 lakh unit loading dose over 30 minutes, followed by 1 lakh unit over 24 hours. There can also be an accelerated regimen, like using the 1.5 million international units over 2 hours. One can also use the recombinant tissue plasminogen activator or urokinase. So these are the common thrombolytic agents that we use in pulmonary embolism. Regarding IVC filters, they have got a class 2A indication, particularly if we cannot use the thrombolytics or if we cannot anticoagulate the patient. Now, routine use of IVC filters is again not recommended. That's a class 3 indication. Now, so it's very clear how to manage the massive pulmonary embolism. They need hemodynamic support and they need thrombolysis. And it is also very clear how to go about the mild pulmonary embolism. You just use the anticoagulation. So the intermediate ones, they are the difficult ones to choose, how they behave, and the behavior changes also with time. So let us now look at the submassive group and let us see their behavior with thrombolysis. The results are that in long-term results, the results are better with thrombolysis, even in the submassive group, and they reduce mortality, as you can see in these charts. But the flip side is that if you use thrombolytics, even in submassive PE, they are all associated with major bleeds, and there are increased incidence of intracranial hemorrhages. So they tried half-dose lytic agents. Now, half-dose lytic agents had similar efficacy as with full-dose lytic agents, and that's wonderful. But the bleeding complications with half-dose lytics are at par with full-dose lytics. So the bottom line message is that half-dose lytics are not beneficial, and they are no more recommended for use in pulmonary embolism. So it's not safer. That's the clear answer. Half-dose lytics are not safer than full-dose lytics. So if you are to use thrombolytics for pulmonary embolism, you should be using a full-dose thrombolytics. Now, catheter-directed therapy. So there are 4 types of catheter-directed therapy. One is the standard catheter-directed thrombolysis, which we will take the catheter directly to the site of the thrombus, and we will give the thrombolytics locally. One is the ultrasound-assisted catheter-directed thrombolysis. The other is the pharmacomechanical catheter-directed thrombolysis, in which we mechanically disrupt the thrombus and then we inject the thrombolytic locally. And the other is suction, mechanical thrombectomy without using thrombolytics. So these are the 4 main catheter-based therapies in acute pulmonary embolism, which are nowadays used. Now, one is the direct catheter-directed thrombolysis. Now, it has to be a multi-hole catheter, and the infusion and the dosage rate are a lot less. So here you can see we are using only 20% of the systemic thrombolytic dose. So the chance of having bleeding or other complications which we fear with thrombolytics are much less if you are using the thrombolytics at the local site. So that was the common belief of using catheter-directed thrombolysis. But one must be careful that if you do not impinge your catheter inside the thrombus, the thrombolytic agents are likely to go to the perfusion segments of the lung without entering into the thrombus itself. So the message is that you should bury your catheter inside the thrombus and through the side holes, then you must inject the thrombolytics so they act in the thrombus itself. Now, thrombolytics has shown to decrease pulmonary artery pressure, and there is improvement in the RV-LV ratio, and the major complications are pretty less because we are using a low dose thrombolytics here. Now, the other technique that one uses here is ultrasound facilitated thrombolysis. Now, this is done with using a catheter which takes also an ultrasound wire inside. Now, as we give the ultrasound energy into the thrombus burden, it is seen that the fibrin, they dissipate. And once the fibrin dissipate, there are more receptor sites for action of the thrombolysis. So that was the theory behind the use of ultrasound facilitated thrombolysis. Now, Sunset P was the major trial that tried ultrasound guided thrombolysis using the ultrasound energy. But the results were not much encouraging. As you can see, the trial compared with standard local thrombolysis, catheter-directed thrombolysis, and the results are at par, both in terms of RV-LV ratio reduction. So, and ultrasound-directed therapy is very costly also. So, it does not offer much advantage over catheter-directed thrombolysis. Now, the other directions of using catheter-directed thrombolysis are the mechanical ones, and you finally develop new types of catheters. You develop new types of catheters, which are these kind of catheters are now available, and they have got multiple sites of injecting the thrombolytic agent through various different pores. This is a Bashir endovascular catheter device for pharmacomechanical thrombolysis. So it exposes a lot of surface area in the thrombus itself for the thrombolytic agents to act. So pharmacomechanical thrombolysis is you can use pulse spray or you can use infusion, but one must be careful. There is always chance of distal embolization with this kind of procedure. And there are case reports that initially there was just a saddle thrombus in the main pulmonary artery, which was non-occlusive. But trying these kind of procedures, the thrombus has migrated into one of the major pulmonary arteries either side and has caused a massive pulmonary embolism. So that risk is always there of thrombus migration. So the other options are the aspiration of the thrombus, which is called catheter thrombectomy, and you can aspirate this kind of thrombus. And of course, the larger the catheter size or the bore of the catheter, the more the aspirate it will be. So large bore aspiration catheter is now tried, and these are the different aspiration devices. The common ones are the flow retriever, and they show improved mortality. So there are two sizes here being used. One is the 16 size and one is the 24 size. It's no wonder that the 24 size is showing greater reduction in RV systolic pressure and improvement of the cardiac output. So the more the catheter size is there, the bore of the catheter, the better the results. So large bore aspiration catheter is a good procedure. And here is one trial which is looking at catheter-directed thrombolysis vis-a-vis large bore aspiration thrombectomy. And we got similar results in reduction of pulmonary artery pressure, reductions in the heart rate and hemorrhagic complications. But large bore aspiration thrombectomy has got higher procedure-related mortality, mainly from thrombus embolism. And catheter-directed thrombolysis on the other side has shown greater reduction in thrombus burden. So this is one very important trial which shows a slight edge of catheter-directed thrombolysis over large bore aspiration thrombectomy. And of course, if, for the surgeons, the surgical embolectomy, if available, that has got class 1 indication, and they are at par with catheter-directed thrombolysis in terms of mortality reduction, incidence of transfusion, but the length of stay in the hospital is higher with surgical procedures than with catheter-directed thrombolysis. So to sum up here, I've got a lot of trials and I have discussed most of the results of all these trials. Now, EPOS is the ultrasound guided versus catheter directed thrombolysis as in the Sunset trial. So these are the trials. Now, come up to anticoagulation. Now, if we got reversible factors, then only 3 months of anticoagulation is good enough. But in all other cases, full long-term anticoagulation, lifelong, is recommended. Now, one very important trial I should share here is that low-dose anticoagulant like apixaban, rivaroxaban are as good as using high-dose or full-dose rivaroxaban, apixaban. So now the treatment choice, what we are doing or we are suggesting is that for 3 months you give full-dose apixaban or rivaroxaban as the NOAC of choice, and then you, after 3 months is over, you switch to half-dose rivaroxaban or apixaban for long-term use. So this is the flow chart of how one should treat pulmonary thromboembolism nowadays. One should straight away go for a CT pulmonary angio and decide whether you got a submassive or massive thromboembolism vis-a-vis a mild thromboembolism, and then act accordingly. So I think I'll stop here, and I thank you again for your time and attention. Thank you, sir.
Thank you, Dr. Ghosh for your excellent talk. It was really an learning to everybody present over here. But in the current scenario, in this COVID context, so this pulmonary thromboembolism has taken the center stage almost in every situation. We are facing some problem in these patients who are dying of it. So what should be the strategy to deal with this kind of thromboembolism, pulmonary thromboembolism in this COVID scenario? What should be, because everything is a big challenge in this COVID perspective. So what should be your strategies to deal with it regarding management, prevention, and regarding this investigation also? So can you throw some light in this COVID pandemic situation?
The COVID pulmonary embolism, bottom line, is not much different from the pulmonary embolism case that we used to see before. So again, we are again getting these 3 patterns of pulmonary embolism in the COVID itself, because COVID is basically a vasculopathy. The important component of COVID is a vasculopathy, and there is a lot of thrombus burden in the COVID also. So we have come across cases of acute coronary syndrome with pulmonary embolism also in COVID. So the management will be just as I have already discussed in pulmonary embolism. That is, we need to differentiate whether we are having a case of submassive or massive pulmonary embolism or mild pulmonary embolism. Again, one has to decide, but most patients we are tackling with low molecular weight agents, and one must do everything to make the patient hemodynamically stable. So there are a lot of COVID patients who are now on ECMO support or who require ventilatory support. So basically the management remains same, like we discussed, and long-term NOACs are recommended for follow-up. The NOACs of choice are again rivaroxaban and apixaban, because these are the 2 NOACs with which there are a lot of trials in pulmonary thromboembolism.
Recommended.
Right, sir.
Okay. Thank you. Professor Ganguly, would you want to make any comment?
Thank you, Dr. Ghosh for a beautiful deliberation. So only thing is that the window of this that is thrombolytic therapy is much longer compared to AMI. That is the advantage.
Yes, sir, because here we have a collateral circulation going on. It is not an end artery, because there is a pulmonary circulation as well as a bronchial circulation. So to develop infarct, it takes a lot more time than in the myocardium. So the thrombolysis, rightly, you can do it even up to 14 days. So there are a lot of case reports of you can do thrombolysis at the 7th day or 8th day. So whenever you detect thromboembolism, plan for thrombolysis if there is a massive thromboembolism, massive pulmonary thromboembolism.
Number 2, we have got a special catheter nowadays for this catheter-directed thrombolysis in pulmonary embolism.
Right, sir. We have discussed all those things. There are lot new gadgets are coming out, but in our day-to-day practice in our hospital, the most common thing one can use is the pigtail catheter. If they can take it up to the main pulmonary artery and do some rotation with the pigtail, that can churn up the thrombus, and you can infuse the thrombolytic agents locally also.
Yes.
So that is cheap, and that can serve the purpose of this kind of very costly gadgets, which are also not readily available. And if aspiration catheters are not available, one may use guide cath, a large 7 French or 8 French guide cath. You can easily take it up into the pulmonary artery and aspirate as much as possible.
Right. The next point which I want to highlight is that we have touched most of the points which are essential for the diagnosis. But main thing is the suspicion. When a patient comes, as you have rightly pointed out in first case, suspicion is the first.
There is always confusion with acute coronary syndrome. The presentation is almost similar. Presentation is almost similar. The troponin may be elevated. People may be thinking that patient has got an RVMI, and we may miss altogether. We may miss pulmonary embolism if one fails to detect the subtle signs of pulmonary thromboembolism in the echo, like McConnell sign or the 60-60 sign. And then again, these are not always 100% present also.
Right. Those things come later on. But first thing, you must suspect pulmonary embolism in a susceptible individual who have got high risk for developing pulmonary embolism, like cancer patients, prolonged recumbency, all those points. So, and take immediate action in massive and submassive pulmonary embolism so that you can revive the patient.
One question is there in the chat box: what to do if the patient is too unstable to shift for CTPA and your suspicion is high?
Right, sir. That is why I stress so much on the echo. I stress so much on the echo. One must have his suspicion on echo itself. So the main confusion is whether you are dealing with RVMI or you are dealing with there is a pulmonary embolism, because both have got RV movement is RV movements are free wall movement is compromised in both the cases. So if there is, as sir said, there are predisposing factors and the high clinical index of suspicion, then you must start treatment with anticoagulation. And once you are sure with the diagnosis, then and then only you should try thrombolytics. And again, the window period is very large. So once you stabilize, you can always shift the patient next day to the for CT pulmonary. There's no hurry.
Thank you, Dipankar. Thank you very much.
Thank you, Dr. Ghosdosira, for this beautiful session. Now it is over to Dr. Professor Goel.
Time is over. So we should move to the next subject. Salvaging the failing heart, heart failure with improved ejection fraction, prognosis and management. To deal with this subject, we have Dr. Shubhra Banerjee, and to chair this session, we have Dr. B.P. Pandey and Dr. S. Ramakrishnan. Dr. Ramakrishnan, you are here?
Good afternoon, sir.
Good afternoon. Shubhra, please.
Okay. Thank you and good afternoon, everyone. It's my pleasure to be invited to give a talk on a new entity, which is heart failure with improved ejection fraction. And I'm going to specially talk about its prognosis and management. Are my slides visible?
Yeah, make it full screen, please.
Yeah, I've made it full screen.
Thank you. Thank you.
Okay, great. Okay, so as you know, in 2016, ESC guidelines classified heart failure into 3 groups depending upon the ejection fraction. And so these 3 groups are heart failure with the reduced ejection fraction, those with preserved ejection fraction, and those with mid-range ejection fraction, which is now renamed as mildly reduced ejection fraction. However, this year they introduced a new term, which is heart failure with improved ejection fraction. And the reason for this was, it was soon realized that those patients with heart failure with the reduced ejection fraction who with treatment improved their ejection fraction, maybe to as high as more than 50%, still they differed in characteristics from those with heart failure with preserved ejection fraction. So it's not just the ejection fraction, it could be something else as well. And to classify patients as heart failure with improved ejection fraction, there must be a previously documented ejection fraction, which is 40% or less. And now the ejection fraction must be more than 40%. And not only that, there has to be a jump of 10 point or more from the previous one. So in other words, if the ejection fraction was 37 and it has now improved to 44%, technically it is not heart failure with improved ejection fraction. Now, this is a new concept, and as you know that heart failure, well, this is why a separate class again, because heart failure with improved ejection fraction was found to have a more favorable clinical biomarker and functional characteristics compared to those with reduced and preserved ejection fraction, but less favorable compared to those in the normal population. In other words, those who never had heart failure. Then the improvement in ejection fraction could be partial, like 40 to 50%, or could be a complete normalization of ejection fraction more than 50%. Recovery usually happens due to guideline-directed medical therapy or device therapy, but sometimes may also happen spontaneously. But what is most interesting is a significant proportion of these patients with recovered ejection fraction may develop a recurrence of LV dysfunction or relapse, resulting in recurrence of heart failure events. Now, this heart failure with mid-range ejection fraction are heterogeneous. As you understand, they could represent those patients with a reduced ejection fraction where the ejection fraction has improved to that range, or it could equally be those patients with preserved ejection fraction whose ejection fraction has deteriorated. So to classify patients with heart failure with improved ejection fraction, the LV ejection fraction evolutionary trajectory is very important. Otherwise, we can't say whether it's improved or declined or it's just the same. The improvement usually represents a myocardial remission rather than a true cure of heart failure. And the term improved is used rather than recovered because A, it has been seen that despite normalization of LV ejection fraction, these patients may continue to have heart failure signs and abnormal biomarkers of functional impairment. And B, it's seen that the underlying structural cardiomyopathic process may not improve. And there are 10 to 40% of patients with heart failure with reduced ejection fraction may come to be heart failure with improved ejection fraction. However, there's still lack of consensus regarding the treatment. Now, this is what I have already discussed. So heart failure with the reduced ejection fraction may improve to full recovery, more than 50%, or partial recovery, 40 to 50, or there may be no significant recovery. However, even in those where it has recovered more than 40 to more than 50%, or between 40 to 50%, the clinical characteristics, they differ from that of heart failure with preserved or mid-range ejection fraction. Now, let's move on to the prognosis. The cardio CHOP registry has shown that those with reduced ejection fraction, those with improved ejection fraction have a survival which is better than that of reduced and preserved ejection fraction, and also they have less heart failure hospitalization. Moreover, those patients where the ejection fraction has improved to a greater degree have better survival than those whose ejection fraction is improved by a lesser amount. And this was also true for heart failure hospitalization. Now, the Penn heart failure study has shown that these patients with improved ejection fraction have an NT-proBNP value, which is on average less than that observed in patients with reduced and preserved ejection fraction. And the combined endpoint of death, transplant, or VAD replacement was significantly reduced in those with improved ejection fraction compared to the other two. And these findings have been confirmed by a post hoc analysis of the Valsartan heart failure trial. But what was most interesting is that this slide, this showed that patients with reduced ejection fraction who have actually improved the ejection fraction to the mid-range values, that is between 41 to 49%. And if you compare them with those patients who have been diagnosed as mid-range ejection fraction, but their ejection fraction has not improved, if you compare these two, then the survival is better, a lot better than those who have heart failure who are in heart failure with mid-range ejection fraction, but the ejection fraction has remained static. And this is to say, like, if you move forward, you're going to live, and if you are static, then you may die. This is just to add a bit of something to the story. Anyway, so what are the predictors of heart failure? What are the predictors of recovery in patients with heart failure with reduced ejection fraction? So these are could be divided as clinical parameters, biomarkers, imaging, and genetic factors. Clinical factors would include female sex, younger age, non-ischemic etiology, shorter duration of heart failure, lower heart failure NYHA functional class, fewer comorbidities, absence of left bundle branch block, and continuation of guideline-directed therapy for heart failure. So if these are present, there's a higher chance of recovery. Patients who have lower levels of natriuretic peptides, troponin, ST2, and galactose-3, they also have higher chances of recovery. Similarly, those patients who present with lower ejection fraction at the initial evaluation have higher chances of recovery. And if on CMRI there is absence of your late gadolinium enhancement, that also indicates higher chances of recovery. Coming to the genetic factors, presence of truncating mutations in the TTNA gene, and absence of activating mutations in the angiotensin converting enzymes or beta-1 adrenergic receptor genes, or absence of pathogenic mutations in some of these locations could also indicate higher likelihood of recovery. Now, it's been seen that 40% of patients with heart failure with improved ejection fraction experience a subsequent decline in ejection fraction. Now, why does a relapse happen? The exact biological explanation is still not known. However, the postulation is the reverse LV remodeling represents a transition to a new, less pathological steady state that allows the heart to maintain LV pump under normal conditions. The reverse remodeled heart, however, retains many of the molecular features of the failing heart and therefore is more prone to redevelop LV function in response to hemodynamic neurohormonal or environmental stress. And this article published way back in 2005 actually says that morphological or functional myocardial improvement may occur without widespread normalization of pathological transcriptional patterns. So the real reason may lie in the genes. Now, how to manage such patients with improved ejection fraction? I'll divide into 4 headings. First is whether to discontinue or reduce medical therapy. Secondly, what about CRT and ICDs when the end of life is approached, and whether we need to rechange them or not, reimplant them, and what should be the follow-up protocol. Now, TREAD heart failure is the only study which has looked into this, whether withdrawal or withdrawal of treatment or reduction of treatment would be is feasible in patients with asymptomatic DCM who have improved ejection fraction. And as you see, the results show that there is a significant increase in cardiovascular events in those patients where the treatment was discontinued. So heart failure treatment should continue indefinitely. Now, there may be some exceptions to this. For example, those who present with peripartum cardiomyopathy or fulminant myocarditis or Takotsubo cardiomyopathy, some of them may actually experience normalization of left ventricular ejection fraction. And so in such cases, reduction or withdrawal of therapy may be considered. Now, this shows that in patients with heart failure with improved ejection fraction, beta blockers, but not RAS or MRAs, were associated with a reduced all-cause mortality risk. This sounds very interesting. However, this is the only study, and I think we need to have more data to say that in heart failure with improved ejection fraction, beta blocker is the one that is most necessary. Now, what about CRT generator change? As a rule, CRT should be maintained because in fact, replaced because electrical dyssynchrony and forward LV remodeling are known to recur with loss of desynchronization. But the issue of ICD replacement is still uncertain. We know that improvement in ejection fraction is associated with lower arrhythmic events. However, some arrhythmic risk remains despite improvement of ejection fraction. And because fatal arrhythmias may occur despite normalization of ejection fraction, continuation of ICD has been recommended independent of EF in patients who have genetic mutations such as LMNA, SCN5A, and FLNC. But what about those who do not have genetic mutations or where we do not have genetic study, because it's not widely available? What to do with them? And that's a very practical question. Now, this publication in JAMA, it shows that patients who had an improvement in ejection fraction to more than 35% during follow-up had a similar mortality benefit with ICD as those whose ejection fraction remained less than 35%. So if you consider this, then possibly it's best to change the ICD as well. And when the ERI approaches. Now, the American College of Cardiology has given a statement regarding this, but it's a bit ambiguous. They said that if the ejection fraction has improved to more than 50%, then ICD replacement may still be appropriate, and that although continuation of CRD therapy in patients with prolonged QRS duration is appropriate, replacement of CRD with CRT may also be appropriate. So ultimately, I think it's up to the operator to decide what they are going to do. Now, this is just how to follow up patients who have heart failure with improved ejection fraction. They have to be followed up closely. Now, in all clinical follow-ups, we have to take the history, do a meticulous clinical examination and an ECG and NT-proBNP, and then maybe at times an echocardiography, and maybe even less often a CMR if it's available, to look at the function of the heart and some more sophisticated parameters like your longitudinal global shortening. But the patients who are not at high risk, for example, those without persistent left bundle branch block, genetic DCM or high biomarker profiles or more comorbidities, they may be selected. They may be called for review for after a longer period of follow-up. So that is something the clinician would decide when to call the patient. So in summary, knowledge of LVF trajectory is necessary to diagnose heart failure with improved ejection fraction. Recovery usually happens due to guideline-mediated therapy or device therapy, but in some cases may happen spontaneously. There are clinical biomarkers, imaging, and genetic factors which predict recovery. Patients with improved ejection fraction have a more favorable outcome compared to those with reduced and preserved ejection fraction, but less favorable to those who never had any heart failure. And despite a complete normalization of ejection fraction, a significant proportion may develop recurrence valve dysfunction. Heart failure treatment in these patients should be continued indefinitely, and a close follow-up of such patients mandatory. Thank you very much.
Thank you, Dr. Surya Banerjee. It was a fantastic lecture. I think we've covered almost all the aspects of improved ejection fraction, which is, I think, we are all seeing quite a number of patients. So my question is, when would you consider, at what point of time you will consider discontinuation or reduction of therapy? Or will you consider partial reduction of therapy, like maybe avoid aldactone antagonist first, move on then in stepwise fashion?
Yeah. I think the only study which we had, it didn't look at partial discontinuation. And I think every case have to be judged on its merit. If I have one of those patients, say, for example, who had a Takotsubo syndrome and have recovered, maybe in such patients, I may gradually think about withdrawing the therapy, maybe by step-by-step approach, and observe them very closely. should they show any signs of deterioration, like increase in NT-proBNP or any of the more sensitive imaging markers, then I may again put them back on therapy. Apart from that, I think it may not be prudent, especially if the chances that the patient may be lost to follow-up, may be best to actually continue them on medical treatment.
Yeah, Shubhra, I have one query.
Yeah.
Whether this is a 10-point improvement or it is a 10% improvement in ejection fraction?
That's a 10% actually. 10 point is 10%.
Okay. And second query is, suppose in your clinical practice, you get an ejection fraction of 44%. How often it is going to be heart failure with mildly reduced EF, and whether this is a heart failure with improved EF, or both are the same?
I think this is a difficult question. I mean, unless we follow the trajectory, the evolutionary trajectory, we are unable to say whether it's an improved fraction, improved ejection fraction, or a mid-range ejection fraction. So once I find a patient who is in mid-range ejection fraction, and I do not have any documentation of his previous ejection fraction status, then it's vitally important that such patients are followed up closely with repeat echocardiographical parameters to see whether it's actually improving or static or they're actually getting worse. But in any case, I'm not going to stop the medication.
So one question. One query, because you said it is 10% increase in the ejection fraction. Suppose the ejection fraction was, say, 30%. 10% of 30% is 3%. So at 33%, should we say that?
No, it's not 10%. It's actually, we said 10 points because 1 point.
That was the confusion, actually. That's why I wanted to clarify. You please explain this part.
Yeah. So by 10 point, it means actually, see, the percentage is used, the term is used in different sense. When it's 10% increase, it's an absolute 10% increase from the previous echocardiographic ejection fraction. It doesn't mean that a 10% increase, it's not like 10% of 33. No, it's a 10 point. That's why if you look at the definition, they've actually used 10 point. And they have clarified. They have clarified also what they mean by 10 points.
Exactly.
And one question in the chat box that has come is what is the difference between spontaneously recovered patients and patients who have improved drug treatment? Is there a difference?
I think spontaneously recovered ejection fraction happens in a few cases perhaps. And these are the patients probably who are more likely not only to improve, but also perhaps to retain their ejection fraction at that level. So, but again, we have to be a bit cautious about it. So ideally, these are the patients probably where we can stop the treatment, medical treatment. But again, I think we still do not have that much data to say that it is safe to do so. If we are reducing our treatment and what is, which is often necessary from practical point of view, patients are on numerous treatment, and very expensive treatment. So we are tempted to reduce the treatment. If we really do so, then it's vitally important that these patients are followed up closely.
Yeah, and in a TREAD heart failure registry, 16% patients did not have recurrence of low ejection fraction even after stopping the treatment. So it's really a clinical adjudication where to stop, where to reinitiate. And we have seen in our experience that in majority of the patient, it does recur. That means EF does goes down if you stop at least the RAS blockade and beta blockade. I don't know about MRAs and SGLT2 inhibitors, but definitely in majority of the cases, it does recur. We'll close the session.
Yeah, sure. So 25% to 35% is not fulfilling your criteria. That is very interesting to note. So even 25 to 39%, 14% ejection fraction is not fulfilling. And Dr. Pandey, this is a very strict compartmental definition. So by 144% value, you can never say it is an improved. Improved has got in its definition the whole trajectory of the as Dr. Shubhra said, the trajectory. So without the trajectory, you can't attach a terminology of improved ejection fraction. So you have to settle for the term of mid-range or mildly reduced. You can't say improved unless you have got the whole trajectory in front of you.
Absolutely.
I think there is a little bit of a confusion growing up. One of the chairpersons, please give the concluding remarks.
I think the whole discussion about discontinuation is only when there is a complete recovery. And there's a partial recovery. I think there is the point of discontinuation is not there. Leave alone the numbers, leave alone the definition.
Exactly.
That is the most important thing.
Exactly. Absolutely. So thank you very much. Shobra, a wonderful talk, and it evoked a lot of debates as well. Good. Good from the academic point of view. Now I hand over to Soumitra.
Yeah, thank you, Dr. Guho. Actually, we have designed the program in such a fashion that now we have discussed to improve the ejection fraction by 10% or more. But how to do that? So there is a debate whether we can go for a sequential adding medicine after medicine and giving a gap of 4 to 6 weeks in between to see whether they are still effective or need something more, or we should go together and hit it on the Billi ko mardo shadi ka raat mein aise, so kill the cat on the marriage night. So whether you attack with whatever you have got on the day one and see what happens. So with this fantastic idea now brewing up across the Atlantic, including India, we invite our chairpersons, Dr. Ranjan Sharma and Dr. Shunib Banerjee, to invite the speakers, and we'll keep the discussion at the end of 12 and 12:24 minutes. There won't be any rebuttal. Whatever you have to say, you speak your heart out, Bapaditto and Shumanto, and then we'll discuss for 6 minutes. So Ranjan Sharma and Shunib Banerjee, please.
Yes, good afternoon, everybody. It's a wonderful program that is being designed. And now we are deviating from treatment of heart failure from the guidelines, and some are just which approach is better. Let us understand from the two learned speakers. Dr. Bapaditya Kumar will talk on existing step care approach to be followed as it is described in the guidelines. Dr. Kumar, please.
Are my slides visible?
Yeah.
Yes. They are visible. Just go to full screen.
Yeah, I have gone to full screen.
Go ahead.
Go ahead. Good afternoon, respected seniors and my dear friends, and my mentor and Professor Santanu Guho sir for the opportunity. So over the next few minutes, I will be speaking on my part of the debate, the management of heart failure and reduced ejection fraction, whether we are going to follow the existing step care approach as mentioned in the guidelines. So basically, let me clarify what the debate is all about. So where we will be adding a AC inhibitor and a beta blocker at the onset, titrate the doses, then add a mineralocorticoid receptor antagonist, titrate the doses. If the patient is still symptomatic, you replace a ARNI for the AC inhibitors or ARB, and the newest entry in our heart failure armamentarium, the SGLT2 inhibitors. Whereas the recent proposed new sequencing by McMurray and the Milton Becker is that you add a beta blocker and a SGLT2 inhibitor at the initiation. Within 1 to 2 weeks, you add a ARNI, and within 1 to 2 weeks, you add a MRA. So basically, you are adding all the 4 drugs within 4 weeks and then up titrate. My talk will be basically based on the 2 guidelines, the ESC 2016 guideline and the recently published 2021 ACC-AHA consensus decision pathway. Basically, we have been following this guideline over the last few years till up to say 2019. We have been following this ESC guideline. Patients with HFrEF comes to us. We add a AC inhibitor and a beta blocker. We can give either of the 2 at the first onset and add the other within 1 or 2 days. Then we up titrate the doses. The patient is still symptomatic and EF is less than 35%. You add a MR antagonist, up titrate the dose. The patient is still symptomatic. You can substitute ARNI for AC inhibitor ARB for heart rate more than 70 on a maximum tolerated doses of beta blocker. You add efavirenz, and in patients who are still symptomatic, QRS duration more than 130, you can evaluate for the need of CRT. Meanwhile, during all this time, you give diuretics to relieve symptoms and signs of congestion. But some things changed in the year 2019 and 20 that has led to our discussion. The publication of the 3 trials, the Pioneer HF trial, which ushered in a new era for the increased use of the harness, and the DAPA HF and the Emperor Reduced trial. Now, coming to the Pioneer HF trial, it showed that even just after admission of a patient with acute decompensated heart failure, after the patient is stabilized within hospital, within 24 to 48 hours, you can start with a ARNI. It has shown that after 8 weeks with treatment of the ARNI, there was further reduction of NT-proBNP levels, and at 12 weeks, the patients who received ARNI within the hospital had a lower risk of death and dehospitalization. This Pioneer HF study ushered in a new era for the use of ARNIs, and it is the study that has led to the approach of direct to ARNI treatment. Coming to the DAPA HF and the Emperor Reduced trial, Milton Packer was the primary investigator of the Emperor Reduced, and J.J. McMurray was the primary investigator of DAPA HF. I have taken these names because these names will again crop up in an important paper. This trial showed that the SGLT2 inhibitors, empagliflozin and dapagliflozin, given in patients with heart failure and reduced ejection fraction in class NYHA class 2 to class 4, when given on the top of the established treatment of RAS inhibitors, the beta blockers and the MRS, improved fairly better on these SGLT2 decreased heart failure hospitalization and cardiovascular death irrespective of the diabetic status. As a result of which, we have some new opportunities regarding the use of the ARNIs and the SGLT2 inhibitors, but there are some challenges. Where do we put the ARNIs and the SGLT2 inhibitors now? What about the older heart failure therapies like digoxin and vasodilators? And when do we refer for ICD or CRT, or when do we do a ICD or CRT? This is the paper I was talking about. Milton Packer and J. McMurray published in the European Heart Failure Journal, the interesting paper regarding the evidence-based sequencing of the foundational drugs of heart failure. Here they proposed to initiate the beta blocker and the SGLT2 inhibitor at the first onset of treatment, then to add a ARNI, and then to add a MRA. But evidences are very limited for this proposed new sequencing, and if this proposed new sequencing gains momentum, this paper is going to be a landmark paper for the management of heart failure and reduced ejection fraction. Now, coming to my portion of the topic, why we are really undergoing our major improvement is that there is a lot of therapeutic inertia while we are giving optimal medical management. In the CHAMP registry, it was seen that even after 12 months, there was only a minuscule amount of patients received optimal doses of the drugs. So there is a significant scope of improvement in optimizing GDMT. In a resource poor setting of India, where most of the patients are not able to take the SGLT2 inhibitors and the ARNIs, we have to rely on the guideline-directed medical management for further improving compliance so that we can improve the GDMT in most of our HFrEF patients. In Indian population, it was seen that patients who did not receive GDMT had almost a 53% increase in mortality than those patients who received GDMT. For our GDMT, we have trial evidence of more than 30,000 patient years. We have evidences for the Paradigm HF trial, from the CHARM trials, from the SOLVE trials, Concentrus trials, and lots of trials. We do not need to speak each and every trial, but there is a data from 30,000 patient years regarding the optimal medical management for HFrEF patients. Still, there is a significant mortality of the HFrEF patients, and 5-year survival is only 50%. Although AC inhibitors and NRB reduce mortality by 16 to 17%, beta blockers by 34%, MRS by 30%, but we are definitely missing something. So are we need to add more drugs? Are we needing to apply drugs in another fashion, or there is something we are missing? In fact, we are missing compliance of the patients. There are lots of drugs we are using for management of HFrEF. There is in fact a drug cocktail which increases the risk of medication errors, poor adherence to pharmacological therapies, inappropriate drug prescription, adverse effects, drug-drug and drug-disease interactions, and most importantly, underuse of the effective treatment. So in Indian population, it is more prudent to stick to the established protocol of treatment rather than go to an unestablished protocol where there may be chances of drug interactions and underuse of effective treatment.
In India, it is a healthcare resource poor setting that is increased morbidity and mortality of our most heart failure patients, and quality of life is compromised. So with overwhelming heart failure and reduced ejection fraction therapies, there is a need to inform the clinicians about where evidence may be new and where there is more data is required. Numerous care gaps exist, and highlighting the need for more streamlined and efficient process implement the best practices for HEP patients. ACC-AHA guideline, if you go by this guideline, they recommend to either initiate a RAS inhibitor or a beta blocker. In some cases, both the therapies can be started at the same time, and this should be uptitrated every 2 weeks fashion to help HEP patients with optimal GDMT. This is the newest protocol they have set, the ACC-AHA 2021 guideline. This is more easy to use because they have advocated to use either of the 3 RAS inhibitors, but they had put forward a direct to RNA approach. I will come in my later slides. Along with this, they have advised to use evidence-based beta blockers. To uptitrate the doses for patients who are still symptomatic, that is NYHA class 2 to class 4, with the EGFR more than 30 and potassium less than 5, you add a aldosterone antagonist. For patients meeting the EGFR criteria with NYHA class 2 to class 4, add a SGLT2 inhibitor. For relieving congestion, you add diuretics. For persistently symptomatic patients, on all these 4 classes of drugs, you add hydrolazine isotonic dinitrate combination, and ivermectin I have already mentioned for those with heart rate more than 70. This treatment algorithm is more feasible and more easy to use. Also, I would like to stress here is that they have applied the approach of direct to RNA because we have already known from the paradigm HF trial, RNA results in 20% reduction in the primary outcome of cardiovascular death and heart failure hospitalization compared to enalapril. In the PROVE HF trial, it was shown that RNA resulted in a better reduction of NT-proBNP and caused reverse remodeling effects after 12 months of therapy compared with enalapril. Evaluate HF trial echoed similar findings of the PROVE HF trial, and there are improvement in the echocardiographic parameters. HF already initiation of RNA during and ADHF episodes resulted in superior outcomes compared to enalapril. All this together led to a de novo use of RNA in our heart failure patients, and this is the result of which a direct to an RNA approach was applied in the ACC-AHA 2021 guidelines. But we must remember, though RNA beta blocker and mineralocorticoid receptor antagonist results in a mortality reduction of almost 63%, keeping in mind our Indian scenario where it is very much difficult for the patients to get empagliflozin and a circuitry valsartan together because of financial constraints, we can at least put the patients on a AC inhibitor, beta blocker, and mineralocorticoid receptor antagonist, because these 3 drugs also cause a reduction in mortality by 56% in the HEP patients. Now, coming to what are the approaches of SGLT2 inhibitors. The SGLT2 inhibitors put on the triple drug regimen, that is the RAS inhibitor and the mineralocorticoid receptor antagonist, extends overall survival compared to conventional therapy. As a result of which, the SGLT2 inhibitors are recommended in patients of HFrEF who are already receiving these RAS inhibitors, beta blockers, and aldosterone antagonists. Remember that the 2 trials, the reduced trial as well as the DAPA-HF trial, used SGLT2 inhibitors on top of this guideline-directed medical management. They did not use SGLT2 inhibitors in de novo HFrEF patients. This is the most important thing that is to be kept in mind, because if we follow the new sequencing management, here we are using SGLT in de novo HFrEF patients. So I have already discussed this. Now coming to the explanations, forth by the rapid sequencing group, they tell that the traditional sequence does not necessarily conform to the known relative efficacies of the available drugs. But our counter argument is that GDMT has evidence from studies more than 20,000 patient years. The new sequence proposed does not have any RCT evidence for benefit. It is backed only by expert opinion extrapolated from other related studies. Also, after the introduction of the direct to RNA approach and the SGLT2 inhibitors in GDMT, there has been further evidence-based improvement in outcome of the HFrEF patients. Another argument is that even low doses of the drugs afford significant benefits, whereas the escalation of dosage adds only marginally to the efficacies, whereas initiating multimodal treatment, even in low dose, may exert greater beneficial effect. Our counter argument is that in GDMT, multimodal treatment is used in a more scientific way backed by evidence. There are affordability issues with ARNI and SGLT2 inhibitors in the Indian population. At least a patient can receive a ACE inhibitor, ARB, a beta blocker, or a mineralocorticoid receptor antagonist. In the Indian population, where compliance is a major issue, instead of jumping to a new unestablished protocol, it is more prudent to follow the standard GDMT with an emphasis to improve compliance. And another opinion is that SGLT2 inhibitors may have a better safety and tolerability profile if we follow the new approach, because they can reduce the renal dysfunction associated with the RAS inhibitors, or they can mitigate the risk of early worsening heart with the beta blockers. But our counter argument is that without following a standard protocol, there is increased risk of adverse effects, metabolic abnormalities, renal dysfunction, and drug-drug interactions, and cost issues. Moreover, the two trials, DAPA-HF and the EMPEROR-Reduce, studied these SGLT2 inhibitors in patients who are on GDMT for FREF. This is the Canadian guideline. What they have proposed, I like this guideline because they have not discussed whether we are going to initiate beta blocker or SGLT2 inhibitor at the onset. Rather, they have put forward that we can initiate with all the 4 drugs. We can either choose a ACE inhibitor, ARB, or ARNI. We can add a beta blocker. We can add a MRA and a SGLT2 inhibitor. Then assess the patients and ultimately uptitrate the doses at 2 weeks interval. That is studying the safety, tolerability, and efficacy of rapid optimization of the heart failure therapies. The results will be published in the late 2021. Till then, we have to wait for other evidences. So I have told my part, and I will be waiting eagerly to hear my dear friend and colleague, Dr. Sumanta Chatterjee, to his part on rapid evidence-based evidence-based treatment of the 4 foundational therapies. Thank you.
Thank you, Dr. Panchita Kumar. It was a wonderful speech, and you registered a new trend that is going to happen in the next. And many of us are believing that we will be moving towards what Sumanta Chatterjee will be taking. Let us see how he presents his case. Sumanta, please.
Yeah. Thank you, sir. Let me share my screen first. Dr. Bappa, please stop sharing screen, otherwise I cannot start my sharing. Yeah. Thank you. A very good afternoon. Thank you, everybody, for giving me the opportunity here. So today is a debate, and the topic is for management of HEPREF, existing state care approach to be followed as in guidelines, as spoken by Dr. Padita Kumar. And my topic is no. It should be replaced by a new algorithm for sequencing drug treatment. Actually, the thing is that the debate is not about the 4 molecules or the foundational 4 molecules. Everybody know that ARNI, SGLT2 inhibitors, beta blockers, and MRA. These 4 molecules are the pillar of the drug treatment of heart failure. And we know that heart failure is a devastating and worsening disorder. It is worse than cancer even. It should be treated in all multiple prongs from multiple corners. We know that around 70% of the cases of HEPREF is due to GAD. Type 2 diabetes mellitus is associated with 50% of cases of HEPREF. 20% mortality rate after hospital discharge within 3 months. 33% mortality rate within 1 year. In spite of knowing all these things, the utilization of GDMT is around 20 to 25%. And if you use GDMT in full scale, we can reduce 3 months mortality by about 72%. So this is a bleak slide, to say the least, but it is representing that how severe is the disease. Whatever arsenal, whatever evidences, data, and treatment protocol we are having, from the very day one, we should utilize all these things. It is not the evidence, it is our experience. Whenever we are preparing a soup, maybe 4 ingredients are needed to prepare a soup. Number 1 is salt, sugar, some pepper, or cheese, or something like that, or milk, something like that. It is not that we are using salt first, then adding up again salt, and then try to add sweet, and then try to add pepper. Then there is no point in tasting the soup. We are adding all the 4 ingredients simultaneously and upscaling it. At every minute or every 5 minutes, we are tasting it whether the composition is right, and then adding another pepper or adding sweet or decreasing the amount of salt. This is the kind of thing where we are preparing the soup. This is the scenario. So why not here? Because the GDMT are saying that, guidelines are to guide. They are saying that definitely these are the fantastic 4 molecules. We have to add that thing, but we are starting with maybe beta blocker, then upscaling it. We are seeing that there is no competition. Then after some time, after few months, we are adding another molecule. But in our experience, if there is no complication and if the patient is not symptomatic, if the patient is symptomatic, then we are gearing up the next stage. But in our experience, what we do, we initiate beta blocker in very low dose. If the patient can tolerate, we see hardly for 10 days of 1 week or 10 days, and then adding up our next arsenal, maybe S inhibitor or ARP or RP, then MRA or SGLT3 inhibitor. So whatever the sequence is. So the debate is what the sequence will be, especially in Indian population. What is the sequence? Beta blocker first, then RP, then MRA, then SGLT3 inhibitors, or the reverse? The debate may be regarding this. There is no debate that all the 4 molecules should be very first upscaled or very first introduced and then modify the dosing. So we all know this. This is a position statement. There's one slide presented in ESC 2021. All the 4 molecules are enjoying class 1 indications. We know that beta blockers from CVS to Merit-HF, Copernicus, all the trials are saying that it is having 30 to 35% all risk, all cause mortality and CV death reduction, heart failure hospitality reduction in the tune of 30 to 35%. MRA. Next line is MRA because it has the capacity to reduce it by 25 to 30% and HHF by 35 to 40%. This is the highest range. RNI 20% to 20 to 25%. SGLT2 inhibitors from Emperor reduce and DAPA-HF is in the tune of 30%, both in the cause of all-cause mortality of CV death or heart failure hospitalization. So all the 4 molecules in the tune of 20 to 40%, there we are enjoying the death benefit. So this is foundational paper for which this debate has given the table by Milton Parker and J.J. McMurray. So Dr. Kumar has already, this slide has already been presented by Dr. Kumar. This is the conventional sequencing SE inhibitor, ARB or direct RNI, then beta blocker. If we see that there is no symptomatic deterioration or there is no side effect, after some time, if the patient is symptomatic at all, then MRA, then SGLT2 inhibitors. Up titration to target dose at each step typically requires 6 months or more. And we know within 3 months, there is around 20% death. Rapid sequencing, step 1, beta blocker and SGLT2 inhibitors. Step 2, ARNI. Step 3, mineralocorticoid receptor antagonist. So here lies the debate. What will be the sequence of introducing newer molecules? So this slide was taken from J.J. McMurray statement. Compelling proof of robust risk reduction with HHF and death, BB, beta blocker, all the 4 molecules. Each foundation therapy is effective independently of others, acts through distinct pathophysiological mechanism. Clinical benefits occur rapidly and maintained. More benefit, introducing additional foundational drug has more benefit than treating existing drug. Early initiation of all the 4 molecules in 4 weeks facilitates early risk reduction, improve safety profile of others. One molecule may improve safety profile of others, like SGLT2 inhibitors may improve safety profile of MRA by reducing its hyperkalemia or by reducing the chance of dropping out. This is a step 1. Beta blocker, it is the foundational drug, most effective and rapidly acting drug to prevent sudden cardiac death by left ventricular remodeling in long-term management. If the patient is dry, this should be the first agent. Next is SGLT2 inhibitors from Emperor reduce, then DAPA-HF lots of data are coming that this should be included in the step 1 because it is non-hemodynamic drug. There is no up titration of dosing. Side effect profile is less. It may reduce the dropping out chance of MRA by reducing its hospital admission or by reducing its hyperkalemia. And it is renal safe and renal beneficiary. We know that more than 20 or 30% patients of heart failure ultimately live in cardiorenal syndrome or chronic renal failure. In that front also, SGLT2 inhibitors can act. Hardly, if the patient is not dry, that is, patient is wet, then this can be your first molecule. Early osmotic diuresis, rapid reduction in risk of heart failure worsening, kidney protection. Initiated at therapeutic dose without requiring dose titration. So whether the patient is having all-cause mortality, cardiovascular death, they are faring. If either the patient is having ARNI or not receiving ARNI, Emperor Reviews showed that consistent reduction in risk of severe death and heart failure, regardless of ARNI use. And benefit starts from day 12 and sustained throughout. This is also very much important. Patient is having ACVD or not, in any spectrum, it acts. Like heart failure, atherosclerotic disease, CAD heart failure, heart valve disease, patient is having atrial fibrillation, chronic kidney disease, in all the spectrum it acts. That's why it is included in step 1. Step 2 is ARNI. We know that it is a very important molecule. This one slide, there is Pioneer HF, starting of ARNI in acute decompensated patient after stabilization in hospital. Transition means transition from ICU to general ward or during discharge. Then Paradigm HF, and then Prime HF, Prove HF, Evaluate HF in atrial fibrillation patient, mitral valve regurgitation patient to reduce improve the ejection fraction, and the LV parameters will improve. Atrial fibrillation may improve in cases of ARNI that we already know in direct to ARNI approach given by Dr. Papaditya Kumar. So this is the ARR and NNT 19, 21, and 22. Empagliflozin and ARNI. This is the statistics we can quote. And lastly, MRA is a very important molecule. Significant reduction in mortality, morbidity. Background use of SGLT2 inhibitors and ARNI may lower the risk of worsening kidney disease and hyperkalemia. The reason we exactly do not know. From ARNI, from FSS and RAILS trial, we already know these things. Empagliflozin use or SGLT2 inhibitor use may be associated with 22% lower risk of discontinuing MRA therapy in patients with HFrEF. It's a very much important thing. One molecule is reducing the chance of dropping out of other molecules. So, if the 4 molecules are added up simultaneously or in rapid sequence, this will benefit the patient. They may benefit the patient. So this is CCS, Canadian Heart Failure Society Guideline 2021. Initiate all the 4 molecules standard therapy as soon as possible and titrate every 2 to 4 weeks to target or maximally tolerated dose over 3 to 6 months. So contradictory to your guideline recommendation of 16 or 19, we are having this statement that all the 4 molecules will be there in your system by 3 months in maybe in standard dosage. At least we should try, because it is like a cancer and it is a devastating disorder. We should try all our strength to act maybe simultaneously or within rapid weeks. So this is another NFS with optimizing therapy with need for speed. This is a new term, that is comprehensive disease modifying medical therapy, CDMMT. Here the change we know here: CV death, heart failure hospitalization death, CV death or hospital hospitalization death, or emergency urgent visit for worsening heart failure. The change is minus 40% to minus 60%. So another 2 slides here. So this slide, this is 2021 heart failure ESC, HFA ESC slide. That is 9. How can we sequence the foundational 4 molecules? We can categorize the heart failure patients in 9 categories. Low BP, high heart rate, low BP, low heart rate, normal blood pressure, low heart rate, normal blood pressure, high heart rate, AFib normal blood pressure, AFib low blood pressure, CKD or hyperkalemia, pre-discharge, and patient is having hypertension despite GDMT. So they have categorized the 9 strategies of heart failure by which you can strategize that these patients should get beta blocker first, these patients should get ARNI first, or these patients should get SGLT2 inhibitors first. But nobody is denying that all the 4 molecules should be used in rapid succession, if not simultaneously, so that heart failure patients can be given some extra years. So this is my last slide, that if we use all the 4 molecules at the age of 55, you can add 6 years in his lifetime. 65, you can add 4 years. And at the age of 80, we can add 1.5 years to his lifetime. So we know that heart failure develops in our country maybe 1 decade earlier, maybe in the 50s or in the 60s. So we can add around 4 to 5 years productive life. You can we can add these 4 foundational molecules in rapid succession, if not simultaneously. Cost, if we can afford CRT, definitely we can afford it. Compliance, I don't know. In pandemic situation, if I go by road, we doubt that what is the compliance in our population, basically. In respect to mass only, that we I don't know. I doubt it. Thank you. Thank you.
Thank you, Sumanta. So you have proposed a new thing, and new proposals are always, there are many inhibitions and many resistance that you have to face. And the new things may not be always good. We hope that it should be good, but it may not be good. So let us hope that in future we can have some outcome trials that is in a better way. But let us hear from Pandito what is his comments about his proposition.
Sir, basically my approach is that you add all the drugs, but follow the guidelines, because it will reduce the complications, it will improve the compliance, it will reduce the hypotensive side effects, and all this will help us because the protocol is already established for last 10 years. So just the new drug SGLT2 inhibitors has already received a class 1 recommendation from the ACC/AHA. So there is no harm in adding the SGLT2 inhibitors after we have already started these 3 drugs. So my approach is add all the drugs, but take time to add all the 4 drugs.
Shunip is there?
Yeah. Shunip, you give your comments, please.
We are waiting to hear your comments.
Thanks. I think they have all said the right thing, but for practical purpose, what I do and everybody should do, reconfirmation of your diagnosis of FRM, and I will request everyone to do the echo, see the echo Doppler at least yourself, that you don't miss any reversible, correctable thing. And remember one thing, this new hue and cry on SGLT2 and ARNI is on the top of beta blocker and AC inhibitor and MRF therapy. So you need to discuss what the patient wants also. How much he can go, how much he can afford. That's more important. And I have seen a different perspective also, that patient with a creatinine of just 1.5, the nephrologist have stopped AC inhibitor or SG ARNI. This is not the case should be done. They should be continued even with mild rise of creatinine. And hypovolemia is a real issue, and everybody has to be careful not to give unnecessary nitrate diuretic. And both Papatu and Shumandra, you were right, and actually what you said, you didn't debate, you actually agreed with each other, and that is the approach. Thank you.
Thank you, sir. Thank you.
Thank you. I think that we are going behind time. So thank you, Bappa and Shumanta. Thank you very much. The chairpersons, Ranjan and Shunip. So let us move to the next subject. Soumitra perhaps loves playing with the words and has a knack for dancing as well, because next session he has termed dancing with the rhythm, and he being the first speaker. May I invite the chairpersons, Dr. Dilip Kumar and Zabir, you are here by any chance?
Zabir is here.
I'm here, sir. Good evening.
Good evening. Please take over the session and Soumitra will speak on subclinical AF evaluation and management. Over to you.
Thank you. Thank you, sir. So this is something new which we are coming across nowadays with the ever-increasing use of the cardiac devices, the implantable cardiac devices and the wearable cardiac devices. We are quite clear about the clinical AF, its problems, the management, and anticoagulation treatment to prevent stroke. Are all these things in clinical AF? Can we apply it into subclinical AF? We do not know, because the subclinical AF of various variable duration that is detected by the asymptomatic episodes of atrial fibrillation, and it's detected by the wearable devices. Is it only an accidental thing? What is its clinical relevance? How do we manage it? Is the stroke rate similar to that of clinical atrial fibrillation? What is the progression to clinical atrial fibrillation? So there are a lot of questions which requires answers. Some are guided by certain data in the form of meta-analysis, as well as data we derived from the randomized controlled trials, and a lot of data which is expected to come in the future from the ongoing clinical trials like RTPI and other trials with apixaban. So we have to discuss this extremely important topic. We have none other than Professor Dr. Soumitra Ray, who I don't think any introduction is required. Wonderful speaker, great academician, and a person who is so known across India in the cardiology circle. Dr. Soumitra, please.
Thank you, Javid, for your sweet words. Thank you, Professor Guho, and all my colleagues and other chairperson. It's very unnerving to talk anything about rhythm when Dr. Narasinghan is already logged in. So please excuse me if I fumble. And another request to the back office that don't give that sheep-like siren when I end. It is very disturbing and unnerving. Just say that, Doctor, your time is over. That will be much more practical way. So my talk will be based on 2020 ESC guideline on the atrial fibrillation. And while preparing this talk, I rediscovered the definition of subclinical aortic atrial fibrillation. I had some different idea about it, but I have changed my idea. What is it? It is actually defined as episode of AF or atrial tachycardia with duration of 5 minutes to 24 hours detected in patients without clinical history or symptoms of AF. That is for screening. And if you see on the right, if it is device detected, then what is the definition? Then AHRE more than 6 minutes but less than 24 hours with lack of symptom in patient with an implantable device detected with continuous ECG monitoring, which is intracardiac, but without prior diagnosis by ECG or Holter. So it's a very watertight definition and sometimes very gray area of definition. Now, no symptom attributable to AF and not previously diagnosed with clinical AF, you detect it by the implantable device. Now, what to do? You do an ECG. If the ECG shows AF, it's a clinical AF. But if ECG does not show AF, then it is subclinical AF. So it's a very handful of patients who are not looked upon even 10 years ago, but over the last 10 years, you can see there is explosion of trials on these. And there are explosion of devices. Some are medically directed, some are commercially directed. And if we see the intermittent monitoring to continuous monitoring and come from non-invasive to implantable device, it's Apple Watch, it's Zio Patch, it is Mayo Clinic device, it is Medtronic device, and it is implantable cardiac monitor. So it can be just a simple watch to implantation operation, what you can do for. And they are different in their sensitivity and specificity. If you see, they are very sensitive to pick up the AF, or so to say irregular rhythm, more than 90% each of them. But the specificity varies widely from 70% in pulse taking to up to 100% in smartphone apps. What to do with this data? There is a progression of atrial high rate episode. When you detect, if you see the left panel, the 5 minute to 1 hour episode, within next 6 months, how many will go or progress? So if you see that 5 minutes to 1 hour, only 5% will go for a day or more of atrial fibrillation in 6 months. But if it is 12 hours to 23 hours, 63% will develop a more permanent AF within next 6 months. And now, what about the stroke? Stroke depends on the CHA2DS2-VASc score and what is the duration of AF. Even if there is no AF, there is some risk of stroke if a very high CHA2DS2-VASc score. But if it is 6 minutes to 23 hours, vis-a-vis more than 24 hours, there is some difference, particularly in the lower values of CHA2DS2-VASc score. But on the higher values of CHA2DS2-VASc score, very surprisingly, there is no difference of stroke rate. And also, the ESC has recommended that opportunistic screening of AF by pulse or ECG rhythm strip is recommended on everybody above 65 years. So these are the vulnerable people when you should be go for head hunting and for proactive detection. Also, it is recommended to interrogate the pacemaker and implantable cardiovascular defibrillator on a regular basis for AHRE. When we implant a pacemaker, we just are interested about the battery life. Okay, battery life is fine, then go on. We don't have to see you. But it is mandatory to check the atrial high rate episodes when you have got the opportunity of a pacemaker inside the body. It is mandatory. We don't do it many times. Now, when screening for AF, it is recommended that the individual undergoing screening are informed about the outcome of the screening and its relevance. It's almost legally important. He might say, hey, doctor, you have detected something in me. Now what to do with this? Why didn't you explain that there will be so much problem in my life if you detect it? Then I wouldn't have subjected myself. So that is very interesting. A structured referral platform should be organized beforehand, and definite diagnosis of AF in screening positive cases must be done with an ECG which show at least 30 seconds of AF. So screening does not lead to anywhere excepting leading it to a specialized clinic. Nothing more, nothing less. Now we know who are susceptible to this opportunistic screening positivity. Aged and male patient with some ethnicity and genetic, a lot of comorbid condition, and obese, hypertensive, OSA, COPD, CKD, diabetes, and so on. So if these things are present, you are more proactive to hunt for the atrial fibrillation. If you see the blood pressure, no blood pressure versus hypertension, there is high risk of atrial fibrillation in hypertensive people. 140 systolic versus 130 systolic target. Twice as many AF in 140 systolic target hypertensive patient. Hypertension with LVH, without LVH. Twice as many AF patient in LVH with hypertension. So these are the clinical cues. Elderly patient, 140 and more blood pressure, LVH with blood pressure, they are supposed to have atrial fibrillation if you look carefully. So hypertension in sinus rhythm, but when you suspect AF, if there is a cryptogenic stroke, as I mentioned, certain other parameters, age, etc., then frequent opportunistic screening. If it fails, long-term non-invasive ECG monitoring. If it fails, implantable cardiac loop recorder, depends on how strongly you suspect of an underlying atrial fibrillation. Now, what to do with this atrial fibrillation? Now, if you detect atrial fibrillation clinical, you know that standard protocol, everybody, even a child knows how to treat an atrial fibrillation nowadays. But what is the subclinical thing? Incidental finding on implantable or wearable device, incidental finding during monitoring for other cause, and detection during the embolic stroke of undetermined source. What to do? High false positive rate for device detection, uncertain impact of symptom status and the burden of the disease, and uncertain role of anticoagulation. So you are more in a soup. What are the advantage or benefit of detecting this subclinical AF? You can prevent a stroke, you can prevent a symptom. You can prevent electrical atrial remodeling, you can prevent an hemodynamic derangement and cardiomyopathy by upstream treatment or proactive treatment. You can prevent AF-related morbidity and reduction of other associated conditions. But what are the risks? Abnormal result may cause anxiety, with more hypertension and actually precipitation of atrial fibrillation due to anxiety. ECG misinterpretation result may lead to overdiagnosis and overtreatment. And very interestingly, ECG may detect other incidental abnormalities, which were not supposed to be detected and treated for another 10 years. And then you do an angiography, you put a stent, you do a bypass surgery, you put an ICD, and which causes more harm than good unless the patient has got enough reason to go for these parameters. Now, the current vision of International Society of EHRA 2017, duration has to be more than 5.5 hours. CHA2DS2-VASc score must be permissible to do the oral anticoagulation. Otherwise, you don't look into it. If the CHA2DS2-VASc score is low, don't hunt for atrial fibrillation. You won't gain anything by detecting that AF. If CHA2DS2-VASc score is high, then only there is some reason, some rationale to go for it. Now, cryptogenic stroke and underlying atrial fibrillation. If there is a cryptogenic stroke, patient in sinus rhythm, and if you hunt for atrial fibrillation by standard versus the implantable device, in 6 months, the detection rate is 2% versus 10%. In 1 year, 2% versus 15%. In 3 years, 2% versus 30%. So you see that 2% remains 2%. Even after 3 years, if you don't do anything. But if you put an implantable cardiac device, with every year, you are detecting 10% cases of atrial fibrillation, so that at the end of 3 years, 1/3 of patients are candidates for oral anticoagulation, so that you can prevent a second stroke, which is important. Now, if you see the duration of AF, more than 23 hours versus no AF. And there's of course between 0 and 23 hours. But if you see the two extremes, you will see there is a huge gap of stroke associated with this atrial fibrillation, either more than 24 hours or less. So lesser the AF burden, lesser the chance of stroke. The ASSERT study published 3 years ago, duration of device detected subclinical AF and the stroke chance. So if you take the 6 minutes as cutoff, you will get 40% people detected to have AF. If 6 hours, it is 20%. If you get the standard as 24 hours, still you will get 10% people getting the stroke. But only if it is more than 24 hours, that is clinical AF, then only the stroke risk is really high. In the other areas, 6 hours to 24 hours, 6 minutes to 6 hours, they don't have much increase of stroke risk. So there is some contradiction. So if you have an ischemic stroke in sinus rhythm, do the ECG monitoring for 72 hours. No AF detected. Additive non-invasive ECG monitoring based on the risk stratification. Only, as I mentioned, if you think the patient has got high chance of AF, then go for the invasive monitoring or 30 days extra monitoring. But if you see it is a low risk, just forget it for the time being. So recommendation for the search of AF in patient with cryptogenic stroke by ESC last year, in patient with acute ischemic stroke or TIA and without previously known AF, monitoring for AF is recommended using a short-term ECG recording for 24 hours, then 72 hours. And in 2A recommendation is that in selected patient without known AF, additional ECG monitoring, long-term non-invasive monitoring, as well as interventional monitoring to detect AF is class 2A recommendation. Treatment of subclinical AF, does 1 + 1 always equal 2? A very interesting article published in Circulation. Subclinical AF doubles the risk of stroke, particularly in elderly hypertensive patient on pacemaker or ICD. If you detect a 6 minute or more AF, there is 2.5 times more stroke. Clinical AF, whether symptomatic or asymptomatic, and paroxysmal or persistent AF you are treating. So why not subclinical AF? What are your symptoms to do with the risk of stroke? If there is AF, if it is for 10 hours, so why don't you treat it? What about some people have more tolerance, they don't complain about palpitation. So why should it be judged by clinical parameters? But trends, ASSERT and impact all show no association between AF and the stroke in terms of temporal relation. No AF is recorded in the preceding month. Even when there is a stroke, AF was not recorded within 1 month of that stroke. So it is not causally relative. Is it only a bystander marker? And episodes of at least 24 hours is actually increasing the stroke risk, not 6 minutes, not 6 minutes to 23 hours. So what is the point in detecting this? So actually we are trying to find out by the Artesia trial and the NOAA-FNET trial. Pending the results of this within next 2 to 3 hours, if you get a patient, you can enroll these patients into these 2 trials, or it's up to you. If it is more than 6 minutes duration and the pulse rate and the rate was 180 per minute or more, then you very carefully think about the CHA2DS2-VASc score. And if the CHA2DS2-VASc score is 2 or 3 or more than that, then you really go for hunting for this AF detection.
So sorry to
When to
interrupt,
give
but
anticoagulation?
the time up, sir.
Yeah, I'm finishing. In primary prophylaxis, depending on CHA2DS2-VASc score, ESC is very wise. They didn't give any watershed cutoff. They said at CHA2DS2-VASc score increases, your threshold for giving the anticoagulation decreases. And as the duration of AF increases, your threshold for giving the anticoagulation also decreases. So there is no watertight compartment, but depending on the CHA2DS2-VASc score and the duration, you decide what to do. So I summarize, my friend, subclinical atrial fibrillation is an AF detected in asymptomatic patient without proven AF but suspected. SCAF is not uncommon, especially detectable after cryptogenic stroke or people with high risk of stroke, as I described. Signs of atrial myopathy without detected AF are not currently sufficient to initiate any oral anticoagulation. The diagnosis of AF on post-stroke monitoring requires documentation of an ECG of sufficient quality to allow confirmation by a trained person. And the concept of ESAS has not been proven to identify patient with stroke who can benefit from OSE. Fulfilling the criteria is neither an indication for NOAC treatment nor the withholding of prolonged ECG monitoring. Patient with ischemic stroke or TIA should have at least 72 hours of Holter monitoring. Cardiac imaging marker, etc., should reduce the threshold of invasive monitoring for AF. The AF detection rate after cryptogenic stroke is a function of length of monitoring, how long do you monitor, and what the definition you give, 6 minutes or 1 hour or 23 hours. At present, it is controversial how to manage an incidentally detected SCAF in terms of arrhythmia prevention and stroke prevention. So, sir, from this so beautiful area when we could detect the atrial fibrillation, I still love this approach. But unfortunately, we have this approach, a very smart approach, so to say, but quo vadis domini. Where are we going for detecting AF? Are we directed or are we misdirected? Thank you.
Thank you, Dr. Soumitra. It was a fantastic talk on this new topic. I must say, this is a topic of high relevance because of the increasing use of devices, and we may be detecting a lot of episodes of atrial fibrillation, not clinically detectable, not previously detectable before the implantation of these devices. Now, what to do with these patients? There are 2 questions. One, are we supposed to do something to prevent the episodes of atrial fibrillation, to reduce the burden of atrial fibrillation, so that we should prevent the atrial cardiomyopathy or a chance of development of heart failure? Second, what is the need for stroke prevention in atrial fibrillation? You have clearly told that there are 2 most important situations where you need it. One, when the CHA2DS2-VASc score is high, otherwise there is no point. There it may be only an innocent bystander. There is no point in hunting or chasing these events. Second is patients who had a cryptogenic stroke and now they are found to have a asymptomatic or subclinical atrial fibrillation. This is important, where you have to, any duration of atrial fibrillation may be important in terms of stroke prevention in atrial fibrillation. So what is your take-home message? I think due to the short the time constraints, what is your take-home message of when we detect a subclinical atrial fibrillation, what should we do? Dr. Soumitra?
The first question you yes, I'm there. And to hear me?
Some break in your voice. There is some problem with your bandwidth.
So, Javi, you have posed a very important problem which I did not touch upon. Is not the what we call the upstream therapy. And there is evidence two ways. One is if we reduce the risk burden, like the range of blood pressure, like the obesity, like the COPD and the hypoxia damage, this is very important. And number two, there is some proactive treatment, particularly like ARB, angiotensin receptor blocker, has proved to prevent the first episode of atrial fibrillation in a clinical atrial fibrillation. There is some evidence. I'm not saying full evidence. Surprisingly, beta blocker fails here. Rather, ARB is better over here. So there is something we can do, even not going into oral anticoagulation, while we detect this subclinical atrial fibrillation by reducing the risk, and if in addition of an ARB, if possible, if the conditions allow. That's my submission is.
Dilip?
Yeah, I think it was a wonderful presentation, and Dr. Ray has almost clarified most of the points. One small point from my side: how much weightage and kind of importance you are going to give to PPG-based devices, wearable devices, whether you'd be going for anticoagulation or some therapy. Those patients who like Apple Watch or maybe some Fitbits, which tells you that with algorithms that there is atrial fibrillation, very varying RA interval. They have come up with the algorithms that this patient is having more than 24 hours atrial fibrillation. Would you like to go ahead with therapy, or would you like to reconfirm with ECG-based devices or implantable or external patches and ECG-based, kind of confirmation of atrial fibrillation?
We have to wait for those results of two big trials. That is number one. And for the time being, I would say it's better to wait and prove it clinically by ECGs, or you admit the patient for a few days and see whether there is anything detected, something like that. Not on Apple based. You can hook on the patient for a lifelong oral anticoagulation with all its hazards. I am against it. Maybe Dr. Narasimhan will say something on this, please, sir.
Nothing. I tend to use this. If a patient truly has an true indication is when the stroke is of undiagnosed origin, you want to prevent a second stroke. And by imaging and the TOAST criteria, it suggests the intracranial vessels, everything is normal. We do a D-dimer soon after an episode. If D-dimer is elevated, I presume that the patient has had an past history of AFib, and I don't do monitoring. I recommend anticoagulation to these patients if the CHAT score is more than 2. I don't think we achieve anything more than that.
That's interesting. Always something new to learn from Dr. Narasimhan. Great. Thank you, sir.
Dr. Soumitra, can we put it as all subclinical AFs may not require a particular treatment, but there are some subgroup of patients in the subclinical atrial fibrillation who require treatment to prevent further episodes of atrial fibrillation, to reduce the atrial fibrillation burden as well as stroke prevention.
Conclusion. That's the conclusion we can draw at the moment. Yes, Dr.
Just one question, quick question. Like, you did mention about the duration for diagnosis of AHRE or subclinical AF. You did mention about the duration of the episode. But what about the rate? Do you think the rate is also important?
Yes, it is mentioned 180 or more. I have given in one of the slides. More than 6 minutes episode, and the rate, the ventricular rate will be more than 180 per minute, or at least 180.
I think we should come to an end of this session, a wonderful session, rather a new one. So let us move to the next one. To chair the session, may I request Dr. Rakesh Jadhav and Dr. Shuchit Majumdar to come in as chairpersons and to speak on the subject, bundle branch block in ECG. Actually, the original title, I kept it, when one should be cautious. But Dr. Narasimhan wanted to have a little different title. So it is up to him. Dr. Narasimhan, please go ahead with your deliberation.
Thank you, Dr. Guha. And I think Dr. Narasimha is our teacher, and he's a teacher of everybody. He teaches what we try to preach and what we try to practice. And this is a very important topic because invariably you find bundle branch block on ECG. So to know what significance of bundle branch block is, when to pace, when to ignore, when to go for further investigation, I think none other than Dr. Narasimhan can explain in the best possible way. Dr. Narasimhan, sir, please.
Thank you very much, Dr. Yadav and Dr. Guha. I've kept this talk a little more basic and clinically oriented, so pardon me if some of the concepts are very basic. As you all know, the initial vector in a right bundle branch block, this is the sternum, this is the vertebra, and in all of us, the activation is from left to right of the septum, which inscribes a small R, and then a very delayed activation of the right ventricle leads on to the R prime, which is very tall and delayed. So that defines the right bundle branch block in terms of electrophysiological characteristics. However, the biggest problem is in several patients, it can be a normal finding. Also, it is a marker of structural heart disease like hypertensive heart disease, coronary disease, and especially pulmonary disorders. So even though by itself, it may not indicate a need for a pacemaker, it will tell you that you need to investigate this patient further. For example, for diastolic heart failure, for hypertensive heart disease, there is some diffuse interstitial fibrosis that is going on that preferentially affects either the conduction system in terms of fibrosis or calcification, intravascular calcification. So you need to take a little more holistic view about this in terms of treating the patient. For example, these things are very common in people where the calcium phosphorus ratios are abnormal in renal failure. Extrinsic calcium can cause the problem. So when you have a person with a bundle branch block and syncope, very often it's neurocardiogenic syncope versus is it a true arrhythmic syncope is the question. Here, more than the ECG, you go by history. An abrupt onset of syncope, absence of prodrome in a person above 50 with bundle branch block, we tend to err on the side of giving a pacemaker because very often tilt test may be falsely positive and an EP study may not be able to throw some light on this. However, there are certain clinical characteristics. For example, if you see a QRBB, that tells you that the patient has a septal fibrosis. It may be an old infarct or a dilated cardiomyopathy or a HCM, which may be causing, and you have a lower threshold for giving a device. However, if a patient in addition has poor tissue velocities in this situation on echo, it could still be not a bradycardic syncope, but a VT could be a reason for the syncope in these patients. The second is when you see a patient with syncope and he comes to with a sinus tachycardia and he has a right bundle branch block, one of the causes which presents as syncope and right bundle branch block is an acute pulmonary embolism, which presents typically with an S1, Q3, T3 and a sinus tachycardia. You falsely see a small transient AV block and start working up the patient for a pacemaker. You may miss the underlying diagnosis in these patients. Third is not all right bundle branch block are always related to conduction system disease. The clue is the amount of delay and slurring that you see in R prime. As I told you, the second half of the QRS, which is the R prime, is a delayed activation of the right bundle. If it is very diminutive in voltage, if the voltage of the second component is very diminutive, it suggests a diffuse muscle disease of the right ventricle, and ARVC should be considered in these patients as a delayed epsilon wave masquerading as a bundle branch block. This is typically the pattern. Instead of a sharp upstroke, a very delayed and a diminutive R prime. So in contrast to a typical right bundle branch block where the delayed component is tall and robust in its voltage, patients with ARVC will have a very diminutive R prime and much more delayed than normal. The other condition is the company it keeps. When you have a person with a right bundle branch block and the PR is also prolonged, you need to think whether there is some diffuse conduction system disease or something else going on. If the voltages are all tall, one of the differential diagnoses is a forme frustrae of HCM. But if you start seeing this kind of Q waves, spiky Q waves all over. HCM is a differential, coronary artery disease is a differential, and patchy fibrosis due to granulomatous disorders like sarcoid should be considered. The reason why this is important is because just giving a pacemaker alone may not suffice, because giving a pacemaker 2 years later, he'll come as a dilated cardiomyopathy because of a progression of underlying disease in these patients. Similarly, when you have a diminutive voltage of the R prime, which is accompanied by fascicular blocks, it again draws your attention to a condition like sarcoidosis or a tuberculous myocarditis, when you have a diminutive R prime component with fascicular block or prolonged PR interval. So not only is pacemaker required, but you need to work up these patients for an additional disease beyond just giving a pacemaker to a patient. The third condition, which can again present as right bundle branch block, is conditions like Brugada syndrome, where the typical ST elevation can be masked when they develop a right bundle branch block. The clue to the diagnosis is the base of the triangle of the R prime is very broad. That is, if you take the R prime, the second component, it is a very broad, slurred, and therefore the base will be very wide in comparison to a typical incomplete right bundle branch block, where there is a spiky R prime. This should make you suspect that it is probably Brugada, and you need to move the ECG V1 one space up to confirm the diagnosis, if necessary, with pharmacological challenge. And again, the right bundle branch block like pattern may indicate this kind of a typical notching that is seen in inferior leads, which should serve as a marker for underlying left to right shunt, especially at the atrial level. We have had this kind of situation where patients come with right bundle branch block and they mistake this as tachycardia, and repeated cardiac shocks are delivered. Remember, large anterior MI in a young person immediately can trigger a surge of adrenergic response, and they have a marked tachycardic response compared to older people. And therefore, this is typically a young smoker with large anterior MI coming with a heart rate of 150 and 160. And the clue is to look at one particular lead anywhere where you see a P followed by a QRS, P followed by a QRS. And if this is accompanied by an ST elevation in AVR, this may suggest a left main occlusion, which should not be mistaken as VT, because this patient very often are coming to casualty with very rapid tachycardias and repeated shocks, and amiodarone is started, missing the underlying diagnosis in these patients. Sorry. Now, when you have a patient with a right bundle branch block and comes to you with syncope, when do you decide that this is malignant or which requires a pacemaker vis-a-vis a benign right bundle branch block? One is if the PR is prolonged or even upper limit of normal in such a patient, or if they have a posterior fascicular block. Posterior fascicle seldom gets involved in conduction system disease unless it's a diffuse conduction system disease. And very often these people will progress to develop complete AV block, and we will have a lower threshold for giving a pacemaker for these patients. Again, when you sit in the casualty and the patient comes to you with hypotension and comatose situation, and it looks like a right bundle branch block with delayed second component and notching, and there is a delayed second component in AVR, one of the differentials is something like a diffuse sodium channel blockade. Several drugs we use in clinical practice like amitriptyline, tryptomer, tricyclics. Of late, we have been seeing cocaine, which is young adults coming with cocaine poisoning, can present with altered sensorium and a right bundle branch block like pattern. You should consider this because immediately you need to start them on sodium bicarbonate, which will normalize some of the hemodynamic abnormalities before giving any other ionotropes to these patients. Switching gears to left bundle branch block, as I said earlier, the initial activation in all of us is through the left bundle and a left to right activation that gets disrupted in patients with a left bundle branch block, especially if the left bundle branch block is accompanied by left anterior fascicular block. So the sequence of activation will be from the right side of the septum, this aspect of the septum where the posterior papillary muscle is inserted. So you will have a posterior papillary muscle contracting with the septum and a very delayed lateral wall activation and an eccentric contraction of the lateral papillary muscle leading on to eccentric mitral regurgitation in some of these patients. So left bundle branch block can be a relatively asymptomatic finding in a person with hypertension and LVH, but can lead on to progressive ventricular dysfunction or present as syncope. Again, the typical criteria is 120 milliseconds or more, and we typically look for a notching or a slurred R wave in V5 and V6, and the RP time is prolonged. Why is this relevant? Because if you look at it, the transeptal activation time, you're seeing the sternum, the interventricular septum, the right bundle gets activated first. From the right to the left, it takes about 40 milliseconds. And another 40 milliseconds, the whole of endocardium gets activated. Then the second notch is predominantly because of a late activation of the epicardium. Now, why is this relevant in terms of looking at an ECG and deciding whether a patient is going to respond to conduction system pacing or you need an additional left ventricular lead? This is what the ECG should tell you. The initial component is sharp, which is due to endocardial activation of the left ventricle. The delayed component is because of the epicardial activation of the left ventricle. The taller and the broader and more notched the second component, it suggests that it's probably better to put a left ventricular lead rather than correcting it by just fixing a lead in left bundle itself. So the second component, the height and the width, tells you the amount of muscle that you are likely to recruit by placing an LV lead, and therefore this patient is likely to respond very well if the second component is tall and fat. Now again, it makes a lot of difference to understand whether this bundle branch block is rate related, and physiologically all of us know with a transition from a particular heart rate to a faster rate, the bundle branches can physiologically block. If it is right bundle in long term, it doesn't seem to have much of a prognostic implication, but patients with a left bundle branch block, which develops during tachycardia, can develop a syndrome similar to angina. And this is called a painful left bundle branch syndrome, where they present exactly with typical angina because of a delayed epicardial squeeze of the epicardial vessels. And they truly have lateral wall ischemia in this situation, which is functional, and they can be corrected by left ventricular free wall pacing. In contrast to that, if you have a patient where the QRS is narrow, but when the heart rate decelerates, you get a very wide QRS. This is malignant, this is pathological, and this indicates phase 4 block, and phase 4 block usually happens in a diseased bundle branch. And if you see this in a person with syncope, you will have a very low threshold for giving a pacemaker for that patient. The other thing which we forget is when you have a person with a pre-excitation and a left bundle branch block like pattern, if it's a pure pre-excitation, the right-sided pre-excitation itself can cause some LV dysfunction. Getting rid of this pathway may correct the ventricular dysfunction as well as you may be able to correct the QRS. However, one of the subsets, some of the hypertrophic cardiomyopathy variant like AMP kinase mutate, PRKAG mutations can present with this kind of a syndrome where they will have a pre-excitation and a very tall QRS and lateral leads, and you should carefully look at the echo before just jumping and doing an ablation on these patients. When you are uncertain, when the patient's history is uncertain, when you are not sure what to do, you can, a very rare situation, you may consider doing a his bundle study in them. If you demonstrate a very prominent HV prolongation, which worsens with pacing or gets blocked, you may consider giving a pacemaker for a given patient. So the EP study is restricted to an occasional situation when you're not able to decide clinically what is required as a next step. Switching gears, among patients with left bundle branch block, it becomes because the initial vector in the septal activation is altered. There is a difficulty in diagnosing acute MI, and Scarbosa criteria would be useful to make a diagnosis. This is a typical example where the patient has an ST elevation in the lateral leads in the presence of a left bundle branch block, and patients has atrial fibrillation, and this patient should be immediately either taken to cath lab or they need thrombolysis. And it's important in late presentation, some of these patients, the old infarct can be picked up by looking at the notching in the lateral leads or mid-precordial leads. If there's a lot of fractionation and notching, that should make you suspect there is an old septal scar in those patients. Second is, if you look at the ST to S ratio, that is, in a person with a chronic left bundle branch block due to conduction system disease, the ST elevation is very minimal compared to the depth of the S wave. In a person with an acute MI, however, the ST elevation is much more in comparison to the S wave depth. So you look at what is known as S to T ratio, and if that is more than 1/4 ST elevation, then it's more likely to be an acute ST elevation MI, and you need to consider as such if this patient has an acute coronary syndrome. Occasionally, you have this kind of bundle branch block-like pattern, but this is not a typical bundle branch block. When you see an effacement of the ST segment in a person with a bundle branch block-like pattern, it should make you suspect a diffuse sodium channel blockade. And the commonest sodium channel blockade that you see in clinical practice is hyperkalemia. Hyperkalemia at very high levels blocks all the sodium channels, and therefore there is a QRS becomes very wide in these patients and presents like a sinoventricular conduction like this patient. And again, when you have these patients with bundle branch block, you need to be extremely careful when you take them for even minor central vein insertion or pulmonary cath insertion, because transient trauma to the existing right bundle can result. This is during a right heart cath in a person with a bundle branch block. The catheter-induced complete CHP can occur. You should be aware of this complication. If you have a person with syncope, and if you have in the same ECG, one showing a left bundle and right bundle, you don't need further testing for this person. Straight away, go ahead with a pacemaker. And this is alternating bundle branch block. The third situation where physicians need to be aware is when you have a person with what looks like a right bundle branch block, but the S waves are absent in 1 and AVL. That should make you suspect he has a bilateral bundle branch block called as masquerading right bundle branch block. These patients are likely to benefit from CRT as much as a pure left bundle branch block. I think I've given just an overview of this. I would like to stop here. By any means, this is not complete. If there are any questions, we'll be happy to handle it at the end. Thank you so much.
Thank you, sir, for a wonderful talk. I think if there are any questions, I don't see question in the chat box.
You can initiate a discussion.
Yes. I think I should go to
yourself
chat
and Shuchit.
Dr. Nasima, this is a very common query that we find an RBB with PR interval of 180 millisecond. And these patients are often refused for any general surgery. In pre-anesthetic checkup, the surgeon will, the anesthetic will say, it is a high risk, get an Holter done. Some say put a temporary pacemaker while doing surgery. So, and patient is entirely asymptomatic. So what your take-home message for these type of patients? Because it's a very common scenario.
Nothing is required. Nothing is required. As I said, if a person is asymptomatic, normal effort tolerance, we can clear them for surgery without any issues.
Second important query, can you tell me which patient of left bundle branch block need further investigation? Asymptomatic 50 years female came with a left bundle branch block. So just tell 4 or 5 points for an audience that these patients, if these are the things, they required further investigation.
Okay. Left bundle branch block initially usually suggests there is some other disease we are missing. At least listen to the patient carefully, look for effort tolerance, look for murmurs, because the commonest reason for that in an asymptomatic person is annular calcification. So either aortic or mitral annular calcium, which starts very as a speck of calcium at the age of 55, 60 in a postmenopausal women, will progress to complete heavy block over 2 decades. So you look for any cause for which will aggravate the calcification. One of the commonest thing is uncontrolled hypertension, hyperuricemia, several other things which can be corrected. So it gives an opportunity to evaluate the patient for aortic stenosis, mitral regurgitation, and of course, if the effort tolerance is limited, you need to think of coronary evaluation. But having said that, the commonest cause in women is uncontrolled hypertension.
Sir, can I ask one question to you?
Sure, please.
Yeah. So, how will you evaluate a patient who has a transient LBUB while doing a TMT? Means, how will you
That's a very, very
stratify that
interesting
patient?
question. Because if you take a ventricle and acutely load the ventricle, you, for example, go and avulse the aortic valve and the ventricle dilates, animals will develop bundle branch block. So there are 2 reasons for bundle branch block happening during exertion. One is long refractory period of the bundle branches, or there is a transient ballooning or dilatation of the ventricle during TMT. So the second cause is more important and malignant. You should suspect a triple vessel disease in those patients. If a patient is symptomatic and he has developed other changes, you should rule out a triple vessel disease. However, the other cause is, of course, asymptomatic progression of an incomplete left bundle branch block, which becomes complete during a sinus tachycardia.
So does the rate is important, or at what rate he develops an LBUV? That may be important in that case.
Yes.
So if he develops at maybe 130 or something, may not be that important as one develops at 80 or 90.
That's right. As you know, the bundle branch block occurs at a higher rate, but resolves at a lower rate. That is, you will develop occurrence of a left bundle branch block at a rate of 150. But it has to wait till the rate comes to 110 before the block resolves because of functional re-entry into the contralateral bundle.
May I have a quick question?
Yes, please.
How do you use a beta blocker or diltiazem in presence of different bundle branch block, second degree and bifascicular block, etc. in these scenarios?
That's a very, very important question. So if you have a person with bundle branch block and normal PR interval in an asymptomatic patient who has got, say, for example, a mild LV dysfunction or hypertension, there is generally no fear of using a beta blocker, because if you actually reduce the sinus rate, the His-Purkinje system will conduct better. On the other hand, if you think the patient has a bundle branch block plus an AV nodal block, which is marked by a little prolongation of the PR interval, then I would be cautious about using a beta blocker in those patients, especially if they had symptoms.
Thank you, sir.
Dr. Narasimhan, there is a question in the chat box. Any comments on Barcelona criteria?
I'm not aware of this.
I'm also not aware of. That's why I just asked you.
Thank you for the question. That helps us to go back and read. Thank you so much.
Rakesh or Shuchit, any other question?
Yeah, one more question. Sir has already mentioned that the role of EP study, when you should do. So how many means we can see a percentage of patients, if we put an empirical pacemaker in a bundle branch block, there is a chance of recurrence of syncope in those patients. Maybe that is around 20 to 25%. So what is your take, sir, on ILR in those patients?
I think ILR is far overrated by the studies. If you really look at it, any ILR, yes, it picks up AFib, it picks up transient AV block, but as a clinician, I'm interested whether the event rates at the end of, suppose you randomize 1,000 patients, have I improved the survival, prevented syncope? Then it becomes very questionable, because the next time the patient comes to you, he may be, ILR will pick up a VF, but the patient is dead. So when you need to have a certain degree, if it's a strong suspicion, it's a traumatic syncope, patient had an abrupt fall, I don't wait for an ILR, I just go ahead and give them a pacemaker.
Thank you, sir. Thank you. Thank you very much.
Sure, thank you.
Narasimhan, thank you very much. Sure. Soumitra, please take over. Soumitra.
Yes, Dr. Guho. Thank you.
You are not audible, sir. Soumitra is perhaps not audible.
Thank you. So we are going now into a very controversial subject, the ICD, which was fraught with controversy birth. And now the controversy is increasing every day with different kind of management going on. So here I invite our chairpersons, Dr. Narasimhan is already there, and Dr. Manatosh Paja will have a debate. Just to remind our viewers that 4 years ago, Dr. Shantanu Guha and we published a heart failure position paper on behalf of Cardiological Society of India. And there the role of ICD and CRT, that chapter were hugely contributed by Dr. Narasimhan himself. So he is here with us. So if there is anything changed over the last 4 years from his recommendation, and Dr. Paja, we'll discuss that after the debate. So Dr. Paja, please initiate the debate with Dr. Karok and who is that? Dr. Bashab Datto. Yes.
Bashavendra Choudhury.
Okay, thank you very much. Thank you, Goa and Dr. Rai, for inviting this occasion. And I'm very happy to get the chairman with me, Narasimhan, on our friend. So very important subject today, implantation of ICD in primary prevention in India. First thing, should we strictly adhere to the Western guideline? This is very important. You know that Dr. Ovik Karok, Ovik Karok is one of the consultant cardiology in Medical College, and Dr. Basavendra Choudhury also consultant cardiology Medical College. So Dr. Karok will talk again for the motion of this debate, and Dr. Choudhury against the motion. So may I request Dr. Ovik Karok to proceed to start the lectures for motion.
Thank you, sir. Good evening, everyone. Respected chairperson, my teachers, seniors, and my fellow colleagues. The topic of today's debate is implantation of ICD in primary prevention in India, whether we should strictly adhere to the Western guidelines or not. And I would be speaking for the motion. So at the outset, I would like to thank Michael Mirovsky and Martin Mower, the pioneers for the development of ICD. And since the first device that was implanted in February 1980 by Dr. Levi Watkins at Johns Hopkins Hospital, the development in the field of ICD has taken a hugely developing scenario over the last 40 years. Now, ICDs in primary prevention, the ICD has been the mainstay for prevention of sudden cardiac death. The chances of surviving a cardiac arrest in the out-of-hospital setting is very low. The figure is about 4.6 to 8%, which is a very dismal figure in the Western population. And considering the Indian situation, it's going to be even more dismal. Over the last 3 decades, the indications have evolved, and the current treatments of myocardial infarction and heart failure have improved substantially over the last decades. And thus, the patient population at risk of sudden cardiac death may have been altered as well. Consequently, data on high-risk patients after MI and with the heart failure are relatively sparse, and definitely there is scarcity of the Indian data. The rationale behind sudden cardiac arrest prevention is to identify individuals at the highest risk for cardiac arrest and offer an ICD for sudden death prevention, provided they have an anticipated survival time of 1 year with a reasonable functional capacity. However, some have questioned the role of ICD in the contemporary clinical practice, because major point of the controversy regarding primary prevention comes with dilated cardiomyopathy, be it ischemic or non-ischemic, considering the huge burden of the disease. The other indications for primary prevention are basically non-controversial, as I'll touch on later. So the prediction of the degree of benefit from ICD implantation is basically a balance of risk versus benefit. The risk of sudden cardiac death from ventricular arrhythmia vis-a-vis non-death, non-sudden death, procedural risk, inappropriate shocks, and device infection. Various validated risk calculators and risk assessment tools are available for aiding in the estimation of each patient's benefit or risk of an ICD. Now, briefly touching over the Western guidelines regarding the primary prevention of sudden cardiac death in ischemic heart disease, LV ejection fraction of 35% or less with an NIHA class of 2 to 3 despite GDMT, or an ejection fraction of less than or equal to 30% with an NIHA class 1 despite GDMT, at least 40 days post-MI and at least 90 days post-revascularization with a meaningful survival of more than 1 year, then an ICD is indicated. In patients with non-sustained VTA due to prior myocardial infarction with an LV ejection fraction of 40% or less and an inducible sustained VT or VF at electrophysiological study, again ICD is recommended. In patients with non-ischemic cardiomyopathy, heart failure with NIHA class 2 to 3 symptoms with an ejection fraction of 35% or less despite a GDMT, an ICD is recommended provided there is a meaningful survival. Now, regarding the patients with bifascicular bundle branch block with unexplained syncope, if the patient is having an ejection fraction of less than or equal to 35%, depending upon the bundle branch block, an ICD or a CRTD is indicated. Now, in patients with cardiac tachyarrhythmia with syncope with the documented VT, definitely ICD becomes an indication. And also ICD is indicated in patients with syncope and previous myocardial infarction who have VT inducible during electrophysiological study. Now, regarding unexplained syncope in patients with high risk of sudden cardiac death, an ICD therapy is recommended to reduce SCD in patients with symptomatic heart failure after more than or equal to 3 months of optimal medical therapy. The ACC American guidelines are in line with the European Society of Cardiology guidelines, both in the ischemic and the non-ischemic cardiomyopathy. Now, briefly touching over the hypertrophic cardiomyopathy, we need to assess the established risk factors, the risk modifiers, and in patients with definite risk factors, becomes an ICD, becomes an indication in these population. Regarding adult congenital heart disease, in patients with adult with repeat TOF with frequent or complex ventricular arrhythmia with unexplained syncope, with at least a moderate ventricular dysfunction or marked hypertrophy, ICD becomes a class 2A indication. In patients with Brugada syndrome, if the patient is having a suspected Brugada without a type 1 ECG, following a pharmacological challenge, if the patient is having an unexplained syncope, and if the patient is an ICD candidate, ICD becomes an indication as a class 1. Regarding long QT, high-risk patients with long QT syndrome with QTC more than 500 milliseconds, females with genotype LQT2 less than 40 years of age, and so on, then ICD becomes an indication. Now, what are the arguments against the guidelines? The RCTs conducted many years ago might not be relevant today. Trial population might not relate to real-life patient profiles. Individualization of the therapy needs is important. Medical therapies for HFrEF have evolved and hence might have lessened the survival benefit of ICDs. Definitely the Danish study and the cost of the therapy is also important in the Indian perspective. So let us now evaluate these arguments closely on the merit. Wait, before going to ICD, why not medical therapy? So the various sudden cardiac death prevention trials with antiarrhythmic agents like CAST, CHF stats, SWORD, and so on, with multiple antiarrhythmic agents have effectively shown that some of the trials are negative trials, and basically they have made the antiarrhythmics wanted for murder. So here comes the role of the hero of our talk today, the device that delivers shock, that is ICD. So there's a huge body of evidence supporting ICD, both old and new. Older pivotal trials establish the efficacy of ICD, not only in secondary prevention, but equally so in primary prevention. The MADID-2 trial, the SERI-HEF trial, which has shown significant reduction in the mortality with survival benefit. Even in the non-ischemic cardiomyopathy with definite trial, there is a significant improvement in the survival. The recent publications have also been in favor of ICD implantation for primary prevention. The UCERT ICD trial, which was published in 2020 in the European Heart Journal, showed that in contemporary ischemic cardiomyopathy or dilated cardiomyopathy patients with an ejection fraction of less than or equal to 35% with a narrow QRS, effectively ruling out CRT in these patients, a primary prophylactic ICD treatment was associated with a 27% lower mortality after adjustment, though there appeared to be lesser survival advantage in older patients or diabetics. But if we look into the pooled analysis from 5 different RCTs published in 2015, the benefit of ICD even remained with the elder age group, though it was slightly attenuated. Thereby, age alone cannot be a reason to withhold ICD therapy. So the key findings from the newer studies is basically HFrEF patients receiving ICD have similar survival benefit to patients who received an ICD in the MADID 2 SCD HEF trials. Medicare beneficiaries with a LV ejection fraction of 30 to 35% hospitalized for heart failure had better 3-year survival with an ICD than without ICD. And the survival benefit was across a diversified group of patients in various studies, including women, racial minorities, and patients with multiple comorbidities. So most importantly, these observational studies sheds light on the role of primary prevention ICDs in patients not well represented in the randomized control trials also. Now, if we look into the SWEDE HF trial, ICD use was associated with a reduction in the all-cause mortality risk at 1 year and 5 years. Well, in the CSI consensus statement, the implantation of the ICD was relaxed to up to 2 years survival. So, in this publication, it was shown that the all-cause mortality reduction benefit was seen as early as 1 year itself. And in this study, it was also identified that there was underuse of the ICD for primary prevention purposes, and they recommended to support the current guidelines and better implementation of ICD in the clinical practice. But what about the Danish study? It's important to understand the nuances of the study to evaluate its implication. The Danish trial allowed use of CRT in both the arms of the trial in the tune of about 58%, and the trial required that the patients had an elevated NT-proBNP level, thereby placing them at higher risk of advanced heart failure death rather than sudden cardiac death itself. A secondary analysis of the Danish trial showed a significant reduction in mortality with an ICD in patients less than or equal to 70 years of age. So we look into the meta-analysis of 4 randomized clinical trials, including the Danish trial published in 2017 in JAMA Cardiology. It showed a 25% reduction in all-cause mortality by a primary prevention ICD implantation. These findings support the professional guidelines. ICD is still relevant despite the recent advancements in HFrEF managements. Undoubtedly, the management of HFrEF have improved drastically in the recent years. However, there is no strong evidence that this reduces the potential benefit of ICDs, and because majority of the patients with HFrEF are not candidates for CRT because they don't match the criteria for CRT implantation, and also the usage of neurohumoral antagonists might not be in the same tune as in the trial settings. The Trivandrum Heart Failure Registry showed a very dismal finding that 3 out of every 5 patients had died during 5 years of follow-up with a median survival of approximately only 3 years. So thereby proving the fact that despite the development in the armamentarium of HFrEF patients, there is significant mortality of these patients. So then what to do after GDMT then? Is cost an issue against an ICD, or should we actually follow the Danish legacy? Because the two statements are actually contradictory. Because if we have to follow the Danish study, then we need to implant CRT to negate the beneficial effect of an ICD. But in that situation, we need to increase the implantation of CRT, which again is a costly affair. And moreover, a lot of patients do not match the criteria for CRT, which again becomes an issue in our management of HFrEF patients. So this a survey was conducted by the Indian Society of Electrocardiology and Indian Heart Rhythm Society, a survey of cardiac implantable electronic device implantation in India, which showed that single chamber ICD was most frequently used for prevention of sudden cardiac death from ventricular tachyarrhythmias. Primary prophylaxis use was seen in the tune of 52.5%, and the most common etiology of ICD use was coronary artery disease in 58.5%, followed by idiopathic DCM with 31.8%. And the indication for ICD implantation was almost equal for primary and secondary prevention. So the Western guidelines not followed in practice in India due to high cost basically is a misconception. So before I conclude my talk, the ICD can be replaced by a pacing system. It may be removed or abandoned at the time of ICD generator, end of life or service in patients with life-threatening comorbidities at the request of the patient, or when an ICD is unlikely to increase the life expectancy. So in conclusion, it can be said that ICDs have stood the test of time, and thereby whether we should strictly adhere to the Western guidelines is a big yes for me. Thank you. I rest my case.
Thank you very much, Dr. Karak. Then excellent talk for the motions. Next talk, Dr. Basudeb Choudhury. He'll talk for 12 minutes for against the motions? Dr. Chaudhary, please. Dr. Chaudhary?
Yeah.
Unmute.
Yes. Am I audible, sir?
Yes, audible, and your slide is visible.
Yeah. So, big thanks to Dr. Shantanu Guha, sir, for this opportunity for enabling us to discuss such an important topic. So, Dr. Karak, my friend, has very nicely put his case forward regarding why we should support the Western guidelines. At the onset, I would like to make some things clear. So I am speaking against the motion that we should not strictly adhere to the Western guidelines for primary prevention using ICD implantation. The word strictly adhere, I would like to focus on. The Western guidelines have been made with good intention so that a large volume of patients can be given the latest therapy available so that we can prolong survival as well as decrease morbidity. However, actually, where do the guidelines fall short? So the same therapy cannot be a tailor-made one for each and every patient. So always there is though the guidelines are here to support us, there is always a scope to individualize on a patient-to-patient basis and look for finer points where we can adjust and go for a tailor-made therapy instead of just strictly following our guidelines for its sake. So the first problem with the guidelines are that we all know that most sudden cardiac deaths are occur in our society in patients who actually don't have any history of cardiovascular disease or who have a relatively preserved ejection fraction in their last medical records. The latest example which comes to our mind is that of Christian Eriksen, the Danish footballer who just collapsed while playing in the recently conducted Euros 2020. He was a top player in the top European clubs for almost a decade now, and obviously there were no obvious abnormality in his cardiological checkups, which could not have gone unforeseen. So actually, there is no tool or guidelines or recommendation present to pick up those patients by screening programs or tools from our society or from the general population who can actually benefit by preventing a sudden cardiac death or a sudden cardiac arrest, and no recommendation for ICD for primary prevention for such a subset of patients is still there. So also moving on, only a minority of patients who receive ICD therapy actually receive an appropriate shock. It is only around 2.6% in primary prevention cases and 7.4% in secondary prevention at the end of 30 months. And weighted lifespan gain at 3 years with an ICD is only 1.5 months for primary prevention. And also, as Dr. Karak has also explained that with the advancement in the pharmacological heart failure and reperfusion therapies, the annual sudden death rates have also declined, which further decreases the benefit provided by costly therapy like ICD. And also, as years have gone by, the amount of proportion of unresponsive patients have increased, as I will touch upon in the later slides. And also, by dividing patients into ischemic and non-ischemic groups, actually, large myriad group of etiologies and heterogeneous disease conditions are actually neglected, and detailed evaluation and treatment of those systemic conditions are often missed. Next, another point against the guidelines is the over-reliance on echocardiography. Though it is the very important tool, no doubt, for routine cardiological checkup and assessment. Geometric assumptions from 2D measurements often fail to give the actual volumetric assessment of the ventricles and their function. They are influenced by the loading conditions, often not reproducible and accurate, especially in patients with wall motion abnormalities. And no clue regarding arrhythmias are obtained. And also in patients with low EF, often comorbidities, especially CKD and end-stage renal disease,
which have higher SCD risk and low benefit after ICD implantation, these things are not included in the guidelines. Only the life expectancy of more than 1 year, this thing has been included over the years. With every therapy, besides the possible benefits, there are the risks associated with it. So let us look into the risk associated with ICD therapy. So the acute conditions during the implantation procedure, which can complicate the procedure, we all know some of them are trivial and can be managed easily. However, some of the conditions may be life-threatening, such as pulmonary embolism, pneumothorax, cardiac perforation, and complications related to defibrillated threshold testing, resulting in post-shock pulsed electrical activity, embolism from conversion of AF, and so on. And infection, though not that common, are on the rise as more and more procedures are being performed. And we must not forget, because infection of ICD often requires complete extraction of the system, which itself can be very dangerous and a costly affair, and you even have a high morbidity and mortality. Next comes the issue of inappropriate shocks. So even after ICD implantation, we cannot just rest and be happy and tell the patient and their relatives that we have given the device and it will take care of the problems. Up to 5 to 15% of patients can receive an inappropriate shock, and for some reason, mortality rate is almost doubled in those patients who receive inappropriate shocks. And often in the case of with primary prevention, as the patient has not yet suffered a sustained ventricular tachycardia, so the issue with VT threshold is always there, and often sinus tachycardia with aberrancy or supraventricular tachycardia, or often AF are taken as ventricular arrhythmia by the device, and the patient go on receiving shocks. And inappropriate ICD shocks themselves can further give rise to further arrhythmias. And the psychological effects of incessant shocks, recurrent shocks, can be quite disabling. And up to 40% of patients who receive ICD therapies go on to develop psychological issues like anxiety, depression, or PTSD. And lead failures and recalls have been well reported in Western literature. I will not go into the details, but these things are definitely should be kept in mind before we go on prescribing ICD and implant ICD for a patient. So some of the authors have tried to devise some tools or some schemes which can predict which patient will have a less chance of shock and less chance of death, which patients will have a less chance of shock but high chance of death, which patients will have a high chance of both shock and death, and which patients will have a high chance of shock and will yet survive. So some of the factors like ischemic heart failure pathogenesis, atrial fibrillation, diabetes mellitus, renal insufficiency, and in higher NYHA class has been associated, which can lead to death even after shock or death without shock. And these things can be, we can put the patients either in this A, B, C, D, 4 subgroups and discuss with the patient and party and what actually they can expect after ICD implantation, what benefit they can expect, and what can be the course in the near future. Next comes the cost versus benefit ratio. Even the advanced countries like the US and the European based cost benefit analysis have given mixed results whether ICD should be routinely used in primary prevention. So the key is to implant devices in moderate risk patients who would more likely to use the ICD, get the benefit of ICD, but are less likely to experience death due to high risk conditions. And as in a country like India, which in 2016 itself had an estimated heart failure population of 8 to 10 million, and which is always on the rise, cost benefit analysis is certainly should be taken into account before we say that ICDs can be used for primary prevention for all the heart failure patients, because the patients who will qualify for ICD implantation is huge. and neither all the patients nor the government is ready, as we all know, to implement this sort of rule or strategy. So now we will look into the details of some of the recent studies which have looked into the declining clinical benefit of ICD in heart failure patients. So if we look at the older studies which were done for primary prevention, ICD versus OMT, like the MEDIT and the MUST, NSVT and VTVF inducibility were a definite criteria for enrollment. However, later on these things have been neglected, and the recent guidelines, as Dr. Karak has shown, does not include the VTVF inducibility or the NSVT criteria. Only the ejection fraction is being highlighted upon. I think with that, both the number of unresponsive patients and the number needed to treat is actually increasing. So another important thing is that the advancement in the heart failure therapy, even if you don't consider ARNI, the proportion of patients receiving beta blocker, ACE, ARB, MRA, and even CRT therapy have been actually on the rise, as has been shown in this slide. In the latest trial with for primary prevention in non-ischemic etiology of heart failure, the numbers are actually quite high. 92% of patients receive beta blocker and 97% of patients receiving ARB RAS blockade. So if we look at the outcome data, so definitely if we see that the total mortality, that the annualized event rate in the control patients itself is on a decreasing trend. Also, the hazard ratio is actually increasing, suggestive of that the benefit given by ICD for total mortality is actually on the decline, whereas the number needed to treat at 3 years and 5 years are increasing. That means in order to get benefit, we have to provide with ICD to more number of patients. And after the results of the Danish trial, which showed no significant mortality benefit of ICD therapy in non-ischemic cardiomyopathy, the debate has again arisen. So if we look at this is the first sort of study which has looked into the primary prevention of STD, included 7 trials, major trials. The baseline STD risk, the baseline risk of total mortality have been on the decline, whereas the patients unresponsive to ICD and the clinical benefit of ICD, the number needed to treat has been increasing. This slide also gives similar sort of information. So 2 factors, the progressive decline in the baseline risk of STD and total mortality, and the progressive increase in the percentage of patients unresponsive to ICD, actually combined to actually decrease the benefit of ICD in primary prevention. Improper ICD functioning resulting from ventricular undersensing, unsuccessful final internal shock, lead failures are also there, and non-cardiogenic causes of death have also been arisen, as patients with HFrEF are all often associated with important comorbidities. So another recent studies, including quite a large number of patients, ischemic and non-ischemic, have shown that in diabetic patients and in older patients above 70 years, the ICD survival benefit is actually less. And after adjustment with mortality predictors like age, LVEF, NYHA class, creatinine, and COPD, the survival benefit provided by ICD has decreased from a number of 32% to 27%. So what can we do? Definitely some risk models we can follow, like the Seattle proportional risk model, which applied on the MEDIT-2 trial, showed that the patient on the lower quartile definitely did not get the benefit, mortality benefit from ICD therapy. So Bilchik and Casey et al. In JAC 2017 actually published a very beautiful article which showed how we can use the Seattle heart failure model to assess the mortality risk, as well as the Seattle proportional risk model to assess the SCD risk. So the patients who are most likely to benefit from ICD are the patients with low SHFM and high SPRM score. Also in this study, late gadolinium enhancement in the cardiac MR, which can very effectively predict ventricular fibrosis, have a significantly higher risk for VTVF compared to those without the fibrosis. This can be used to further risk stratify the patient so that best possible therapy can be given. And also another important thing is the patient and the party should be discussed with the should be shared decision making should be done. We just should not give our opinion and impose it on the patients. So apart from the no doubt the Western things attract us, and the Western guidelines are quite attractive, and we often fall for it. Actually, the homemade recipes and homemade tools and strategies are often the more effective one. So as stated by the CSI in 2018 in the CSI position statement, we can modify the Western guidelines and use to our benefit. So ischemic cardiomyopathy with less than EF less than 35%, MI more than 40 days, OMT more than 3 months, and life expectancy more than 1 year. Then we can look for the functional status, and if they are not a candidate for assist device, then we can again stratify the patients, including the high risk markers for SAD like documented NSVT, inducible VT during EPS, and if they are present, we can safely prescribe an ICD. Same for the non-ischemic DCM with EF less than 35% after OMT for 3 months. If they have a survival, the expected survival at least 1 year, and they fall in the NYHA 1, 2, or 3 class, then we can look for delayed enhancement on cardiac MR showing mid-myocardial scarring, or non-invasive markers of electrical instability like fractionated QRS, LVDB, or complete heart block, or T-wave inversions, or QT prolongation, or if there is a family history of sudden cardiac death, then we can go for ICD therapy instead of just strictly adhering to the Western guidelines. So always there are options in front of us. There is a main street in the form of the Western guidelines. There are roads less traveled. So often we have to make our own strategies, and no doubt the data in our setup, Indian setup, is less, and the strategies for HCM in the Western guidelines is quite detailed, and risk stratification is present. But as far as the ischemic and cardiomyopathy and the non-ischemic DCM goes, which actually from the bulk of the patients of HFrEF who qualify for ICD therapy, we often have to risk stratify and modify the Western guidelines to our own advantage. Thank you.
Okay, Dr. Chaudhary, we have got 6 minutes, and Dr. Karo requested to talk 3 minutes in his favor.
One of those, there is no rebuttal.
Oh, okay.
No rebuttal.
Okay.
You give your comment, Dr. Narasimhan is there, let him give
yes,
his comment.
Dr. Narasimhan, please give an advice and to how to stop their battle.
I think both of them have presented very well their own perspectives, and it's important to look at both sides of the coin. But I think what has happened is with these guidelines, physicians have lost their capacity to individualize the treatment. And the treatment is a moving target. For example, if you take streptomycin for TB is gone, chloramphenicol for typhoid is gone, within 5 years, newer drugs have replaced. Similarly, the heart failure mortality has come down significantly with tremendous advantages in heart failure therapy. So it is a moving target, and you need to risk stratify a patient who is likely to die more due to arrhythmia than to heart failure. So transiently improving the survival for 6 months, but ultimately within 2-3 months dying doesn't help. So these things need individualization. In a country where the resources are constrained, I don't think we can follow the Western guidelines as such. We need to take the message and apply it to our patients.
Okay. So my question that, Dr. Karo, that you have to wait, and all the literature also mentions the optimum medical therapy must be given at least 3 to 6 months in spite of ventricular irregular beat. So what your opinion in that point of view? Optimum medical
Yes,
therapy.
sir, definitely optimal medical therapy with has to be given, and in all the guidelines also it has been recommended that at least 3 months of optimal medical therapy is needed before thinking about or suggesting an ICD in the patients, and it should include beta blockers, ACE inhibitor, ARB, or ARNI nowadays, the mineralocorticoid receptor antagonists, and definitely after the reaching the guideline directed dosage of the individual drugs for at least more than 3 months, and after reassessment of the clinical status and the echocardiographic evaluation to look into the ejection fraction, whether it is improving or not. After that, we should decide regarding advising an ICD as recommended by the guidelines.
There is a question came in the chat box.
Okay.
Why 40 days is selected for putting an ICD in post-MI patient? Why is it 40 days? By Dr. Jamil Abdul. Dr. Narasimhan, would you like to take this and just have a quick answer?
Yeah, the reason for that was they believed that the LV function, this applies only for secondary prevention. I mean, primary prevention ICDs. So if a person had a VT after 48 hours after an MI, sustained monomorphic VT, then he merits a device. Whereas if a person has nothing, but the EF is 30%, there is a good chance the EF is likely to improve with appropriate medical therapy in about 6 weeks' time. And the risk of sudden death comes down once the LV remodels. That is the reason for taking those 6 weeks cutoff.
Beautifully explained. Beautifully explained.
Okay, Dr. Narasimhan, my question that is in cases of the ischemic cardiomyopathy, we have to correct whether the 30% to 40% ejection fraction, we have to correct the revasculation therapy, particularly either angioplasty or CABG. Otherwise, this IC not be helpful. For your comment.
Very true.
Yeah.
Very true. If residual ischemia needs to be corrected, medications need to be optimized. These things significantly bring down the risk of sudden death. So when we discharge a patient, his BNP is still high, the risk continues to be high. The QT is long, the risk continues to be high. He has a sinus tachycardia, the risk continues to be high. So if there are simple clinical markers we can use and try to optimize, and of course all the ischemia, residual ischemia needs to be corrected.
In cases of DCM, non-ischemic cardiomyopathy, that cases if you do the particular the ICD.
Yes. Again, probably one of the speakers can take up. We have understood that the risk of sudden death varies from the genotypes.
Yeah.
So even if there is minimal scar, there are certain DCMs which are more arrhythmogenic, like laminaceae or some of the newer mutations which are desmoplakin. Some of these are predominantly arrhythmogenic. Whereas some things like titin mutation or dystrophin mutation, they have a very low risk of sudden cardiac death. So we are understanding this entity better and better over time.
Sumitra, any other question in the chat box? Dr. Rai?
No, sir. You can conclude, sir, if you like.
Okay.
Yeah, there are several sessions. You conclude, please. Monotosa, conclude.
Okay, thank you very much. Both the speakers have done a good job. And what are the indications? What are the contraindications? They have already shown the particularly Dr. Chaudhary mentioned the contraindication, complication, and the effectiveness. The contraindication is very high because infection, leak, and inappropriate shock, rightly mentioned. But appropriate cases, particularly hypertrophic cardiomyopathy, one of the important cause little light. We have done the apical cardiomyopathy. You have published in the Indian Heart Journal. Out of 40 cases until now, their mortality is very high. Only one person had died because cardiac arrhythmia, and that is even in spite of the ICD. So therefore, the appropriate case selection is very needed by clinical history and ejection fraction, life expectancy associated with COPD or diabetes. That should be considered. Thank you very much. Both the speaker done very good job and great on knowledge and good comment from Dr. Narasimhan, and well done. Thank you, Narasimhan.
Thank you, sir.
Thank you, sir.
To the chairpersons and the speakers, I simply understand one thing. We are very enthusiastic about putting an ICD on, and then we are very less enthusiastic to get a feedback from the patient, sir, I have got a shock. So we pray to God and amiodarone so that the patient does not share his shock with us. So that's where I finish. The next 40 minutes, we shall have a bonanza of ECGs from Dr. Narasimhan. I request Dr. Munna Das and Dr. Devobroto Bera to introduce Dr. Narasimhan's session, please.
Yes, sir. Good evening.
Very, very basic. So this is a patient who came with an vague chest discomfort and sweating. And then because hospital was nearby, he walked in within the first half an hour after the onset of discomfort. So the choices given, do we have a choice for MCQ or audience poll? If not, I'll just go ahead. So this is a very important ECG sign where Deventer described this as an acute hyperkalemic change but restricted to 2-3 leads. Please remember, when there is an acute ischemia and the vessel is occluded, there is a lot of acidosis there and the potassium elutes from the cell. If that happens within a localized area, you will find something like hyperkalemia there. Typically a tall peaked symmetrical T wave and a very minor ST depression, and the effacement of the ST segment. You see the QRS merges into the T wave. All these things suggest that there is a regional ischemia which is very acute. Even before the infarction happens, this ECG changes are present. And the importance of recognizing this is, if you revascularize this patient, quite likely you can abort an infarct, and the treatment here is immediately give a nitrate if the patient is a smoker, recheck the ECG and get the cath lab activated. Very rarely you may have resolution of these changes if there is a resolving thrombus, but 9 out of 10 you need to take them to the cath lab for early revascularization. So Deventer's group from Wellens, Netherlands, described this as an upsloping ST depression in precordial leads, peaked anterior T waves in the mid precordial leads V2 to V6, with the ascending limb of the T wave starting below the baseline, the ascending limb of the T wave starting below the baseline, and subtle ST elevation in AVR. This is a typical Deventer T wave, and the patient is acutely ischemic. You need to rush him with anti-ischemic therapy and rush him to the cath lab. This is a patient with orthopnea, severe mitral regurgitation. This is one thing which I would like you to remember. Of course, here it's very dramatic, an ST depression. But if you look at the R wave amplitude in V2, it's much taller and the T wave is upright. This should make us suspect that you're dealing with a posterior wall infarction. And these patients, when they develop mitral regurgitation, it's an urgent indication to revascularize because that papillary muscle is ischemic, and you may be able to abort an infarct and abolish the mitral regurgitation here. So this is a sign when you see a tall R in V1 and V2 accompanied by a tall T wave in the upright T wave, it should make you suspect you're dealing with a posterior myocardial infarction. This is inferior wall infarction with posterior wall involvement, and mitral regurgitation 9 out of 10 will get abolished or at least get minimized once you revascularize this territory. So how do you recognize ST segment depression, horizontal or downsloping like this case? Very prominent R wave in lead V1 or V2. RS ratio is more than 1. RS ratio is more than 1 in V2. Prominent upright T wave as was seen in this patient, and combination of horizontal ST depression with upright T wave. Usually this happens in the company of an inferior wall or a lateral wall MI. And when you're unsure, you may use V7 and V8 in the posterior location to document. Now, this patient presented to us about a year ago with rapid palpitation, recurrent atrial fibrillation, and you can see RR interval with ST changes. He was given loaded with drugs, heparin, and then given a beta blocker, and the rate came down. I would like to draw attention to the same fact. The STs are normal in V1, but very markedly depressed in V2, and the T wave is upright with a prominent upright QRS in V2. The next day, you find a completed dorsal infarction here in the same patient. The reason why this is important is to understand left atrial circumflex artery is a branch of circumflex, and that supplies the left atrium. When they become acutely ischemic, you can have atrial fibrillation as the presenting manifestation. Now, all the attention in this patient was devoted to atrial fibrillation. Someone forgot to look at the prominent STT changes, and this patient should have been rushed to the cath lab rather than treating him with more and more amiodarone in this patient. Unfortunately, it was a missed opportunity to treat. He had a completely occluded circumflex, which was opened much later. So when you have doubt what you're dealing with is an infarct or just an ST segment depression, ACS versus an infarct, you can just have the leads on V7, V8, and V9, which is in the interscapular line, posterior dorsal interscapular line, and that will show an ST elevation. And these patients, when revascularized, either with thrombolysis or with acute PCI, you will have the same benefit as patients where this diagnosis was missed. Again, to physicians, the commonest misdiagnosis of myocardial infarction is dorsal wall myocardial infarction. The clues are prominent R wave in V2 in the presence of an upright T wave in V2. This is a 55-year-old person, presents with nausea and chest discomfort. So the diagnosis entertained, was it acute pancreatitis, pericarditis, acute coronary syndrome, or pulmonary embolus? So again, we would like to draw attention to this simple sign, which was described way back by Shamroth, which is called horizontality of ST segment. If any of the leads hug the baseline, normally the ST segment is supposed to be either smooth upstroke into the T wave, it merges, whereas if it hugs the baseline and it's very horizontal with a sharp uptake of T wave, that should make you suspect that this patient has an acute coronary syndrome. The second clue is a sudden diminution of the R wave from V2 to V3. The total QRS voltage suddenly comes down. All the company it keeps suggests that this patient has an acute coronary syndrome and actually had a tight LAD lesion. This is what I meant. In a normal patient, the ST segment smoothly merges into the upstroke of the T wave. Whereas in patients who are having an ischemia, there will be a sharp upstroke and a very horizontal STT angle. Now, please remember, this doesn't mean always it's acute coronary occlusion. Severe subendocardial ischemia in a hypertrophied ventricle, severe subendocardial ischemia in a person with HCM can have all these manifestations. It's a physiological equivalent of a severe subendocardial ischemia. the same patient, left untreated, will lose all the R waves, and at the end of it, you will be left with a large myocardial infarction if it is not treated. Again, this is a patient with a left bundle branch block, presents with chest tightness for a brief duration, left bundle branch block morphology, which limits the diagnostic capability, but ST segment elevation that is concordant to the lead where the QRS is also upright should make you suspect that this patient has a lateral wall myocardial infarction, and he should be given either a lytic therapy or referred to a cath lab where the vessels could be open. So whenever you have an ST segment in a left bundle branch block with an upright QRS complex, QRS is upright and the ST segment is also upright, concordant to both the QRS, the patient who didn't have much of symptom, he came for a routine evaluation. However, he came for evaluation because 3 days prior, he had a mild chest discomfort while he was traveling. And the relatives brought him for a detailed evaluation. He's a diabetic on metformin and was on aspirin. He came for a master health checkup, and then would you do a stress testing or admit and observe, or would you refer him to the cath lab, or what will you do? Now, the reason why this ECG was put in was, again, when you see this kind of a T wave, symmetrical T wave inversion, which is a biphasic T wave inversion, in any of the precordial leads, this indicates the patient has a critical LAD lesion, and you should not do a stress testing on these patients. Not only that, you don't need further testing. This particular sign of a biphasic T wave indicates a large area of underlying hibernating myocardium, which means if you revascularize the patient, the LV function will completely normalize. So this is the importance of clinical observation. A simple electrocardiographic sign tells you a large area of myocardium is at risk, it is ischemic, and the muscle is completely viable, and you need to immediately revascularize. This sign is described by Hein-Wellens, and it's called Wellens sign. Two morphologies are described in V2 to V3, either a symmetrical T wave inversion arrowhead or a biphasic like this, up and down. If you see this, please do not put them through a stress test. Refer them for an angiography and revascularization. So Wellens syndrome, the description is a deeply inverted or a biphasic T wave in lead V2 and V3. It's highly specific for a critical stenosis of LAD. Generally, when the ECG is taken, patients are free of angina. They don't have chest pain. This has happened 2-3 days prior. And they are at high risk of extensive anterior wall MI, and mortality risk is high. Please avoid stress testing. There is a high risk of MI or cardiac arrest during stress testing in these patients. Now, this is again a patient who presented to our casualty with chest discomfort. The ECG looks apparently normal, but there is a minimal ST elevation in lead 3 and AVF. Now, whenever you have this kind of a minimal ST elevation, you are left guessing whether it's a true myocardial infarction or whether it's non-specific. So whenever you have a suspected myocardial infarction of the inferior wall and you are unsure, look at lead AVL. If AVL shows a horizontal ST segment or ST segment depression, this indicates this is real. This is not non-specific. So AVL minor ST depression in the presence of ST elevation in inferior wall confirms that this is an acute myocardial infarction, and you don't need further testing. So whenever there is an ST elevation accompanied by, you need to compare this against the TP segment. There is an ST depression. You need to take them to the cath lab. This was originally described by Birnbaum and Skarlowski. Whenever there is a doubt of an inferior wall infarction, they suggest look at AVL. So ST depression in AVL is a very sensitive marker for inferior wall infarction in the acute stages. Now, whenever you have patients coming to casualty with bradycardia or even complete AV block, this is one P wave, there is a AV conduction disturbance in this patient. And if this patient has a tall peaked T wave, the diagnosis is hyperkalemia. And the reason why this ECG is important is suppose you're in a remote place and your lab is going to give you a result in 3 hours time. Even before you get the potassium results, you need to start acting, and this patient would immediately respond if you start anti-hyperkalemic therapy. Immediate calcium gluconate, flush with saline, then in the same line sodium bicarbonate, and if possible give Kxalate. For the bradycardia, you need to start treating appropriately. This is you can completely save the patient if you start treating the patient even before you get the lab report. This signs can progress to asystole. If you fail to treat this, within hours they go on to a flat line, and even putting a temporary pacemaker may not help this unless you correct the hyperkalemia and acidosis in these patients. So predominantly at lower levels of high potassium, that is potassium in the range of 5.5 and 6, you get predominant T wave changes like peak T wave. As the potassium climbs, you start seeing P wave flattening, and P waves sometimes flatly, they disappear. And when the potassium becomes more than 7, it leads to bradycardia. And this is not always one-to-one relationship. These changes can happen at a lower level of potassium when there is severe tissue acidosis. Even 7 milliequivalent can kill a patient by causing asystole, ventricular fibrillation, and worst is pulseless electrical activity. You may have a pacemaker, but you won't respond to pacing in these patients. So you need to have, and one of the clues is a patient with chronic atrial fibrillation suddenly will develop sinus rhythm. That is a sign of severe hyperkalemia. The next is a patient, 64-year-old male, known diabetic hypertensive, presents with severe heart failure. And he had prior revascularization, then thrombolysis, is on DIG Lasix and sacubitril valsartan, beta blocker, and ivabradine. And this is the ECG that was taken. So the resident who rounded on the patient increased the dose of ivabradine to 7.5 BID. Actually, this was mistaken as sinus tachycardia. What you see is multiple P waves. 1, 2, 3. For multiple P waves, there are less number of QRS complexes. So what this patient has got is atrial tachycardia with block. And one of the commonest reasons for that is digit toxicity. So the way to treat this patient is to stop the digoxin and give appropriate therapy, either in terms of antiarrhythmic therapy, or if this patient being unstable, it makes sense to immediately cardiovert this patient and restore sinus rhythm. So this is often mistaken as sinus tachycardia. And please understand, when you increase the dose of ivabradine, you will not correct this problem, but you can prolong the QT. And therefore, it is not an appropriate choice for this given patient. What I would like to impress upon is patients develop severe heart failure not due to very rapid tachycardias. Very rapid tachycardias produce hypotension, syncope, and palpitation. But slow tachycardias in the range of, say, 110, 120, but persistent, incessant tachycardia very often leads to persistent LV dysfunction and tachycardiomyopathy. So in these situations, patients don't complain of palpitation, but rather complain of dyspnea and fall in urine output. I think I've shown this. This is from our neurology center. Evaluated, this is a lady who was evaluated for slurring of speech and weakness of the right upper limb. Recovered. CT brain was normal. She's a known hypertensive. Was a mild carotid plaque beyond the left bulb. No significant stenosis. So this patient was admitted under neurology, started on aspirin, statins, and then discharged. What was missed again in this patient was, I would like you to see this, same patient, lead V1. I put it, the first ECG is at the bottom panel. The present ECG is now. P, QRS. Whereas here, P, another P. P, another P. P, another P. The second P gets hidden as a terminal notch in the QRS. So you have a 2-to-1 atrial flutter in this patient. An elderly lady, hypertensive diabetic, and presence with TIA with an atrial arrhythmia, you should consider atrial fibrillation, transient AFib in the diagnosis. Unfortunately, this patient came back 3 months later with a dense hemiplegia, and it was most likely an AFib-related hemiplegia in this patient. This is, Munna, please stop if there are any comments. I was under the impression that there may be an audience response, but please go ahead. Munna, Dev. Am I audible?
Yes, sir. Absolutely audible, sir.
Okay.
Amazing lecture, sir.
If there are any comments, please interrupt. You can or show something. I had prepared this as an audience response system. I didn't realize there's no ARS.
If there is any query, we'll put in, sir. Sure, sir.
Okay. This ECG was taken from a medical ICU. Patient was admitted with urosepsis, hypotensive, started on fluids, NORAD, was on antibiotics, and then this is what the monitor showed. A very nasty rhythm. So would you give IV amiodarone, magnesium sulfate, or what is the next choice? This patient was given magnesium sulfate because it's a polymorphic VT. For urosepsis, this patient was on levofloxacin. Levofloxacin can cause prolonged QT. But what is underlying is patient has an AV block. Sepsis, AV block. This is AV block triggered polymorphic VT. So this patient should be rushed to the cath lab. You need to insert a temporary pacemaker, stop Cipro or levofloxacin in this patient, and correct the acidosis. With these things, there's quite likely that everything will improve because there is no sequential management of first, let me correct this, there. All of them need to be simultaneously addressed. Bradycardia needs to be addressed by pacing. Hyperkalemia needs to be addressed. Acidosis needs to be corrected. Offending drug, which is a quinolone, needs to be stopped. Everything has to be done simultaneously in this patient. This lady was transferred after a medical termination of pregnancy, and she presented a couple of weeks later with tachycardia, and blood pressure was 140/50. She's confused hemoglobin of 9, TLC of 9,800, creatinine of 1.8, and potassium of 4.8. And this is the electrocardiogram. V1, lead 1, 2, 3, AVR, AVL, AVF, and V1 to V6. Now, if we walk through the ECG, we can see a PQRS, but a very dramatic T-wave inversion with a prolonged QT. And this patient presented with this kind of a symptom. What should be the next step? Actually, whenever you have a febrile patient who comes to us with a wide pulse pressure One of the things is peripheral vasodilatation. But in this patient, considering all the clinical picture, she was found to have an aortic regurgitation, and there was a cerebral, these are called typically cerebral T waves. Patient had a transient cerebral embolism, and these are called cerebral T waves. And this is typically seen in patients with any form of cerebrovascular accident. The clues are QT is prolonged, symmetric arrowhead T wave inversion, but you seldom see Q waves. But in this patient, the additional clues are wide pulse pressure suggestive of AR, post MTP and fever, it's endocarditis. You can see junctional rhythm coming up. That indicates that there is spontaneous automaticity at the level of the roots, aortic root abscess. And finally, the diagnosis was infective endocarditis, aortic root abscess producing severe aortic regurgitation, and an embolic CVA, which resulted in those ECG changes. So if you put everything together, the reason why this is important is just giving antibiotic will not be helpful. Once there is a root abscess, without delay, this patient needs to be transferred to a peripheral tertiary care center where surgery is possible, because antibiotic alone will not enter the fibrous tissue to clear the infection. The aortic root is a fibrous structure, and that needs to be surgically corrected. 47-year-old person with chest pain, history of smoking, and occasional alcohol. Presence with chest pain after a brief febrile illness. And this patient was quite symptomatic in terms of both chest pain. He was tossing and presented with breathlessness because he was little tachypneic. The clue here is the diagnosis. Whenever you see a tachycardia with diffuse STT changes, and the PR segment in AVR is elevated and compared to the ST segment. These things, so what is this? If you see an ST segment is depressed, but PR segment is elevated, and that should make you suspect with a diffuse ST elevation, it should make you suspect a pericardial effusion. Now, the reason why this is an important differential is, if you don't have this in your differential and you give a dose of heparin and antiplatelets, quite likely the patient will develop tamponade because of an increasing tendency for bleeding. Certain conditions, even with near normal platelet count, there will be a higher tendency for bleeding in the pericardium, like if there's an autoimmune disorder or dengue fever, or some of them which are associated with increased hemorrhagic tendency of some of the viral fevers. The beauty is, once you recognize and take the fluid out, the QRS normalizes, the ST segment slowly comes back to normal, and everything results in a satisfactory outcome. This patient had transient dizziness and was referred with the idea of getting a pacemaker because someone noticed a pause in this. This is an ECG where I would like to draw attention. Whenever there is a pause, this is a normal PP interval, and then this P to this P, there is a very long delay. One of the commonest thing that gets overlooked is a hidden P wave. And the best place to look at it is in the beat that precedes, that is the pause. The first beat of the pause, the T wave will be distorted. So compare the morphology of the T wave of the previous beat and this beat. You find that this T wave is different from this. It is different because a P wave gets buried here. This is a very early APD, which comes very early before the AV node has recovered, and therefore it gets blocked in the AV node. Then it takes a long time for the sinus node to recover, and that is the reason for the pause. So one of the common reasons for long pauses in a given patient is blocked PAC, and this doesn't need any treatment. The patient is symptomatic, you can give a beta blocker, it will suppress the PVC. Or if it's very refractory, you can even start antiarrhythmic therapy for these patients. This is a patient with dilated cardiomyopathy, had palpitation, and he was admitted in the hospital, and on the monitor, this was recorded. EF of 45%, his resting pulse rate was normal, blood pressure was normal, he had a prior coronaries which were normal, coronary angiogram, and this was the reading. So how would we treat this patient? We had a very interesting discussion in the previous session about the role of ICD. Should we give an ICD, or Dr. Panja raised the issue of doing an MRI or increase the beta blocker? Now, this is important. Very often in Holter monitoring, this is a QRS, this is a QRS. Whenever you see a baseline drift or a wander, you should suspect that there is an artifact. And the clue to that is you need to march the rhythm backward, measure the caliper, this RR interval, go back in time and look at the next RR. So there is a QRS hidden here. This is called a spike sign. It looks like a spike in between. You cannot have a depolarization and depolarization again. It has to be followed by repolarization. So you can see some spikes. The clue here, for some reason this doesn't move. Sinus sign is in an ECG, one of the frontal leads generally shows normal PQRS. Spike sign is what I showed you. Tiny spikes can be marched along among the white QRS. You may see this. Sometimes when the artifactual QRS is wide, you can see the native QRS falling there and it causes a notch. So that's called as a notch sign. So you see these spikes and notches, and if you take a caliper and march from the QRS, you'll be able to march within the white QRS, and this shouldn't be mistaken as a VT. This is just an artifact, and you need to take a decision regarding, you can ignore this as far as this is concerned. It's an artifact. The way to avoid, yes, please.
Sir, because short of time, I think we need to conclude.
Yes, I'll conclude with this. The way to avoid this is please make sure that the telemetry electrodes or Holter monitoring electrodes are not placed on the muscle, but on bony points. You'll avoid these problems. I think I'll stop there, and thank you very much for the patient listening.
Thank you, sir. Thank you for your excellent deliberation. You are always a great teacher, and it's quite very good for us to learn from you all the tips and tricks of ECD nuances. And I thank Dr. Narasimhan once again. Dr. Bera, do you have to give an input?
Munada, there is a question from Dr. Jamil Abdul that do we have to give synchronized or asynchronized DC cardioversion in torsades? So if sir can take that.
Yeah, it's async because if you try to synchronize, it will delay the therapy. It keeps on changing the points, so you cannot synchronize. It's a defibrillation.
Yes, sir. So absolutely, because in the guidelines we have that any patients with a VF or polymorphic VT should be treated with defibrillation. Yeah.
Thank you.
So, thank you both the chairpersons and Dr. Narasimhan. Dr. Narasimhan, once I take 10 seconds, Dr. Guho. Once a sponsor sent baskets of fruits, vegetables, prawns, and mutton to my house, and I found that my refrigerator hadn't got enough space. So I feel so frustrated and inadequate each time I listen to Dr. Narasimhan. Why God didn't give me enough brain space to receive such fantastic information and to store them? I mean, I feel so inadequate. Thank you, sir, but we need to listen again and again so that you give us in quotas, in small aliquots, so that we can digest it.
So we try to assimilate that, Shomitra. Thank you very much.
Thank you. Thank you.
And Dr. Narasimhan, thank you for your gracious presence.
Thank you. I enjoyed it. Thank you.
17th year, in each year you have come to the UCD. Thank you very much.
Thank you.
Yes.
We need to.
We are going to the
next one. Yeah.
Shantanu, we are going to the penultimate session, that is session 5. which is mix and match of 3 clinical subjects. The first is on dyslipidemia beyond statin, and to chair no other than Mr. Dr. Sahni with us. And may I request Dr. Rajarai also to co-chair with Dr. Sahni. And the speaker is one of the fantastic speakers today in India, Dr. Prakash Hajra.
Thank you, Samitra.
Dr. Sahni, please.
Sure. Thank you, Dr. Samitra. Thank you, Dr. Shantanu, for giving me this opportunity to chair this important session on management of dyslipidemia beyond statin. As we know in clinical practice, many times statin is not enough, either they are intolerated or they are unable to reach the goal. And we have a lot of evidence now from the non-statin drugs to be added to this. So instead of having a high-intensity statin therapy, we may change the term to now high-intensity lipid-lowering therapy for the management of dyslipidemia. And beyond that, with high triglyceride patients with remnant cholesterol, probably will need some other drugs like EPA also to be added to control the dyslipidemia and reduce the cardiovascular events. I thought to speak to this important topic, we have Dr. P.K. Hajra to discuss, and we'll have a question answer after that. Dr. Hajra, please.
Thank you very much, sir. Why do we get heart attack? We do get heart attack and remodeling because we have cholesterol and inflammations. And from this study, the 56th day of mice life is equal to 10 years of human life. And we get remodeling, dilatation of the heart because we have cholesterol inflammations. If you ligate the LED of the mouse by balloon occlusions, and the very first hour, 21st day, they're still active, eating, jumping around, but the same doesn't happen in female. In a female lady who gets myocardial infarction due to cholesterol and blockage of the artery. And at 56 days, the mouse gets remodeled, the heart, they get their shape back, but the human do not get it back because of the cholesterol and inflammation. It is there in the mummies thousands of years ago. So atherosclerosis is not today's disease. Diabetes is not today's disease. Hypertension is not today's disease. It's not like a syphilis which has been eradicated or polio which has been eradicated. If you start therapy, and if you think beyond statin, if you think the modern day therapy is not only statin, there are many therapy beyond statin, which includes lifestyle modifications, yoga, food and fruits and vegetables, but that's not sufficient in many people, especially those people who have a high state of LDL cholesterol. And if you introduce this newer therapy, for example, PCSK9, if you give them for 2.5 years, you delay the onset of CAD, progressive atherosclerosis, other cardiovascular event by 1 year, even 3 months therapy, you can delay by 37 days. Now, here is a story. I love telling you a story, and the story is Goldstein and the Brown. And the Brown was very curious guy. He started meddling with the transmitter. He got a lucky guy, and he was not a Nobel Prize winner. He was Dr. Stadman in Dallas. And these two guys, they have a beautiful partnership in Mass General Hospital, 6-year-old female. This girl, she used to play around and used to get trauma on the knees, and the cholesterol used to come out from the butt. And they used to get bumps and these xanthomas on her knees. And on the other side, there was another patient. We know that every cell can synthesize their cholesterol, and they get their feedback. And this guy did not get a Nobel Prize, but he changed the whole scenario of treating atherosclerotic disease because he developed a drug which can prevent the HMG-CoA reductase inhibitor, so decrease the intracellular cholesterol. But once you have more cholesterol in your cell, then it gives a negative feedback, and your LDL receptor goes down in number. So you get less LDL cholesterol, so you have to knock out this LDL cholesterol number 2 by blocking them by PCSK9 or silencing the gene for LDL cholesterol. The statin do not work there directly, but as the intracellular cholesterol goes down, there is upregulations of LDL cholesterol. So today's discussion goes back to the historical statement when the statin was discovered. I think there is no doubt that the discovery of compact in the first statin by Dr. Endo from Tokyo was one of the great discoveries in the history of modern science. Statins are to cardiovascular disease that penicillin was to infectious disease. They are one of the most important, if not the most important advances in cardiovascular medicines. The millions of people whose lives will be extended through statin therapy owe it all to Dr. Akira Endo and his search through the fungal extracts of the Sankyo company. This is the Nobel Prize winner of LDL cholesterol receptor discovery, Michael Brown and Joseph Goldstein, and they won the Nobel Prize together. And what was their statement in the Nature's journal? Once they got it from Sweden, and in Science, they said 25 milligram. 25 milligrams should be the ideal LDL cholesterol because every cell in our human body, including brain, can synthesize their own cholesterol. So you need not bother about the side effects. So if you have polio, you have to treat all, and we have been able to treat and eradicate polio by treating even the people who do not have polio. Smallpox, early detections. So similarly, early detection of atherosclerosis, vaccinate all. Iodized salt, forget the population who have normal iodine, treat all and save all from goiter. Some may be overtreated by harmless interventions like statin, PCSK9, azithromycin, or EPA, but this is not going to kill you. The theory is very simple to go beyond statin. If too high cholesterol causes progression of atherosclerosis, why too low will not cause regressions? And no, it's not like hypoglycemic event or hypokalemia or due to hypertensive drugs, which is going to kill you because of the side effect. Nobody is going to die because of excess statin, high dose statin, PCSK9. But inappropriate therapy is not been recommended by any scientific forum, any guideline. And why we are different from the animal? Have you ever seen a jockey who is riding on a horse dying suddenly due to sudden cardiac death on race course, or a deer who has a cholesterol, very low cholesterol, or a baboon who has a very low cholesterol dying suddenly when they are running? But it does happen in human being, and that is due to LDL cholesterol. Maybe many things beyond LDL cholesterol, like ApoB, we have a lipoprotein A. There is no doubt this is the only thing for causative reasoning or a causative agent for progression of atherosclerosis and regression of atherosclerosis. Whatever you have in your scientific literature like tobacco, diabetes, hypertension, elevated homocysteine, elevated CRP, or oxidized LDL is just a bystander. So if PCSK9 do not decrease the CRP, don't bother about it because it's a bystander. And there are many theories, epidemiological, biological, plausibility, RCT, FH, animal studies, and dose-response relationship that going beyond statin by inviting other therapies. There are so many, but most of them are historical and they cause a lot of side effects. Cumulative exposure of LDL drives ASCVD. So it is the total LDL time, and if you have a very low LDL for longest period of time, starting early childhood, that is going to give best benefit. It is possible to think beyond statin by PCSK9, azithromycin, bempedoic acid, and lifestyle modification exercise. In the future, we have many genetic things. We also know that this gradient of effect is also very, very early in ACAs. You have a gradient even if you have a very low LDL cholesterol. And there are many studies to prove that, CTT meta-analysis, but improve IT. You can fall back on azithromycin if somebody cannot tolerate, but it takes a lot of time. And the comparison was with simvastatin. We do not use simvastatin in today's life. So it has got historical importance, but since it is very economical, without any side effect, we cannot forget azithromycin. So azithromycin comes as a second on the top of statin, then bempedoic acid, who are intolerant to a statin, or it can be given in a combination of triple drug combinations, oral pill. So how much this statin can do to your human body? Moderate statin, high intensity statin, the recent study published in ESC, in the Da Vinci study, only 27% of the people they take high dose statin. PCSK9, high intensity 75, PCSK9, high intensity statin, azithromycin can reduce the LDL cholesterol by 85%. Just think opposite. Why not start from de-escalation to escalation rather than escalation only as step care approach? So if you start with PCSK9 inhibitor without statin, there is no harm. You can always combine azithromycin statin when they are leaving the hospital, or you believe in the conventional way, non-statin, statin, and this kind of therapy is not. I don't think there is a huge difference if you start with PCSK9 inhibitor in ACS, because PCSK9 inhibitor beyond statin can reduce LDL cholesterol rapidly, and statin takes time. So statin is a gold standard, and you have to look at the other side of the moon. Statin increases coronary calcium, LPA neutral, increases diabetes, though not significant, hemorrhagic stroke, myopathy, statin resistant, it increases the rhabdomyolysis with. So statin is not a panacea for everybody. And we look at this trial, 4,444 patients. It was done when there was no opponent. So it scored, the reduction of mortality was huge because there is highly significant molecule, but there was no opponent. Now, the recent trials like PCSK9, alirocumab, evolocumab are tried on standard of care, which is very, very elegant and very, very contemporary. So, ladies and gentlemen, these are the therapies available, and there are a lot of data got generated on bempedoic acids, lot of data on PCSK9, siRNA is coming to India next year, and the gene silent antisense antibody will be available very soon. We also know that cholecalciferol is very good. It reduces the other forms of non-LDL, the glucose, but it is not available. So this is a recent study, the fixed dose combination of 3 drugs, statin, ezetimibe, bempedoic acids, and it does reduce the LDL cholesterol significantly, 1.5 millimole per liter. It does reduce the apoprotein B and HSCRP by 35. So what we have missed in PCSK9 or other therapy like your inclisiran can be complemented by bempedoic acid. And these are the newer therapies, NGPLT3, EPA, and things are getting better and better because we know that it reduces the platelet reactivity, immune cells, anti-inflammatory, immunological biomarkers. So there are more studies are available to think beyond statin. Now, every guideline is changing very fast, 55, 50, 17, 70. What I recommend here, you change your thought process very fast. We stay ahead of the time because there are many people who lose their life if you do not reduce their LDL cholesterol, do not follow the recent guideline. So do not. It's not a single. It's not a gospel truth that 70 is the ideal LDL cholesterol. All human beings, some may be low, some may be high risk, but some low risk may be at high risk of dying because of comorbidity. So the physicians, they have a different perspective. If you give them and advise to start 80 milligram, they start 40 milligram. If you give them 40 milligram, they will start 10 milligram. So it is a human mind that higher dose of statins are usually not being practiced, and the compliance and adherence of the statins is not so good in our country, and it is same everywhere. So PCSK9, which is injectable, people never ever forget an injection, especially when it's given by another caregiver. You can miss your statin, but you will never miss your PCSK9 or gene silencing like inclisiran, 2 doses per year. This is again elegant thing, and you should always aim higher. And these same MPA PCSK9, statin, ezetimibe, bempedoic acid, PCSK9, inclisiran should be there in our armamentarium to treat difficult to treat familial hypercholesterolemia, and it only takes one black swan to disprove the theory that all swans are white here. That is the price of the non-statin like PCSK9 gene silencing. There is a meta-analysis available. There is imaging things available. You can demonstrate the effect of thinking beyond statin by PCSK9, GLAVOX study, OCT study, that it does reduce the necrotic core on the NIR spectroscopy. The thickness of the fibrous atheroma increases, and it protects. So, ladies and gentlemen, it's the time to think or to go for immortality by polypharmacy. And if you have a statin and non-statin, most of the things due to atherosclerosis can be conquered. Thank you for your kind attention. Over to you, sir.
Thank you, Dr. Hajrao. My co-chairperson is there. You want to make any comment? No, then.
Dr. Rajana, please unmute yourself.
Okay. Dr. Hajra, I see that you have very nicely discussed, very elegantly, as Dr. Samitra said, that you're a great speaker with such a great, photographs you have correlated so well, make it so easy to understand that the non-statin drugs are very important. And as you know, the new guidelines have come now that is class 2A indication that starting PCSK9 inhibitor and ACS, but those who are on statin and ezetimibe and not getting the control, and they're still getting ACS. But I want your opinion about as you know, the literature is now moving towards the triglyceride, and we are now looking into that. There is a lot of remnant cholesterol IDL, LDL cholesterol, VLDL lipoprotein, they are more atherogenic than LDL particles, and they need to be addressed with even up to 500 milligram of triglyceride. So that with that, the reduce-it trial has shown us the EPA part, not the EHA. So what is your opinion? When shall we start this drug in the management of acute coronary syndrome? Immediately, as I told you earlier, the old thought of only intensive statin therapy to be initiating treatment may be changed with now intensive lipid lowering treatment from day one, putting them onto ezetimibe and statin. For example, if a patient has a baseline LDL of 130, we know high dose statin will only reduce by 50%. It cannot reach below 55. So for day one, we can start straight away with ezetimibe 10 milligram. Then we know we'll be able to achieve by 65%. So where do you place EPA now?
You said it all, sir. It should be started as soon as possible and as soon as it is available in our country. The problem is it is very, very attractive. I never seen a trial which has got so many zeros for their p-values. It beats the ARNI trial, it beats the SGLU trial by p-value. Sheer p-value strength is so robust with this reduced ID trial, there is no doubt it's going to save life by reducing the ventricular tachycardia, sudden cardiac death. Only drawback is hemorrhage and atrial fibrillation. So if it is available, there is no harm trying this medicine who has got something beyond cholesterol like triglyceride. And we have something in our hand already, like PCSK9 inhibitor, which can take care of non-LDL like apoprotein, lipoprotein A, the remnant particle, etc., etc. On the top of statin, these are the new drugs. If some people can afford it, should be initiated on the very first day, very first contact. And as I said, it is not only precision medicine, it is a personalized medicine and preference medicine for some people, and may not be any medicine for some people who cannot afford it.
That's right. So the lipoprotein little a, we raised that point. I think is no recommendation. Every patient should have at least once their LPA estimation. And we know a lot of patients on statin do not respond to the dose, like for 50% reduction with high dose, we do not see sometime. It is probably because of associated high lipoprotein little a, which can cause some partial resistance to statin. So addressing LPA probably in future will be a way to forward. And we know only PCSK9 is available, but Horizon trial is going on at the moment. So the management of dyslipidemia should not stop at only an LDL. We should look for remnant cholesterol. We should look for LPA also to give a clear cut or overall reduction of cardiovascular event in dyslipidemic populations. Any further
one query or rather one comment. In the reduce-it trial, cardiac events were reduced to the tune of around 20 to 30%, but the survival advantage was not there. There was no mortality benefit. So should we be so enthusiastic about reducing the triglyceride right now in patients with ACS?
I think Sumitro, Anjanda, and Dr. Rajarai, they can comment because
I think on the strength trial, as Dr. Sawhney himself also explained, the strength trial was a negative trial after the reduce it. So eicosapentaenoic acid and docosahexaenoic acid, how they interplay, at what dose, that is a bit controversial. And as Dr. Hajra said, too many zeros for the p-values, it itself raises a suspicion. With all the contemporary management, how come another sort of soft target with a soft medicine can cause so much of significant thing? Something somewhere is fishy. I am talking it literally. Something is fishy about these fish oils. So, okay, let's wait for the fish to get the ashes out. Okay. So
this was supported by the Jellis trial from Japan, which again gave similar results. Dr. Shantanu, it gave similar results. There were no difference. Only difference was they used 2 grams because the intake of fish in Japan is high, so they have high EPA level already. So they only needed 2 grams and they showed similar results. So it looks like that there has to be some reason for that.
Some reason, yes. So it's only the conclusion. I think we should eat more fish first, and then we can try those tablets or capsules. So let's go 50.
My question, I wouldn't say it's a question, it's a comment. I would say Dr. Hajra is saying what he's saying is you can replace statin by PCSK9 inhibitor. I believe that pleiotropic theory with statin has gone out of the window. I don't think that LDL cholesterol, I think, is the most important one, which needs to be done to a certain extent. And as per the even the SC 2019 guideline, where you need to achieve in very high risk mean any patient with documented coronary artery disease is a very high risk as per ESC, where you need to go down to around 55, and with 55 milligram LDL cannot be achieved in most of the time. In maybe in 50 or 60% patient with a statin and ezetimibe, you need to give a PCSK9 inhibitor. But the problem is really the expense. It's a hugely expensive medicine, and you need to consider the expense and benefit as well. But Prakash, do you think that it's going to replace statin in the future? This PCSK9.
That's a very, very important question. I'll tell you one story more. I love storytelling. The mayor of London has decided to give inclisiran to people of London for next 5 years free of cost. Because in NHS, the cost of having angioplasty, bypass surgery, hospital admissions are tremendous, a burden to the society. And people do not take statin if it is free of cost. So forget about high dose statin taking every day. Nobody will take statins for every day, even if it is given free of cost. So what they have decided to give inclisiran to 45,000 people in London without any statin, because statin is a problem to take. But if you give a jab, people will never forget, because these jabs are not available they have to come to a doctor or a caregiver. So jabs are assured that you will get a jab. And if you can demonstrate without statin, inclisiran can reduce the national morbidity and mortality of cardiovascular disease, you can think. But we have to wait for the data.
Yes, Braunwald usually predicts very rightly, and Braunwald predicted 3 years ago that an annual jab of inclisiran, like flu jab, will have a tremendous effect on the societal health, on the world
Who knows
health.
Braunwald's LDL number? I can tell you an LDL number of Braunwald's 23 LDL cholesterol. He's taking statins since he published the first report on 4S.
Yes.
It is Jagat Narula's statement that he takes statin. It doesn't believe any other thing. He is not on PCSK9. Just statin can do wonder in some group of people, but may not work in some group of people.
I think we should.
Dr. Hajra,
yes.
Inclisiran had only completed phase 1 trial. We don't have, we just know the safety data, but we don't have any outcome data as yet.
Yeah.
Outcome data has been presented last year ACC.
Yeah, but
that
was a small figure.
Yes, small. Orion 11 by Dr.
Very small figure.
Yeah, a small study, but I think we are waiting for
All
that.
good things must come to an end. Dr. Shantanu is getting restless.
Right, this is already, we have exceeded the time. It's a wonderful discussion. We can discuss for hours. We can discuss for hours on lipids, but every good thing should come to an end. Shaumitra, please.
Yes. Now we have the pleasure to invite two of the most sophisticated past CSI presidents, Anjan Lal Datta and Mohanan ji.
Mohanan is not past president.
I'm not past yet.
Going to be passed within 3 months. So two most sophisticated presidents of CSI, Dr. Datta and Dr. Mohanan, to take the stage, and for next half an hour we will have I think one of the most exciting session of these 2 days bonanza. Please introduce your panelists, sir, and go along with them, both of you. We have got 3 people here: Devabroto, our current secretary, Dr. Devdatta Majumdar, and who is the other one? Dr. Imran Ahmed, of course, he is there already, fully ready. So let's go.
Over to you, Dr. Datta.
Yeah, good evening, everybody. Thank you very much for this exciting session. We have 3 panelists who will be discussing on 3 important aspects of SCS management. To start with, Dr. Imran Ahmed will be talking on the SCS management from medical point of view. Dr. Devdatta Majumdar will be talking on SCS management in the presence of atrial fibrillation. And Dr. Devabroto Rai would be talking on SCS management in the PCI background. So let us start with Dr. Imran.
Good evening, everybody. I'm audible.
Imran is the Associate Professor of Cardiology, Medical College, Kolkata.
Right. Sir, I think I'm audible.
Yes.
Good evening, everybody, and special thanks to Dr. Goa and the UCD team for giving me a chance to speak. and especially from Dr. Gu, I've learned. I'm working with him in, as you can say, he's the head of the department medical college. Now, up from the very important session which we had with Dr. Hazra on the lipid therapy. Now, when this lipid therapy is failing, then we come to this ACS. So now in this, I think half an hour, very important point. Now, I think the topic is actually a panel discussion which we are going to divide among all, I think, 3 speakers with Dr. Datta, they're chairing. It's on the antiplatelet therapy as such in ACS. Apart from the other management, it's antiplatelet in which we have to look around. Now, my point here is if I've been told to speak on the fibrinolytic therapy, whether non-interventional therapy. Now, this is so very important, especially in this UCD conference. Apart from the cardiologists who are now in part of the panel, it is a lot of physicians who are there in the ground level who are treating coronary artery disease. And for them, this topic is also so very important. Now, I'll be not putting up slides. I'll just put the gist of my matter so that it goes on direct head-to-head to all my audience. Now, the ground reality, as I said, is that nearly 3 million STEMIs are occurring in India per year. Now, that's 3 million STEMI. And out of the ACS, 40 to 60% are STEMI. So you can understand the acute coronary syndrome burden in India. And compounding is that 18% of or 20% of the population are in the middle income group or above, and the rest are in the low and very low income group. Now, if you understand the burden of this problem, if you take the STEMI, which is the highest mortality, now in that case, only 50% are receiving some form of reperfusion. So 50% are not getting any reperfusion, 50% are getting reperfusion, and you can imagine those who are getting the ideal reperfusion, that is the PCI and angiography, that's even less proportion. In fibrinolytic therapy, whether it's streptokinase or TPA or retiplase, now the problem with fibrinolytic therapy is that the limitation is that the benefit, if you know, if it's less than 3 hours, it's quite good from the onset of symptoms. But the problem is that it's failure to achieve TME3 flow. 40 to 50% TME free flow is achieved in the IRA with fibrinolytic therapy. And then the re-occlusion rates, which is around 5 to 15%, there's a re-occlusion rate. So the importance of, even after fibrinolytic, going to an angiography, doing a pharmacoinvasive therapy. These 2 points support the hypothesis that just aspirin is not enough. So we are focusing on antiplatelet therapy in ACS without any intervention. So just aspirin is not enough. You need to add other P2Y2 inhibitors. So the recommendation of antiplatelets in those patients after fibrinolysis that you have to start with aspirin 150 to 325 milligram, non-enteric coated, chewable to get effects early. Now, clopidogrel is the preference. Now, this is very important. Those who are being planned for fibrinolytic therapy, those who have not have the access to angiography and intervention, the preference should be clopidogrel, because ticagrelor and prasugrel have a relative contraindication to fibrinolytic therapy. The loading dose, of course, is 300 milligram in those age less than 75, and in 75 milligram in age more than 75 years of age. This is coming from the Clarity TME28 trial. For most patients who are receiving clopidogrel and fibrinolysis, there is no switch to other P2Y2 12, from clopidogrel to ticagrelor or prasugrel is required, except in the patients who are going for a PCI. So if it is within 24 hours, it's better not to shift into those. But if it's beyond 24 hours and if a PCI is required, then it's reasonable to switch to ticagrelor or prasugrel, particularly if the angiography is revealing high-risk features, say a left main block or an ostial LAD-LM or ostial LCX block, a lot of thrombus. So it's better to go to a loaded again with a ticagrelor and prasugrel. Now, as far as the this is according to various trials. Now, in the long-term therapy, you can continue with clopidogrel, or in those patients, especially in those patients who have not received fibrinolysis also, those just on medical therapy, and a lot of them are there in the rural setup at least, it is better to give a loading of a ticagrelor and continue with ticagrelor, because as you can see through the Plato trial, the ticagrelor potency is much more then clopidogrel. And those are the
ভাট করছে তুমি মাঝখানে ইন্টারফিয়ার করো
so now the duration of the DAPT, what is the should be the duration of DAPT in patients who have had fibrinolysis? So as whether it's on fibrinolysis or if it's on or even after stent implantation, it should be for at least 12 months. In those with high bleeding risk, it should be at least for 3 months, and then continue on ticagrelor. So those patients who have high bleeding risk, at least 3 months of DAPT, and then continue on ticagrelor beyond 3 months. And in those patients which have a ACS history for more than 1 year, and they're free of symptoms for the last 1 year, so they are considered to have transitioned into SIHD, that is stable ischemic heart disease. That's according to ACC, and therefore these patients can be continued on single antiplatelet therapy. Those who are after fibrinolytic therapy, but those who are after stent, which will be dealt, that might require dual antiplatelet therapy. And so those who are with very high risk of severe bleeding or intracranial surgery is required. At least 6 months of dual antiplatelet therapy is required. So if you have a surgery planned, postpone it to beyond 6 months of the dual antiplatelet therapy. So that's there. And the minimum of dual antiplatelet therapy after fibrinolysis should be at least 14 days. That's the ACC saying that if just the minimum of dual antiplatelet should be 14 days after fibrinolytic therapy. Suppose if the patient has a high bleeding risk, so you have to just give 14 days of double antiplatelet and continue with either clopidogrel if there's high bleeding risk. So this is regarding the therapy after fibrinolysis. And the important point is that once you need to shift from so this is another problem. Once you need to shift from clopidogrel to another molecule like ticagrelor or prasugrel, how do you do that? Now, if you are going to shift to ticagrelor, there's a 180 milligram loading dose of ticagrelor anytime within 24 hours of last dose. So patients on clopidogrel, if you want to shift to ticagrelor, you have to give a 180 milligram loading dose within 24 hours of the clopidogrel. Now, there are situations even after fibrinolytic therapy when the patient has been started on ticagrelor and prasugrel when you need to shift to clopidogrel when there is an increased bleeding risk. Now, this is another important. If the patient is on ticagrelor, the first dose of clopidogrel should be given after the 12 hours after the last dose of ticagrelor. So first dose of clopidogrel should be given 12 hours after the last dose of ticagrelor, and that should be a 600 milligram loading dose. So once you're shifting from ticagrelor to clopidogrel, you have to give 600 milligram loading dose of clopidogrel. That's 12 hours of the last dose of ticagrelor. And prasugrel, if the prasugrel has been continuing for less than 5 days, then a clopidogrel 300 milligram loading dose has to be given 24
Dr. Imran,
hours.
you are requested to wind up as fast as possible.
Right, that's it. So after 24 hours of last dose of prasugrel, you can have to give clopidogrel 300 milligram. But if the prasugrel has been continuing for more than 5 days, you just need to give a 75 milligram of clopidogrel after the last dose of prasugrel. So these are the salient points of antiplatelet therapy treatment after fibrinolysis. But of course, if the patient requires and the patient should ideally go in for an angiography and a PCI stenting, that's, I think, the next topic of discussion. Thank you, sir.
Dr. Mohan,
I think he has listed the guideline directions of managing post-fibrinolyzed patient, though we have something called TREAT trial where ticagrelor was used in about 3,700 patients post-fibrinolysis and found out that the ischemic and the bleeding. See, mind you, when we use ticagrelor in a fibrinolyzed patient, the concern was always the bleeding. But they found out in the TREAT trial, if you're delaying it by about at least 4 hours after lysis, then the bleeding complication and the ischemic complication are similar. We have, in fact, a meta-analysis of 5 RCTs. Of course, they were all smaller ones. The largest was the TREAT trial, which showed that
the bleeding and the ischemic complications are similar in clopidogrel and ticagrelor. This will come in important. I do agree. The guideline doesn't say that. The importance will be the issue of clopidogrel resistance. And if we say about 30% of them are going to have it, then we have a chance to use it at least in some sets of patients.
So you have rightly pointed out the treat trial. Any comments or clarification from the audience? Or the learned audience, rather to say. Okay, if there is not any, I can put it up simply like this, that if the patient with STEMI comes for fibrinolytic therapy, the antiplatelets to be used are clopidogrel, nor ticagrelor, nor prasugrel. Although there is a treat trial of use of ticagrelor in STEMI, but that is after fibrinolysis, not before that. The second important issue is that the clopidogrel dose should be 300, not 600, when you are using it before the fibrinolysis. The third important point is that it should be continued at least for 14 days. If there is no serious bleeding, then you can continue up to the DAP. You can continue up to 12 months. So that is so far as guidelines and recommendations of fibrinolytic therapy in the background of STEMI in terms of use of ACS are concerned. You have rightly pointed out the phenomenon or the procedure of switchover when you are switching over from Tika to Prasu or from Prasu to Clopi. So now we come to the next speaker. Let us hear Dr. Debabrata Rai, our learned close friend, Honorary General Secretary of the Cardiological Society of India, Dr. Debabrata Rai.
I think it will be Dr. Debabrata Mojumdar as per schedule announced.
Your voice is not very clear.
Dr. Debabrata Mojumdar.
You can ask either, doesn't matter. You can go ahead with Debabrata. Debabrata is also there.
You are muted, Debabrata.
Debabrata.
Yeah, good evening. Good evening.
Yeah, you can start.
Okay. So,
AFib, ACS, AFib, ACS, and antiplatelets.
Yes. So, my warm regards to all the seniors who are present here, with special regards to my mentor for the last 20 years, Professor Shantanu Guha. And thanks, Dr. Sir, for giving me this opportunity, at least to be a part of this luminaries. It's really an honor for me. I would not waste time. I would just quickly want to share my slides, if you allow, so that a discussion becomes a bit more fruitful rather than just saying. Just allow me 30 seconds time. Are my slides visible?
Yes.
Am I audible and visible too?
Both.
Yeah.
Very well visible.
Thank you, sir. The first three criterions have been satisfied. Lucky for that. So, sir, as you said, my task is a cut down, that is antiplatelets in acute coronary syndrome on a background of atrial fibrillation, which essentially means that the patient is really on a oral anticoagulant therapy, either less likely a VKA in today's date or more likely a NOAC. So my job would be to maybe juggle with these agents, 3 of them in total, and see how to go about it. Yeah, so as we all realize that entire talk, the intent of discussing all this is simply to maximize the thrombotic protection. And we are speaking of thrombotic protection in the intracranial vessels, not only, but also in the coronaries. So double thrombotic protection in that sense, and certainly to minimize bleed. See, we have all understood that bleeding is the spoil sport here. In spite of all our efforts, if the patient really bleeds, then all our efforts really goes in vain. So these are the 2 goals based on which we would have to shape our therapy. Yeah, so I thought I would, talk on these following headings, that if a patient of NSTEMI comes to me, and obviously, let me reiterate, it's well known that the background is oral anticoagulant therapy. So a patient of STEMI lands up with me, and if we can conservatively manage, how do we go about it? If we are invasively managing the patient, how do we go about it as regards to the antiplatelets and the oral anticoagulants? And the same, principle for the STEMI patients as well. Even as we speak today, most patients of ACS would be really managed by the conservative therapy, and very few really fortunate people would have an opportunity to be managed invasively, even as we speak today, and regardless of what the guidelines say. So I thought I would enlist a few of the key principles which guides the therapy and helps us understand how do we handle these three drugs. I put it as TAT, as we know, triple antithrombotic therapy. How do we handle that? So it's obvious that we all do it in our day-to-day practice, assess the ischemic risk as well as it's a delicate balance between the two. We always said, what is the ischemic risk of the patient and what is the bleeding risk of the patient? So the ischemic risk, obviously the commonest score that we are still all use is the STAT-RASC score. And the other two bleeding scores that we use, and again, as we speak, HAS-BLED is the commonest score that we employ for assessing bleeding. It's said that the ABC, scores ahead of HAS-BLED, but I have personally no experience on this. Age, biomarkers, and clinical history of bleeding as far as this score is concerned, we are all happy with HAS-BLED. And obviously to focus on the modifiable risk factors, both in the ischemic scoring as well as, more importantly, in the bleeding scoring, like abnormal liver and renal function, labile INR, those points, drugs, alcohol. If the intent is very clear, try and reduce bleeding risk as much as possible. Triple therapy duration as short as possible. We'll discuss that. Oral, whenever we are using an oral anticoagulant, the default antiplatelet, P2Y12 would be clopidogrel. In all patients, consider NOACs, excepting in mechanical prosthesis and severe MS. Otherwise, it's all NOAC, and there's no hindrance of cost anymore as far as NOACs are concerned. Consider a very importantly, target INR should be towards the lower range of normal. If it's 2 to 3, we would love to keep it at 2. If it's 2.5 to 3.5, we would love to keep it at 2.5. And the TTR would be ideally more than 65 to 70. Again, a very important point. Consider the lower NOAC regimen as has been approved in stroke thromboprophylaxis. We will speak of that also. Clopidogrel, I said, is the P2Y12 of choice as far as concomitant therapy with OAC is concerned. Use a low dose of aspirin. 75 milligrams is enough for all patients, and more so when patients are really on OAC. And for gastroprotection, we all do routinely use PPIs. Yeah, so if we've identified those principles, it's also imperative that we identify who are the high thrombotic risks patients. So obviously, patients who have already had a stent thrombus on adequate antiplatelet therapy goes without saying. Stenting of the last remaining vessel, diffuse multivessel disease, CKD, is a risk factor for both, thrombus as well as a bleed. 3 stents at least implanted, more than 3 lesions treated, bifurcation, CTO, total stent length more than 60. It's very important that we remember all these points. It's well known to all of us so that we can manage the TAT versus DAT likewise. So I thought I would quickly, this is the recent guideline, as we are all aware, ESC NSTEMI guideline 2020. I'm not here to read all of them again, want of time. I thought I would just underline few of these very important points. And that is discontinuation of antiplatelet, mind you, in patients treated with an OAC after 1 year. This is something which even I fail to, digest and maybe employ in my practice. I would have the opinion of the August gathering here. Are we confident enough to completely withdraw antiplatelets after 1 year? Mind you, in an ACS patient who've already been stented. Another point I wanted to highlight here was, had bled more than 3, then rivaroxaban would be 50 and Dabi would be 110. Apixi would be in the same dose, that is 5 milligrams. So lowering the dose of NOAC, as we mentioned. And another point I wanted to highlight was DAT, 1 antiplatelet and 1 oral anticoagulant in medically managed patients, often STEMI post 1 year. I know, and so I would, I know there's a lack of time as always. So I thought I would speak on these few lines. STEMI conservative management, loading would be aspirin 150 ideally rather than that. Clopidogrel we've already mentioned. This is very important. UFH is the anticoagulant of choice, and the dose is also important. Rather than 70 to 100, we would want to have it at 60. Refrain giving any parenteral anticoagulation if the INR is more than 2.5 is also important. And we would love to have a fibrin specific agent as the lytic of choice. Having said that, it is so important to realize that more so in patients having a background of an oral anticoagulant, we would all want to triage patients to primary PCI regardless of the time delay. So more so in here because we know that oral anticoagulation is a contraindication to fibrinolytic therapy, but guideline is something, and the practical scenario is all completely different. But yes, if you are fortunate enough to go for a primary PCI, 600 milligrams would be the loading dose of clopidogrel. No other no other P2Y12. Parenteral anticoagulation, as usual, very important. And this I feel is even more important. Do not stop the chronic anticoagulation. Neither VKA nor the NOAC, even if you are giving a lower dose parenteral anticoagulation, is a point to reckon. Very, very important. And then, NSTEMI conservative, it's all the same. I would, again, for lack of time, it's the same story here. I thought what is more important here is NSTEMI invasive management. Very, very important, because unlike as what we had all done, that dual antiplatelet loading, it's not recommended here, only aspirin loading. If a patient, obviously an invasive strategy, do an angiogram, look for the coronary anatomy. If the coronary anatomy dictates it would go for a CABG patient, don't give the second T2Y12. If a patient goes for a PCI, only clopidogrel here, obviously, because you are on a OAC, but otherwise it would have been prasugrel, as we know, ahead of ticagrelor, or parenteral anticoagulation do not stop is the same. This is the most important slide, and I think I will spare me maybe 30 seconds time to discuss this. Maintenance depth in the NSTEMI, this is something very, very new and very important that we would love to, I know you have three category of patients where the ischemic and the bleeding risk is almost equivalent. That is the default strategy. High bleeding risk, we've already said the score, and high ischemic risk also we've discussed. So in all three categories, till the duration of hospital stay, aspirin would be there. So triple therapy, TAT, 1 OAC plus 2 antiplatelets, aspirin just for a week's time, and then continue with clopidogrel and oral anticoagulant up to 1 year in the default strategy. If obviously the bleeding risk is high, you reduce that duration of DAT to 6 months and continue NOAC alone. And if obviously the other end of the spectrum, if you have a high thrombotic risk, increase the TAT for 1 month and then up to 12 months, use a DAT in the sense ki double antithrombin therapy. And this is the point of interest, that after a year, regardless of whatever you do, you don't have any antiplatelets here, much unlike what we still do. And maintenance DAT, yes, maybe a minor change from what we had in NSTEMI. Here, TAT would be for 3 to 6 months, depending on the ischemic, I mean the bleeding risk, followed by DAT up to 1 year. TAT standing for triple antithrombotic therapy, and that is for dual. And again, the same, logic, OAC, oral anticoagulant after 1 year without any antiplatelet whatsoever in an ACS patient. I think I would end here. If the patient really is subjected to a CABG, we would just have the TAT for the duration of hospital stay and followed by that for 12 months, OAC alone, and it's the same throughout, regardless of what management we employ. I think it was a pleasure to discuss such an important topic. There's always a want of time. Sincere thanks to all of you, and my warm regards to all my seniors. Thank you.
Dr. Mohanan, like to...
Thank you, Dr. Datta also. He has covered most of it, except that the naming of the NOAC study. Maybe I should do that. The Pioneer AF, the Redual PCI, the Augustus trial, and of course, finally, the Entrust AF PCI, which is the last one, which also, in fact, was trying to show a superiority over the warfarin regime. And every one of them has shown that possibly the time has now come to decide on, in AFPCI, better we will use a DOAC rather than the conventional warfarin. And as you rightly said, here the concept is less is more. So we will try to do away with the aspirin part, as the Augustus has shown us at the earliest. I will not say 1 week, but that's what the Augustus guys has done. That is one point. So keep it to the maximum of 1 month, then the 2 drugs, then finally after 1 year, just the anticoagulant. That's one. Then the next point, again, you mentioned that, see what will happen, even though conventionally it is clopidogrel always that we are using. Augustus data showed at 12% of these patients being used ticagrelor. So at the time, possibly is going to tell us about the use of the newer newer, more potent antiplatelet drugs when in using with the DOACs or even warfarin. So these are the 2 important areas I foresee in the future in AFPCI, which is not a very small group. Maybe about 10% or 12% of our patients had AF, and we are not forgetting another subgroup of DVT patients or somebody who had PE and then on oral anticoagulant. So we do definitely see patients who merits PCI in AF situation or anticoagulant situation.
Yeah, this is a very difficult group of patients because decision will depend on the trade-off between ischemia and hemorrhage.
Yeah, absolutely.
And we should remember 4 figures: 7 days, 1 month, 3 months, 6 months, 1 year. These are the different mileposts in terms of time when the antiplatelets may be reduced or may be switched or may be de-escalated.
But one thing, yeah.
Sorry.
One thing, Dr. Majumdar, we should remember, Dr. Kahali here, that all patients of AFib, you know better than me, doesn't need, this oral anticoagulant. So some of them will do fine if their CHA2DS2 score is low and doesn't qualify for OSC. So you should remember about that group also. So if we talk, then we have to talk that DAPT as usual, and in the group who needs OSC because their CHA2DS2 score qualifies, then these things will come.
Yeah.
So 2 points.
Because all patients, all patients of AFib with PCI don't qualify for OSC.
If I can make a small point, if you
Sure.
2 points is just again because of lack of time, I couldn't mention the trials that Dr. Mohanan mentioned. That is point 2. As Dr. Kahali sir mentioned, that if a patient of AFib really doesn't qualify for a OAC, then makes our job very easy. That certainly it's as good as a sinus rhythm as far as antiplatelets are concerned. So I actually wanted to highlight that oral anticoagulant part. And third point, as Dr. Mohanan pointed out, again because of lack of time, that is, even though we are always speaking of clopidogrel in combination with the OAC, we are allowed to use prasugrel or ticagrelor as a part of DAT, not TAT, as a class 2B indication in patients where we can understand whether ischemic burden is extremely high and the bleeding risk is acceptable. So not that it's completely out of the scenario in a combination of OAC, prasu or tica can be used, but yes, it is a class 2B as of now. Thank you, sir.
And most importantly, a patient of atrial fibrillation having acute coronary syndrome itself is probably, along with its risk factors, increases the risk score from 2 or above. So it is very rare, very infrequent, very unlikely that an atrial fibrillation patient with ACS will have a CHA2DS2 score less than 2. But if it is there in rare situation, as Dr. Dhiman Kahali pointed out, then obviously we should go accordingly. And the
VASC itself is an acute coronary syndrome is a VASC.
That's what I say. It may particularly in case of female or male. In any case, it is very, very, very rare that we can get below 2.
How's Debabrata start?
Yeah, just a minute. I just want to make one point that there has been a number of meta-analyses where they have reiterated the fact that going by the guidelines, reducing the DAPT too early may result in increased number of stent thrombosis and MI. And there are reports that if necessary, you continue the DAPT along with oral anticoagulant for up to 6 months or 3 months, depending on the risk of ischemia and hemorrhage, particularly in high-risk burden patients, as the Debabrata Majumdar pointed out at the initial stage. That is very important. Okay, next we come to Dr. Debabrata Rai, our beloved Honorary General Secretary of CSI.
Thank you, sir, for your kind introduction, and a very good evening to Dr. Mohanan and all the dignitaries who are assembled.
Would you be a little louder, please?
Thank you, Dr. Shantanu Guho. Let me share my screen, please. Yeah. So are my slides visible?
Yes.
Yeah. So I have been given the task of discussing on the antiplatelet management in ACS PCI. Now, the present day paradigm is gradually shifting towards withdrawal of medicines that are found to be often unnecessary, and that is why we'll be looking towards aspirin-free strategy in ACS PCI. There is enough rationale behind this because aspirins are very gastrotoxic and they are known for producing bleeding. There are incidences of aspirin resistance. And if you use a higher dose, it will promote vasoconstriction. Of course, we now have more potent agents, the P2Y12 inhibitors. Now, it is pertinent to see whether such a strategy can reduce bleeding risk without compromising the ischemic risk. Why bleeding risk is important? Because both the ACUITY and the ADEPT test trials have shown that any major bleed within 30 days and even post-discharge can increase the risk of mortality significantly. Now, these are the latest trials starting from global leaders in 2018 to smart choice in 2020. Of these, the global leaders and the Twilight ACS sub-study are the largest one, and all of them has shown to reduce or the mortality or the adverse events or the major or the MACE without any significant difference in bleed or even as shown in Twilight ACS with a substantial risk of low bleeding. The special mention must be made about Twilight ACS because it is a very well-designed randomized controlled trial where ticagrelor with aspirin has been tried against ticagrelor alone for 12 months after a high-risk PCI, and they failed to show any major difference in death, MI, and stroke between the two groups with a substantial low risk of bleed. Now, this is a very interesting slide. If you divide the patients according to their precise depth score, which identifies a high bleeding risk, less than 25 is the non-high bleeding risk. And
brother, your slides are not moving.
Is it, sir?
Yeah, now it has moved. Now it has moved.
Am I in the precise depth?
You are in the global leaders slide.
Okay. Now, can you see this slide, precise depth?
Yeah, you can hear and see you. Global leaders, top DAPT, Twilight, that slide.
Smart choice.
Okay. Now, can you see this?
Yeah, we can see the 4 trials, global leaders, top DAPT, and Twilight and smart choice trials.
Anyway, let me, even if you cannot see that slide, it doesn't matter. Let me explain. So if you divide the patients into 2 groups, where the precise depth score is less than 25, who are obviously the non-high bleeding risk, and those with a score of more than 25, who are the high bleeding risk group, and consider the patients who have undergone complex PCI or simple non-complex PCI. So what happens? So if you see the bleeding risk, obviously a short DAPT decreases bleed in both the groups and for both types of PCI. But if you consider ischemia and MACE, in the non-high bleeding risk group, the long DAPT performs better for complex PCI. And if you consider the high bleeding risk group, a short DAPT performs better both for complex and non-complex PCI as regards ischemia. But whenever it comes to MACE, short DAPT performs better than for non-complex PCI in the high bleeding risk group, but not for complex PCI. And that is why Dr. Deepak Bhatt once commented that if I undergo a complex PCI, probably, and I would like to have the DAPT continued even beyond 12 months, depending on the risk, of course. Now, as we see that in many cases, depending on the bleeding risk and depending on the ischemic risk, we can continue with a monotherapy agent. Now, which monotherapy agent we should choose? Obviously, ticagrelor and prasugrel is better than clopidogrel because they have more rapid, they have more greater and more consistent inhibition of platelet aggregation which translates into more clinical benefit. And what is important, that there is no effect of CYP2C19 allele on ticagrelor and prasugrel. Because of this CYP2C19 function, if you have this CYP2C19 function loss allele, even if you increase the dose of clopidogrel to 600 milligram loading and 150 milligram maintenance, in the heterozygote allele, there will be only a 50% of efficacy of antiplatelet action, and in the homozygous allele, there will be even less. Now, whether we choose ticagrelor or prasugrel, as per the ESA-REACT-5 trial, prasugrel has shown to be better than ticagrelor for reducing death, MI, stroke, or stent thrombosis with no difference in bleeding risk. However, this is debatable because in ESA-REACT-5, those patients who have undergone angiogram are randomized to receive only a loading dose of prasugrel of 60 milligram and not ticagrelor. However, the ESC 2020 guideline has recommended prasugrelor as a loading dose before PCI as part of early invasive strategy. We have a newer entrant, the cangrelor, which is an IV agent and can be used for periprocedural use. It has proved to be better than clopidogrel and even crushed ticagrelor or prasugrel, and the effect is better with larger CK-MB elevation as shown in the Champion Phoenix trial. And what is important, that there is no effect of co-administered opiates. The genetic or platelet reactivity testing has no proven efficacy, and it is shown that the newer generation stains with thinner strats and better biodegradable polymers, they give better result with monotherapy. Now, this is the ESC, as per the ESC 2020 guideline on non-STEMI, which is published recently in 2021. It is the bleeding risk which predominantly determines the strategy to be followed. If you have a very high bleeding risk, it is always prudent to go for a 1 month therapy with aspirin and clopidogrel, followed by clopidogrel monotherapy. The same is true for a high bleeding risk patient. However, the DFPT can be continued for 3 months. If you have a low bleeding risk, depending on the ischemic risk, you can continue DFPT for 12 months or beyond. And if you consider monotherapy, you can continue DFPT for 3 months as per the twilight regimen, and then continue the ticagrelor monotherapy as per the bleeding risk. Thank you. Thank you for your patience here.
Thank you, Dr. Devabrata Rai, for very to the point, giving some very valuable insights into the problem of deciding as to which and how long antiplatelets to be used in the case of ACS with PCI. The session is now open for discussions. If there is any comment or questions from the audience, please come forward. Iman, likely to make any point? You unmute yourself, please.
Yeah. With prasugrel, I have used prasugrel in more than 1,000 patients in patients whose ischemic burden is very high. But recently, I had a patient who is 36-year-old, and he has got familial hypercholesterolemia. His cholesterol is 370 milligrams per deciliter, and I had a very difficult stenting on this patient because the surgeon refused the patient's trop high and enzymes were high. Actually, it was a case of NSTEMI, and so they refused to do. And naturally, we had to take the patient. We normally don't give also, but anyhow, I had a consultation and I had a heart team approach. And we did it, but even for 5 seconds, we were inflating the balloon, and it's the stent, and we had a V-stenting, ideal set for V-stenting, and the results were fascinating, very good. But the patient, after 6 months of prasugrel plus aspirin 75, his weight is also near 90 kg. he had a subdural hemorrhage. So we had to stop, send for evacuation surgery.
That's
So what is pertinent for Germans, I think, because this patient has got, high ischemic risk, and it was ideally given, So Prasugrel, after 1,000 patients, one patient, I got a subdural hemorrhage.
Okay, I would refer you to two important trials which has been presented this year, 2021. One is a Talos AMI trial, Korean trial, where the short duration of DAPT with clopidogrel only as against clopidogrel aspirin had a better outcome both in terms of hemorrhage as well as ischemic events. The same type of post-exam trial is another trial where they used clopidogrel instead of aspirin after 6 to 18 months of STEMI, and they found the bleeding is less and the outcome is better. Now, if you look at the top DAP trial, the Japanese trial, or Smart Choice trial is a Korean trial, there also they found that short duration of DAPT involving only clopidogrel occasionally, no aspirin, showing better outcome in terms of ischemic and bleeding event as well. So that brings us to a very important issue, whether the Asians are more bleeder, they tolerate clopidogrel better than the other P2Y12 inhibitors or not. That is a very important issue that should be kept in mind. And the second is a very recent meta-analysis of de-escalation. De-escalation could be either by changing the P2Y inhibitor from Tika, Presu to clopidogrel, or it could be from changing from DAP to SAP, dual antiplatelet to single antiplatelet. By and large, it has been shown that if the bleeding risk is the thrombotic risk is not very high, then 1 month's DAPT, because this 1 month is very important from ischemic point of view, but bleeding is important from the rest of the 1 year. But from ischemic point of view, from stent thrombosis point of view, first 1 month is very important. So all the patients should receive DAPT first month if there is no high bleeding risk, preferably up to 6 months with newer stents. And thereafter, the choice is between ischemia and thrombosis, and individualize the choice. My personal opinion is that long run or long DAPT probably is better with clopidogrel aspirin or only clopidogrel, but I don't know as yet, because still the textbooks say that for secondary prevention, indefinite period of aspirin is recommended. You have not changed it. If it is a question of years, 3 years, 4 years, probably aspirin to be continued. But changes are in view in the horizon in terms of shifting from aspirin to clopidogrel.
Sir, can I come in for 30 seconds? Just 30.
Sorry?
Yeah, Dr. Datta, just one more point I want to say is the Pegasus trial, in which ticagrelor has been given at both 90 and 60 milligram BD doses. So that's one evidence of using.
That's why I said the de-escalation in terms of changing the white dose as well as in terms of changing the P2Y inhibitor.
The other point which I just want to bring in, is what is the opinion of the House on the role of, so since I was dealing with non-PCI cases, non-stent cases, of the use of adding rivaroxaban to a dual antiplatelet or a single antiplatelet in the first year of therapy. Now, this is the evidence from the Atlas to ACS team.
That was Atlas SES trial was long time back, so to say, and it was not all the patients did not receive the PCI, and we now probably not in a position to consider NOACs unless the patient is in atrial fibrillation. The guidelines recommendation does not recommend.
Imran, may I have a quick comment?
Yes.
When Atlas was given, nobody was on ticagrelor. So nowadays, everybody in SCS is on ticagrelor. So that's why rivaroxaban never was popular in the SCS patient on top of antiplatelet. But if you see the COMPASS, it is after 1 year of successful uneventful dual antiplatelet. Only after that you are replacing the other antiplatelet. So I think that Dr. Dotto has given the sum up in one, maybe unknowingly also, that in the first month is the ischemia prevails, and then the ischemia flattens out throughout the rest of the life of the patient, but bleeding remains high throughout the rest of the life.
Exactly.
So that is why it is counterintuitive that you are giving 2 antiplatelet versus 1 antiplatelet and your event rate is not changing. How come? How come the ischemia is not less? So are these dummy tablets? No, the thing is that the event is so less after first 1 month that it is very difficult to get a statistically significant difference in the ischemic event.
And newer
event is statistically significant, we could improve that. I think
the importance of the newer generation stent.
And newer generation stents.
Exactly. That is why I was just mentioned. That is important.
I think time is up. Dr. make your final comment and we'll
Sir, just a question to my esteemed teachers that are you really comfortable of completely removing antiplatelets altogether in a background of oral anticoagulant therapy? That is my question.
As a chairperson, I would say no.
Platelets.
I see it's a FIRE trial. I think the FIRE trial has shown that single NOAC after 1 year is enough.
Again, class 1. FIRE is not a trial with ACS. It was a chronic stable angina.
So even after ACS, after 1 year, it becomes a chronic stable kind of thing. You know, if you don't have an episode of ACS in between.
I think we need more trials to be confident enough to withdraw the antiplatelets altogether and keep the patients on oral anticoagulants, as the doctor has suggested.
No,
So we cannot
Devdatta,
still be confident about it.
very quickly, Devdatta, when you are talking about a patient after 1 year, only NOAC because you are giving the NOAC in full. But the Pampas trial, when you are giving
So
the...
if you kindly wrap up the session and let us go, because I have a lecture in Bihar CSI. Otherwise, I'll have to go.
Shomitra, please move to the next one. It is already time.
Thank you. Thanks to all the previous faculty. Now it's my pleasant duty to invite Dr. K.C. Goswami, our past president of CSI, and Dr. Dhiman Kahali, the chairman of the National Intervention Council, to conduct a very, very important and interesting session, which is a highlight of this UCD program for last 18 years. That is the recent trials which influence our practice. This time, we have divided into 2 groups. So the chairpersons, you please take over.
Thank you, Soumitra. Now I invite Dr. Sora Mukherjee to speak on recent trial which influence our practice, ischemic heart disease, heart failure, and antiplatelet. Sora Mukherjee, please.
Good evening. So I'm just going back to my first slide. So good evening, everybody. So in this brief time that I have been allotted, I'll be talking about the recent practices with regards to recent trials with regard to antiplatelets, ischemic heart disease and heart failure, and try to finish within the stipulated time because it's an elaborate subject. Okay, so we start off with a trial in 2018, the results of 3 failed A trials of aspirin. First one, aspirin trial, done in patients over 70 years of age. You are not seeing my screen?
No.
Okay, let me. Let me go to the share option. Okay. Share screen, okay. Is it okay now?
No, it is not coming.
Yeah. Now it is seen.
It's not coming, but I have already.
Now we can see the slides, I think. So you can start.
See.
Yeah,
showing Einstein.
We can see Einstein.
The desktop.
Yeah,
I think.
It's okay now?
It is not coming.
Yeah. You can go on.
All negative trials. Yes.
Yeah.
Okay.
Yeah, sure.
Yeah.
So it's
So
okay.
the 3 negative trials of aspirin, probably my internet connection is in a problem.
Yeah, now it is okay. Anyway, you can start.
Okay. So we talk about the 3 failed A trials in 2018. One was the aspirin trial done in US and Australia in patients over 70 years of age, primary prevention trial I'm talking about. Second one was the ARRIVE trial in patients who are not diabetics. And the third one, ASCENT trial, dedicated to patients who are diabetics. All 3 primary prevention trials, the first 2 failed. The third one, that is the ASCENT trial, that showed some efficacy, but the cost you had to pay was increased bleeding. So that literally put the seal on use of aspirin in primary prevention. Now, another issue in patients with ASCVT, what dose of aspirin you need? Is 81 just enough, or you need 325? A very important trial called the Adaptable trial done recently that showed that in these patients, there was practically no difference in efficacy in 81 versus 325. Bleeding, practically no difference. So the conclusion was that 81 is as good as 325, and in moreover, patients were in the 325 group, there was some because some had to cross over to the 81 either because of tolerability or because of participants' preferences or clinical practices. Another important trial, host exam trial. This is after PCI in AMI. In the long-term follow-up, are you going to use clopidogrel or aspirin? So clearly it shows that after the initial 6 to 18 months were over, clopidogrel was a preferable option to aspirin for long-term. This is a Kaplan-Meier curve for the primary endpoints. Next, PCI in stable cat. 3 important trials: Courage way back in 2007, Orbita, a sham control trial in 2019, and the ischemia trial in the COVID era, 2020. The same thing, that there was no difference in primary endpoints in patients who are allocated to an invasive strategy versus medical therapy. So there was no evidence that the thing that we learned from the Courage trial that still remains, though there might be some differences in the trial design and the patient population, that still the medical therapies holds and don't disturb the coronary arteries in patients who have stable care. Very important issue in AMI, how many arteries to open? We have been traditionally teaching our students that shock is the only situation in which you go for a complete revascularization of all the arteries. Otherwise, you open up the culprit arteries. So that was the recommendation by ACC in 2013. Even the ESC 2012, that shock or severe heart failure is perhaps the only clinical scenario in which complete revascularization can be justified. So for shock, all the arteries. Non-shock, culprit. However, these were the trials done in the period 2004 to 2019. The series of trials, some of them went for FFR guided strategy, some of them went for staged approach, but whatever, the success of this multiple PCI, multiple arteries, that is in addition, that is complete revascularization. So that led to this particular meta-analysis, which clearly shows that complete revascularization is better, and this information is incorporated into the latest guideline, and what was a class 3 indication in 2012 ASC has been upgraded to 2A in 2017 guidelines. So this is about patients who are not in shock. Surprisingly, there's a somersault. What about patients who are in trial? Culprit shock 2017, that showed that the primary endpoint, which was death and a composite of death and severe renal failure, that was more in the complete revascularization group. Maybe you have to think twice about it. Now, very important issue discussed in the previous talks also. After PCI, the duration of DAP therapy, how long or how short? So it all started way back in DAP 2014. After the DAP trials, we had the seminars in the various hotels. And after this was a comparison between 12 months and 30 months of DAP. It was shown that the prolonged DAP significantly reduced the strain thrombosis, the increased risk of bleeding. So then we considered this course, the DAP score and the precise DAP score. You have to remember those. It was very difficult to remember unless you are making a presentation or you are appearing in a DM exam. But these trials done later on, so some of them were successful trials, some of them are not successful, like the 2 red ones. Then there was a swing of the pendulum. So the first swing was the 6 months DAP. Now, meta-analysis of done in 2018 by Misumida that showed that post-PCI, 6 months versus 12 months, the results of trial showed that there was no statistical difference in MI, stent thrombosis, mortality, cardiovascular death, adverse cardiac or cerebrovascular events. So 6 months is something that we should think about. Continuing that, this DAPT STEMI trial in 2018, that showed the depth of 6 months followed by SAPT, that is single antiplatelet therapy, versus DAPT for 12 months, the primary endpoint showed no difference. Then the SMART DAPT trial, 2018, again, that showed the same thing, 6 months non-inferior. More swing, we went for 3 months DAPT. Reduced 2019 trial done in ACS. That was a very short duration of DAPT, 3 months versus 12 months. Primary endpoint, 3 months was non-inferior again. The Twilight trial, done in patients with high bleeding risks and ischemic risks in 2009. Ticagrelor is used. 3 months DAPT, then ticagrelor alone versus DAPT for 12 months. The primary safety endpoint, that is bleeding, was the safety primary endpoint. 3 months was found to be superior. And the secondary endpoint, the death MI and stroke composite, there was no difference. ECO 2020, PCI after ACS, 3 months DAPT versus ticagrelor monotherapy versus 12 months DAPT. So ticagrelor monotherapy after 3 months, so that was found to be superior in reducing a composite of death MI, target vascularization, and bleeding. More swing, maximum swing, 1 month DAPT. The Global Leaders Trial 2019, PCI for patients of stable and unstable CAD, a DAPT for 1 month versus a DAPT for 12 months. The primary endpoint were again similar. Stop DAPT 2019, 1 month DAPT followed by clopidogrel monotherapy versus 12 months of DAPT, then aspirin monotherapy. It was found that the primary outcome in the 1 month DAPT group was superior, shown in green. The Master DAPT trial will be a hotline session in the ESC, will be presented this month in the last week. We'll be waiting for that. Now, next issue I'm going to touch in very short. It has been discussed in the by my previous speakers. In case of PCI, if the patient is already on oral anticoagulants, whether it should be DAPT or SAPT, or it should be vitamin K antagonist or NOACs, and how many antiplatelets. So 3 important trials have summarized. 2013 West, where VK plus SAPT was compared with VK plus DAPT. Bleeding was the primary endpoint. The VK plus SAPT was superior. Efficacy remained the same. 2016, the Pioneer AFPCI trial, where you had 3 groups, NOAC in low dose plus SAPT, or NOAC with very low dose with DAPT. And the NOAC used was rivaroxaban. It was compared with vitamin K antagonist plus DAPT. It was shown that the bleeding was less in the NOAC plus SAPT group. Efficacy still remained the same. The Redual PCL trial done with dabigatran similarly in 2017 showed that a NOAC plus SAPT was superior to a VK plus DAPT in terms of bleeding, and efficacy remained the same. So that these 3 trials gave the impression that if we use oral anticoagulants, or if oral anticoagulant is already on board, and if you are using antiplatelets, you can safely take away one antiplatelet and use one antiplatelet only. To summarize these 3 trials, first trial in 2019, addressing 2 important issues, whether it should be VK or NOAC, whether it should be DAPT or SAPT. So this was a factorial 2 design. The groups were VK plus DAPT, VK plus SAPT, NOAC plus DAPT, NOAC plus SAPT. What we saw? It was seen that for bleeding, as far as bleeding was concerned, NOAC was superior to VK, and SAPT was superior to DAPT, and efficacy remained. Become heart failure. The journey starts after Paradigm, which was a landmark trial in 2014. In the Paradigm, we had specific patient criteria. They were chronic patients, so can we do the trial in acute patients? They were HFrEF patients, can we use ARNI in HFpEF? There were a majority NOIHA class 2 to 3 patients, only less than 1% were class 4. Can we use it in NIHA 4 patients? we had a washout period. We went for AC inhibitor, ARB, and then we went for this ARNI. Can we go for a direct ARNI approach? And finally, can you use ARNI instead of ACE inhibitors after AMI? So 2021, the LIFE trial that shows the patients with very advanced heart failure, sacubitril valsartan was compared with valsartan alone, and the endpoint was change in NT-proBNP, and the secondary endpoints were efficacy and safety, and it was seen that in both of them, you see, none of them were able to reduce the NT-proNB from the baseline. And the secondary endpoints almost remain the same. So sacubitril valsartan comparison, this combination was not superior to valsartan. There might be some explanations like LIFE patients were sicker, run-in period was shorter, comparator arm here was valsartan instead of the ACE inhibitor in case of Paradigm. Now, acute heart failure. This pioneer heart failure trial in 2019 showed ARNI versus enalapril, the primary endpoint being an NT-proBNP change. So the ARNI was superior to enalapril because it significantly reduced the NT-proBNP level. ARNI in HFpEF, the trial was the Paragon trial, Paragon heart failure trial, where ARNI was compared to valsartan. And just before the ESC 2019, we got the sad news that ARNI narrowly missed the primary endpoint of death and heart failure hospitalization, though the safety profile was confirmed. However, based on the evidences, this year in 2021, FDA has opened up the use of sacubitril valsartan in patients with heart failure with preserved ejection fraction. Now, ARNI in ACE inhibitor naive patients who were never on ACE inhibitor or ARNI, can you use it straight away? The three trials, Pioneer HF, Proof HF, and Titration study, they used ARNI in heart failure patients without a previous run-in period of ACE inhibitor or ARBs. So the 2021 update of this ACC, they mention that because of this totality of data, a direct ARNI approach is now required. Last issue, ACE inhibitor ARB after AMI instead of this ACE inhibitor. Can you use ARNI in these patients? So this was a Paradise AMI trial recently conducted, 2021, to difference as far as concerned, because nowadays the patients are very vigorously managed, so it's very difficult to make out in the efficacy between ARNI and the ACE inhibitors. Unlike the previous, the top four trials, those were in 1990 and 2003, like the Valiant, AR-Save, Trace, and the trial that you see is the recent trial, Paradise AMI. So the background event is so low, it's very difficult to bring out a superior effect of sacubitril valsartan over ramipril. Coming to SGLT2 inhibitors in heart failure, hot topic. So we had initially some organ protection studies, outcome trials like EMPEREG, CANVAS, and DECLARE-TIMI, and then we had some dedicated trials in heart failure. So the two very important dedicated trials in heart failure, DAPA-HF in 2019 shown on the left, and the EMPEROR reduced trial 2020 on the right, that showed there was a definite improvement in the primary endpoint significantly with the use of SGLT2 inhibitors on top of the already existent standard therapy. Soloist worsening heart failure trial 2020. Worsening heart failure trial in diabetes mellitus patients, it was shown that the primary endpoints were significantly reduced by the use of this sotagliflozin. And the primary efficacy, this was observed in both patients who had LVEF less than 50 and over 50. The SCORE trial was done in patients with diabetes and chronic kidney disease, again with sotagliflozin, and a meta-analysis or a pooled data analysis, very important slide. On the left, you see patients with HFrEF. The pooled data from Soloist and SCORE, definitely in the primary endpoint. What is interesting is data from the Soloist and the SCORE in HFpEF patient. Again, there was a benefit. So we are smelling something that probably we are inching towards our target in the treatment of heart failure with preserved ejection fraction. And finally, the Emperor Preserve trial in 2021 was done in chronic heart failure with HFpEF. Empagliflozin was compared to placebo. And in July 6, 2021, we got the news that the single largest unmet need in cardiovascular medicine was satisfied. Because the primary endpoint was significantly reduced by empagliflozin, this will be presented in ESC in 2021. And so out of all these numerous slides, I have shortened my time. And the final take home is aspirin in primary prevention. No role. Dose 81 is just fine. Stable ischemic heart disease. Don't disturb the coronary arteries and let the patient live in peace in medical therapy. Post PCI in AMI. Clopidogrel scores over aspirin for long-term SAPT. DAPT after PCI. Pendulum is swinging from long to short to shorter to shortest. Role of ARNI after paradigm is keeping on expanding in various directions, but presently has stopped at AMI. SGLT2 inhibitors, the role of SGLT2 inhibitors in HFrEF, it's a runaway success, no doubt about it. In HFpEF, what we call in Bible, the Holy Grail, probably we have achieved that Holy Grail in the treatment of heart failure with preserved ejection fraction. Thank you all for your patient listening.
Thank you, Dr. Saurabh. Over to my colleague, Mohan Kali.
Thank you, Professor Goswami, and thanks, Shoro. It was an outstanding lecture. You didn't leave anything, Shoro. I was just listening to you word by word, and yes, really, it's fascinating. You have not left also EMPA Preserve trial. The results which has been preliminarily shown are going to be present truly, as you told, that on 27th of this month in the ESC meeting. And it's favorable because I was also a PI in both the trials, EMPA Preserved and EMPA Reduced trial, and they have really shown fascinating results. And as you told, last time it made the needs. But this Paradise MI, I think it will reduce the financial burden because many of us were using post-MI earnings, but from the recent trial data, it's very much imminent that it's not useful and we can revert back to ramipril as previously. Also, you have briefed all the antiplatelets in a very nice way, and increasingly we are reducing the duration of DAPT, which we have been listening from our previous speaker, Dr. Devdatta Majumdar, Dr. Debabrata Rai, and others. They have also given excellent lectures like you, and it's really fascinating to see that we are gradually reducing the duration of the DAPT and we are going for SAPT. And some of us, I think Imran mentioned about the Pegasus trial data. We have done a similar trial in the South Asian countries, Themis trial, and the results is similar, and it was presented in ESC with 60 milligrams BID of ticagrelor from second year onwards till the end of third year. So for next 2 years, and it was shown that even with that reduced dose of ticagrelor, it was equally effective, like 90 milligrams BID. And as we have been discussing, I asked Professor Deepak Bhatt, who came last Sunday in our meeting, that what is your opinion regarding clopidogrel alone post PCI after 1 year versus aspirin alone in a dose of 75 here, or 100 milligram or 1 milligram, whatever is available abroad. So he told that the increasing data is showing that clopidogrel alone post PCI is better than aspirin alone. Some of the trials have come. However, we need much more randomized data to substantiate these facts. I have also been practicing this for long because of acidity with aspirin alone, and for long-term aspirin, as you know, that it increases the bleeding risk only by its GI side effects, aspirin. So we are gradually reverting to clopidogrel alone. So you have mentioned everything, Shoro. I think it's an outstanding lecture, and I was fascinated by your lecture. So Anjunda, any comments by you?
And Dhiman, please, there is another lecture on those recent trials.
Yeah, sure.
Finish it off.
No, I have typed also that I have to be excused. I have a lecture in Bihar CSI.
Okay, no, you said that. That's why just I started this thing.
Okay, we have to move the next lecture.
Yeah, please.
The next lecture is lipid, COVID, and cardiovascular disease in others. Speaker is Dr. Anab Datta. Please.
Thank you, sir. It's my pleasure and honor to be talking in front of all my senior teachers, colleagues, and hi to my junior friends also. Just a few seconds to share my screen. Just a moment, please.
Oh, no, please keep the time.
Yeah,
we are already running late.
I know, sir. Sir, is my...
yeah, it's visible.
It's visible. Thank you. Thank you, sir. I will be focusing on trials that have influenced our practice with respect to three other important aspects of cardiology and cardiovascular science. The one is completely new for the last 1.5 years. That is COVID and cardiovascular disease. The trials that we have had that have been published in the last 12 months on the management of the cardiovascular aspects of COVID, which have influenced our practice, and some new data that we have on dyslipidemia and hypertension. I don't have much time, and hence I will only summarize those aspects in 2 or 3 slides. Coming to COVID and cardiovascular disease, the most important trial in the last 1 year to have influenced our practice is this trial known as the ACTION trial. This was about anticoagulation in patients hospitalized with COVID-19. We know that cardiovascular manifestations of COVID have been common, apart from respiratory complications. We have been using thromboprophylaxis, both oral and parenteral, in various doses and various molecules. But what does the evidence base have to say about anticoagulation in hospitalized patients and thromboprophylaxis for COVID-19 patients? So this was the background on which this study was done. Very important to remember that elevated biomarkers of thrombosis such as D-dimer, etc., are associated with disease progression and higher mortality. That has already been shown by trials by Gungor et al., showing that elevated thrombotic biomarkers are associated with worsening outcomes. And also recent data had suggested that anticoagulation might improve clinical outcomes. But it was not clear that which patients, what is the type of anticoagulant, what is the correct dose and duration for these drugs was completely unknown. And this ACTION trial was designed to assess whether a strategy of therapeutic anticoagulation primary with rivaroxaban was effective in preventing complications in patients hospitalized with COVID-19 with elevated D-dimer levels. And that is why a randomized trial was comparing both the efficacy and safety of this design was seen in the randomized mode. This was the trial design, and which has been since published in the American Heart Journal this year. It included adult patients. Important to remember that all of them had elevated D-dimer more than the upper limit of normal at admission. The patients were randomized, about 615 patients were randomized, and stable patients in hospital were given rivaroxaban with a full dose of 20 milligram, and unstable patients in the in-hospital stay were given enoxaparin in a dose of 1 milligram per kg twice a day, and that was followed up by rivaroxaban for the next 30 days. This was the study flow diagram, again, which showed that about 300 patients were allocated in each arm, and they were then sent for primary analysis. And you can see here that there was no significant difference between prophylactic anticoagulation indicated on the basis of hospitalized patients and their risk of thrombosis and routine therapeutic anticoagulation either with rivaroxaban or enoxaparin was not found to be different. So, in hospitalized patients with D-dimer levels, elevated D-dimer levels, initial in-hospital therapeutic anticoagulation followed by short-term rivaroxaban therapy did not improve clinical outcomes and rather increased bleeding compared with in-hospital prophylactic anticoagulation. So what is the summary of recommendations as far as thromboprophylaxis in COVID-19 disease for cardiovascular risk reduction is concerned? That patients on chronic anticoagulation or antiplatelet therapy should continue their current regimens despite COVID-19 diagnosis. But again, hospitalized patients, routine thromboprophylaxis for outpatients with mild COVID-19 is strictly not recommended. Hospitalized patients should only receive pharmacological prophylaxis with either low molecular weight heparin or alternatively unfractionated heparin, depending on the renal profile, with standard prophylactic doses. No role of therapeutic anticoagulation either with NOACs or routinely with low molecular weight heparin is no longer recommended, even in patients with elevated biomarkers of thrombosis, including D-dimer. Also, post-discharge prophylaxis must only be considered based on bleeding and thrombotic risk per se, and not as standard guidelines for all patients. And patients with venous thromboembolism are the only set of patients who should be treated with therapeutic doses of anticoagulation, and the choice of agent in that case should be guided by patient-specific factors like renal function, like body weight, etc. The second important trial that I need to summarize in COVID cardiovascular interaction is the role of statins. And unfortunately, this study known as the Inspiration and the Inspiration S trials have also proven to be negative trials, which were actually open label randomized trials where initial randomization was between standard dose anticoagulation and a second randomization was with statin therapy. And there again, you can see that double-blind assignment to atorvastatin 20 milligram once daily versus placebo was done. And this again was approximately a 10-month trial starting in July 2020, and enrollment was stopped in April 2021. And now that we have the data, again, you can see the first randomization between standard dose enoxaparin and intermediate dose enoxaparin, the hazard ratio is only 1.06% and the p-value 0.61 is not significant. So also the second randomization of atorvastatin versus placebo, again there was no difference between in the primary outcome of all-cause mortality or ischemic stroke, and hence it was seen that in patients with COVID-19 admitted to ICU, statin in a standard dose of 20 milligram did not result in significantly reduced risk of primary outcome, ECMO, or all-cause mortality. So the conclusion was that in patients, sick patients admitted in ICU with COVID-19, statin therapy did not result in any significant reduction of risk of primary outcome, including thrombosis, treatment with ECMO, or all-cause mortality. These are the two important negative trials which have influenced our cardiology practice as far as COVID complications is concerned. One was the ACTION trial and the other was the INSPIRATION trial. And unfortunately, both of these trials have turned out to be negative. Regarding lipids, Dr. Hajra, in his earlier lecture, in the first lecture of this session, has already talked in details about the newer targets that are coming up regarding LDL cholesterol reduction, because we now have a lot of newer agents in dyslipidemia, apart from statins, apart from ezetimibe, and apart from PCSK9 inhibitors, which are now being approved and under review and also in early clinical development as far as new targets for LDL cholesterol reduction is concerned. Bempedoic acid, again, this is a phase 3 program, and it has been launched with the trade name of Nexletol, both in United States and the European Union. And there are a lot of trials being designed and which are being already going on as we talk, which are known as the CLEAR group of trials. These are the CLEAR Harmony, CLEAR Wisdom, CLEAR Serenity, Tranquility, and Outcomes trials. And these will all look at this new drug of bempedoic acid along with a fixed dose combination of with ezetimibe. And they will all be used in adults with heterogeneous familial hypercholesterolemia or established atherosclerotic cardiovascular disease who require additional cardiovascular morbidity and mortality reduction by LDL cholesterol lowering. Apart from this bempedoic acid, the other genetic technologies which are in the horizon are the monoclonal antibodies, the antisense oligonucleotides, the siRNA, which are all being developed. Particularly in these group of new drugs, two drugs are important which need to be highlighted in 2021. One is evinacumab, which has been approved by FDA as an adjunct to other LDL cholesterol lowering therapies, particularly in homozygous familial hypercholesterolemia. And it is actually an inhibitor of the enzyme lipoprotein lipase. The change of LDL cholesterol is very, very significant with evinacumab, and the p-value in all the regimens, the dosage regimens, are highly significant. The other molecule that I was talking about is inclisiran, and that is actually siRNA which targets the PCSK9 receptor, and that is the mechanism of action. Again, a lot of trials are already in the horizon which are investigating inclisiran use to support LDL cholesterol lowering, and they are as a whole known as the Orion group of trials, the Orion 9 trial, the Orion 10 trial, and the Orion 11 trial, of which the Orion 10 trial is the most important, where it is looking at the use of inclisiran in atherosclerotic cardiovascular disease patients who have persistent higher LDL cholesterol more than 70 in spite of maximally tolerated doses of statin and ezetimibe. So, to summarize what is going on in the arena of lipid management, and in 2021, the trials have all been targeting the non-statin LDL cholesterol lowering therapy regimen, which provides additional options for management of patients with increased residual atherosclerotic cardiovascular disease risk, of which I have said the three important molecules which are there very much in the phase 2 and phase 3 trials. One is the bempedoic acid, along with ezetimibe, which has lesser muscle side effects and cardiovascular outcome data is pending. Then we have the evinacumab, which I said is actually a monoclonal antibody targeting lipoprotein lipase, and that has been approved for the treatment of homozygous familial hypercholesterolemia. And lastly, we have inclisiran, which is actually an injectable siRNA which inhibits PCSK9 translation and can be given at a 6-monthly dosage. So agents are under development targeting the various newer proteins and enzymes through siRNA and antisense technology, which may offer further LDL cholesterol lowering and may optimize further lipid management in the near future. The last aspect of cardiovascular disease in 2021, which I thought needs to be highlighted in a podium, in a forum like this, where we are discussing new things, things which are on the horizon, which have been which have come in 2021, which we all need to know and share with each other, is the Radiance HDL trial. This is a completely new sham-controlled renal denervation trial. We know that after Simplicity 3, the enthusiasm for renal denervation had gone out quite a lot. But now, with sham-controlled, more properly designed and properly included patients in trials for renal denervation, we might now see a resurgence of renal denervation in the future. Particularly, this trial may be the harbinger of this new era for renal denervation, which is known as the Radiance HDN trial. So, endovascular renal denervation, we know that it reduces blood pressure, but its blood pressure lowering effect has not been previously demonstrated in patients with resistant hypertension. So this trial was done with the study objective to investigate whether endovascular ultrasound renal denervation reduces daytime ABPM in patients who were hypertensive and resistant to a standardized fixed dose triple medication pill. So what is this actually? It is known as the Paradise Ultrasound Renal Denervation System. It's a completely designed system which comes with its own console. A ring of ablative energy is given to interrupt the renal traffic, the renal nerve traffic, and the arterial wall is protected by the water circulating through the balloon. Yes, I'll just summarize in 1 or 2 more slides. So 2 to 3 sonications are given lasting 7 seconds. This was the trial design. You can see that it was a sham-controlled trial where ultrasound renal denervation was completely randomized with a sham procedure. The office BP was more than 140/90, even with 3 or more hypertensive medications. All the patients did have a renal angiogram. About 1,000 patients were enrolled, and only 136 underwent randomization. Around 70 patients underwent renal denervation, but you can see here that the daytime ambulatory blood pressure reduction was significant in the renal denervation arm compared to the sham. You can see here the p-value was significant both in the ITT population as well as the complete ABPM population. There was significant blood pressure reduction up to 6 to 9 millimeter of mercury in the renal denervation arm. Also, additional follow-up will be required to determine whether blood pressure lowering effect is safe and durable over time, and most importantly, whether these patients who remained uncontrolled would have been helped with additional antihypertensive agents, particularly spironolactone. Also, pre-procedural predictors of responsiveness, and there are no intra-procedural markers whether actually successful denervation has been done or not. Since that cannot be done, patient variability will continue to be observed in such a observer-dependent and operator-dependent procedure compared to a randomization. So, in patients with hypertension resistant to guideline recommended triple drug therapy, ultrasound RDN may be effective in further reduction of ABPM, but again, longer-term assessments for efficacy as well as safety are required and are already ongoing, and we need to look at renal denervation in a newer light in 2021 and look at more trials to more effectively manage resistant hypertension in the future with something more than what pills offer till now. Thank you very much, everybody, for being a part of this discussion.
Thank you, Dr. Arnav. We are already 40 minutes late. Is there any question in the chat box? We can take it, otherwise we have to close this session.
No, sir, there is no question in the chat.
Okay, so close this session because we are already late. Thank you, Dr. Samitra.
Thank you, Dr. Goswami. Thank you very much. Soumitra, next, that has been a request. Dr. Rakesh Yadav, he has some problem. He has to leave a little early. So he will speak now. And to chair his session, we have Shivananda Datta and Dr. D.P. Sinha. You follow Rakesh and the same set.
I hope Dr. Zakaria has got time to stay over.
No problem. No problem.
Thank you, sir. Thank you, sir. So nice of you.
Thank you. Giver.
Thank you,
very
Dr.
much.
Gua, sir.
Thank you very much.
I'm audible?
Yes.
Yes. I am not to go anywhere, but there is a power cut announced because of repair of a transformer in my colony. So probably they will cut at 8:15 or 8 o'clock. That's why I have requested. Sir, mujhe de dijiye. I will be available on mobile. And thank you, Dr. Shantanu Gua. This is really a very wonderful meeting, always loved by everybody. A very pertinent, very good questions has been asked, and I was assigned a cardiovascular manifestation during COVID and post-COVID. And I will be highlighting more on post-COVID manifestation. We all know that this disease is caused by SARS-CoV-2, and it is a beta coronavirus, and it enters into the cell by the ACE2 receptor. And
Rakesh, one second, sir.
Like SARS-1, which has outbreak in 2012, and Middle East or MERS-COVID, which is in 2018.
Rakesh.
These are the common symptoms, and I think every day you add one more symptoms. Fever, cough, myalgia, fatigue, expectoration, dyspnea, lymphopenia, sore throat, diarrhea. Even now they believe that few strains are causing more diarrhea, abdominal pain, dizziness, headache. These are the all common symptoms by which
Dr. Rakesh
of the patients of COVID.
Dr. Rakesh, 1 second, sir. Just
in severe cases, yes, pneumonia, ARDS, ACS, cardiac shock, increased risk of co-infection, SCD, and stroke are the main culprit. The most important thing that COVID illness is not limited to just index event. Delayed and persistent symptoms has been observed in the survivors, irrespective of their severity at initial illness. Therefore, COVID illness has been divided into 3 parts by CDC: acute, lasting up to 4 hours, 4 weeks, ongoing symptoms of COVID-19 from 4 weeks up to 12 weeks, and post-COVID syndrome when signs and symptoms continued beyond 4 weeks or they develop after 12 weeks. We all know these are the acute comorbid condition which increases the mortality and morbidity in acute COVID infection. And if you have either CVD or diabetes comorbidity, it increases the risk of death by about 12 times more. As far as acute cardiovascular manifestations and clinical course of COVID-19 infection occur, the first and foremost is that if you have a cardiovascular disease, you are a hypertension, you have these are the 2 important comorbidities. And they increases the acute illness morbidity and mortality to much higher extent. When you have a severe COVID, it is usually associated with myocardial damage and cardiac arrhythmias. And you have to monitor the drug toxicity which are used in COVID-19 infection. The cardiovascular involvement comprises mainly of indirect myocardial injury, which is because of severe inflammatory response to the COVID-19 infection, and hemodynamic changes due to extensive respiratory involvement, leading to hypoxia, which further increase the myocardial injury. However, about 20% cases, it has been demonstrated that the direct myocardial injury is also important. In the presence of myocarditis, because it is known that COVID-19 can lead to acute myocarditis, not acute, subacute myocarditis, and delayed myocarditis. The stress cardiomyopathy is known to increase by 3 times when it is compared to pre-COVID era. The possible is, yes, COVID-19, now it is very clear that it leads to possible ACS because of 2 mechanisms, increased thromboembolic phenomena or because of rupture of atherosclerotic plaque. It has been shown that atherosclerotic plaques become more vulnerable to rupture during COVID-19 infection. It may lead to cardiac arrhythmia and it may lead to sudden cardiac death. Thrombosis to various organs. Pulmonary thromboembolism is one of the very important cause of morbidity and mortality. And bleeding, because you have a thrombosis and higher bleeding because of thrombocytopenia, because of platelet malfunction. So you have a combination of these 2 things which is occurring in acute COVID infection. Heart failure and cardiogenic shock is the last severe manifestation of cardiovascular involvement. This is very, very important. COVID-19 infection per se may lead to increased biomarker level, which is for cardiac abnormality. You have elevated troponin level without acute myocarditis, without ACS. So elevated troponin level is not 100% correlate with myocardial damage, but it has been demonstrated that if you have a higher cardiac troponin level in COVID-19 infection, you have a very high chances of other morbidity and mortality. Pro-BNP level without even heart failure can be raised. So if patient is breathless because of lung problem, his BNP is high, you should suspect, if you are strong that patient is heart failure, it should be taken as a pinch of salt. We have seen BNP level of 30,000 with normal echo, and on CT scan it is not heart failure but more so a patchy distribution, always confusing, because sometimes you may have an hypotension, you give diuretics, it's further deteriorate electrolyte imbalance. You have increased D-dimer level, increased ferritin level, and LDH level. Believe it, increased D-dimer, because it is sometimes very difficult to measure D-dimer level. So even D-dimer is low, you can have increased chances of thrombosis. But invariably, in majority of the patient, if there's a moderate to severe COVID, the D-dimer will be increased. Myocardial injury and acute myocarditis can mimic ACS. That is very, very important. You have ST elevation, you may have increased engine, but you take this patient to angiogram and coronaries are normal. So you have to be very cautious in making the diagnosis of acute coronary syndrome in presence of raise and some STT changes. There's always a delayed presentation of ST-EMI because people think that it is because of COVID changes, but actually patient is having STEMI. And we all know that the COVID increased door to balloon time. The thrombolysis is always preferred in various hospitals. But mind it, if you are doing an intervention, primary PCI, thrombolysis, the coagulation parameters are often deranged. So be cautious. You have an increased chance of thrombosis, you have increased chance of bleeding, and you don't know which patient will bleed, which patient will have increased chances of thrombosis. There's a lot of drugs which are used in treatment of COVID which can lead to cardiac toxicity. Antiviral drugs like lopinavir and ritonavir increases the QT interval and prolong the PR. The ribavirin which is being used can lead to an increase in warfarin dosing. Lopinavir and ritonavir can reduce the effect of rivaroxaban and apixaban. If you are giving the lopinavir and ritonavir, though they are not used in India, but invariably it is used in Western country, it can increase serum concentration of ticagrelor. However, there is only one drug, which is prasogil, which is on study, has not shown to change its behavior during COVID infection and antiviral treatment. Don't give lopinavir, ritonavir with statins because causes a lot of myopathy. Lovastatin and simvastatin are contraindicated in COVID-19. It has been written that it may cause rhabdomyolysis. If you are giving atorva and rozova, give in very low doses. You have to avoid QT prolonger. And if you are giving this QT prolonger, monitor the ECG like SCQ, azithromycin, and amiodarone. And risk of torsity pointing increases if you have electrolyte imbalance, hepatic renal failure, structural heart disease. And one thing, though it has been believed that if you block the ACE receptor, if you give an ACE and ARB, theoretically, it will increases the infection of COVID. But the study has shown that ARB and ACS are going to help in COVID patient rather than cause deterioration. This is a very good algorithm. I'm not going to describe this algorithm, but the Cardiology Society of India has given a very good algorithm of management of STEMI patient in this COVID era. In congenital heart disease, yes, the patient is having congenital heart disease, they are more prone for complications because they have a limited cardiovascular reserve. And there is a Kawasaki-like presentation also seen in these patients. These are the ECG abnormalities. Sinus tachycardia present is approximately more than 70% of the cases. You may have a baseline QT prolongation, which may be because of drug, and per se COVID infection is shown to increase the QT interval. You may have a lot of STT abnormalities. Atrial fibrillation has been reported up to 10% of cases, VT up to 3% of cases. The classical finding of S1 QT3, pulmonary embolism, Brugada pattern has been shown, and there is increased incidence of AV block during COVID infection. Now come the post-COVID condition. Post-COVID condition has a wide range of new, returning, or ongoing health problem of a patient who has experienced the COVID. One thing is very important. Even patient who did not have any symptoms of COVID-19 during the index infection. It simply means that patient is asymptomatic. He was diagnosed to have COVID. They have shown to develop post-COVID conditions. These post-COVID conditions are often called long COVID, long haul COVID, post-acute COVID-19, long-term effect of COVID, or chronic COVID, whatever you name, this all belongs to the same category. And this is a beautiful diagram which depicts the stages of COVID. Acute COVID stage lasts up to 4 weeks. Then there was a subacute or ongoing COVID which lasts up to 12 weeks. And after that, there's a chronic or post-COVID. And believe me, practically each and every important organ is involved in post-COVID care, starting from a generalized fatigue, dyspnea, cough, persistent oxygen requirement, anxiety, depression. Up to 50% of the patient has severe neurological problem, sleep disturbances, headache, palpitation, chest pain, thromboembolism, kidney failure, and now hair loss is coming up to 20% of the cases in post-COVID part. Now, these post-COVID symptoms are attributed mainly because of persistent infection, autonomous imbalance, and direct cardiotoxicity or toxicity of the lung and neurological, the CNS. Now, these are the 4 or 5 important cardiovascular symptoms which comes in post-COVID part: breathing difficulty, tiredness and fatigue, symptoms that get worse after physical activity, palpitation, dizziness or standing, and chest pain. Now, coming to the various, I have really searched, and believe me, after reading all this, I find that practically 50% patient who has a moderate to severe COVID have some important severe post-COVID symptom. This study included about 600 patients, 6-month follow-up. This is the left column shows the symptoms during the COVID, and the red column shows symptoms after 6 months. And see, the anosmia, the fatigue, neurological symptoms, the dyspnea is very, very important, up to 50% cases. So about 40% has a high burden of symptoms, more than 2. And if you see the patient who has a mild to moderate, asymptomatic and mild COVID versus moderate, severe and critical COVID, these symptoms are found in moderate, severe or critical COVID. This study published in Annals, 60 days outcome among patients hospitalized with COVID-19, about 1,700 patients, 500 follow-up. Again, 32% patients report persistent symptoms. Dyspnea 22, cough 15, persistent loss of taste 13. The most important thing, really half report emotional effect by their health. Out of 19 patients, out of the patients who are employed before, about 1/3 cannot join even after 6 months to their employment because of ongoing health issues. This is again a study of COVID after 6 months, which shows again fatigue 53, dyspnea 43, joint pain 27, and they say in 143 patients, up to 87% patient after 60 days will have some form of this system. Again, 6 months, a large study comprises of 2,000 patients, and they again show that muscle weakness and fatigue up to 63%, sleep difficulty in 26% cases, and anxiety and depression 23% cases. Again, in a larger study, in a non-critical COVID, this study has done in a non-critical mild to moderate COVID. And again, in day 60, 66% patients are having anosmia, dyspnea, or asthenia. This is a 7 month of symptoms and their impact. 56 countries were involved. It's a questionnaire-based study. Again, what they show, about 77% patients are having fatigue or post-exertion malaise or cognitive dysfunction. Even after 7 months, 85% experience relapse of these symptoms when they exert, when they do exercise, when they do physical or mental activity. So even after 7 months, more than 2/3 of the patient will have some form of fatigue in these patients. Again, a long study, COVID persisting symptoms. Sorry. And they found again, more than 70% patient will have some form of symptoms after 6 months. And that is important. About 10% will have persistent lymphopenia. 30% will have elevated D-dimer after 60 days. And 10% will have elevated CRP, and majority will have an abnormal X-ray. Again, cardiovascular. This is a very good study done in 100 patients, and they have done a cardiac MRI. They are all patients. Only 33% patient was hospitalized, 66% in home. They are mild to severe COVID. 100 patient, after 71 days, MRI was done. Believe it, the MRI involvement was found in 78% of the cases in a form of some form of myocarditis. And ongoing myocardial inflammation in 60%. Again, this study which is done in recovered 26 competitive college athletes who are absolutely mild symptomatic or asymptomatic. MRI was done in these patients, and about 46% has evidence of myocarditis or prior myocardial injury in cardiac MRI imaging. Though there are some conflicting evidence also, they say this MRI positivity may not translate into long-term myocarditis or heart failure, but it is a very significant finding. These all are manifestation of COVID, post-COVID symptoms involving from lung, hematological, cardiovascular, neuropsychiatric, renal, endocrine, gastro, dermatology, and a lot of miscellaneous. And these are the most important cardiovascular manifestation post-COVID. They present usually with palpitation, dyspnea, chest pain, and orthostatic symptoms. Long-term sequelae, increased cardiometabolic demand, increased incidence of stress, myocardial fibrosis, scarring, arrhythmia, tachycardia, and autonomous dysfunction. This is very important. We have now found a lot of evidence that COVID-19 can lead to sudden cardiac death. And these are the proposed mechanism for sudden cardiac death in COVID era. It may be because of myocarditis, acute coronary syndrome, hypoxia, coagulation disorder, cardiac tamponade, electrolyte imbalance, and arrhythmogenicity because of drug or direct involvement of myocardium. This is very, very important. And the next 3 or 4 slides, I will be finishing my talk. Autonomous dysfunction in long COVID. And now we are finding a lot of patients who were on 3 antihypertensive drugs, and their blood pressure came to 100. We have to practically stop all the antihypertensive drugs. This is known as orthostatic intolerance syndrome, which includes 3 important components: orthostatic hypertension, vasovagal syncope, or postural orthostatic tachycardia syndrome, known as POTS. Because now it is being demonstrated that COVID-19 infection affects the autonomous function test. So any patients, if they present with breathlessness, palpitation, but they give history of pre-syncope or syncope, should be evaluated carefully. An active stand test should be, I will say, please do, if the patient is symptomatic, please do active standing test in all patients. measure blood pressure and heart rate while 5 minutes lying supine, then make them stand and do the blood pressure and pulse rate after 3 minutes of standing. So if they have more than 20 millimeter systolic and more than 10 millimeter diastolic fall, all their heart rate increases by 30 beats per minute or more when standing for more than 30 seconds, and 40 beats or more in those age 12 to 90, it is labeled as a POTS or orthostatic intolerance syndrome. And what is the treatment? Because it's very difficult to treat. Reassurance and education is the most important. Don't make them panic. Just tell them to do some structural aerobic and anaerobic exercise. As orthostasis may be problem, do a non-upright exercise. Patient may be lying down, do a cycling, do anything. Fluid and salt intake, increase their fluid and salt repletion until they have a LV dysfunction, past history of heart failure. I always say during COVID and post-COVID for 6 months, increase your salt and water intake. Avoid exacerbating factors like advice on rising cautiously from the lying down. You should be in a warm environment, avoid dehydration should be avoided. Additionally, patient can be advised to consume a small and frequent meal rather than large meal, and it is being seen when patient take a large meal, he has a postural hypertension and syncope. So advise them because it will avoid spastic vasodilatation. Isometric exercises are very, very important. Compressive garments are very, very important in this situation. So if they have a orthostatic hypertension or POTS, advise them to put a compressive garment, and this garment should extend to the waist or abdominal binders. It should not be limited to below knee. The drugs may be used if it is very symptomatic. In fludrocortisone, midodrone has been used. Patient should be avoid. One thing is very, very important. We advise patient to lie down, but if there is an orthostatic hypertension, advise them to avoid supine position as much as possible. Sit in the chair. And if it's still very much symptomatic, and if there's a POT, a beta blocker, and usually propanol is preferred. If we have a POT, inappropriate sinus tachycardia, we prefer propranolol. And now there's some study which has shown that ivabradine has got a very good result in this situation. So an area which required further investigation, because the COVID cardiovascular manifestation are coming in a huge way. So we have a myocardial injury and a prognostic value of troponin. It need to be further studied. That raised troponin, because a lot of controversial studies has come. Role of cardiac MRI. If a cardiac MRI find about 70% ongoing myocarditis after 71 days, probably cardiac MRI, but is still not recommended in all patients until you suspect strong myocarditis. That is very, very important. An athlete or a patient or a child who is playing, how early he should return to his athlete. Does it require further investigation? Because study has shown 45% are having myocarditis. So whether it is required, whether echo is sufficient, there's a lot of data coming by spec tracking after 60 days, 90 days, and they find abnormal echo, though his LV function is normal. And important thing, what are long COVID? Prevalence of long COVID in a large. What is exact prevalence? We are not doing. Our Indian studies are very deficient, but we are finding a lot of patients, how to manage their symptoms. That is very, very important. And now you believe a lot of viruses are coming. The increased cytomegalovirus, increased incidence of tuberculosis, maybe there may be increased surge of HIV in these patients. So it is coming in India in very high wave. So this all required a lot of investigation, and the efficacy of POTS therapy, because sometimes POTS is very troublesome. So an impact of long COVID over the psychological well-being of in these patients need to be further investigated. So to conclude my talk, the latest observational, pathological, imaging, clinical studies has tried to clarify, has not clarified still, the short-term and long-term impact of COVID-19 on cardiovascular system. Myocardial injury in COVID-19 appear to be predominantly mediated by severity of critical illness rather than direct myocardial involvement. Autonomous dysfunction is common and very troublesome. Role of MRI, though I think may be a future investigation in all COVID moderate to severe, but still not validated and not advisable. But the biggest problem in our country is in COVID is that there's again lack of uniform scientific health resources, infrastructure for all level, poverty, overcrowding, poor sanitation, public awareness, life versus livelihood, unnecessary fear, and social stigma with COVID-19 is going to inhibit the medical practitioner for post-COVID management. And now there's a lot of recommendation coming from CDC, WHO, that post-COVID treatment should be given by the primary level physician, not a tertiary level physician, because it is going to be a very, very important and major problem in near future. Thank you very much for your kind attention.
Thank you, Rakesh. Dr. Shivananda Doctor and Dr. D.P. Sinha, please give your comments. Dr. Shivananda Doctor and Dr. D.P. Sinha.
That's quite an exhaustive lecture which has covered nearly all the aspects of the post-COVID scenario, which has been alarming to the Western cardiologists. In India, we lack data, but thing is that the post-COVID sudden cardiac death is a very common problem.
Jayanto, ekটু পরে কর।
I would like to have some comments on that from you. Post-COVID sudden cardiac death.
Yes. Hello, sir. You are not audible for a short time.
Yeah.
Can you ask question?
Am I audible?
Yes, sir. Now you are audible.
Yeah. Post-COVID sudden cardiac death. What is the problem in India? Can you elaborate it?
Yes, sir. I have written an editorial in Indian Heart Journal. I'm absolutely thinking that it may not be there, but I find in my practice, in my knowledge, lot of patients are dying suddenly after 2 months, 3 months of COVID infection. And probably the cause may be what I believe it 2 or 3 phases. It may be either a myocarditis. Second important thing, it may be because of increased thromboembolic episodes, which is leading to ACS, or it may be because of postural hypotension. So yes, it is a problem, but there is nothing which can come as a study purpose. However, there are a lot of studies done in the Western country. They find that sudden cardiac death incidence has increased drastically during the COVID period. So there is indirect evidence. There is you are knowing that patient is discharged, everything was fine, suddenly he died. So it is a problem, and it required more investigations, more study, but probably we are not going to get a lot of study on that.
Dr. Shantanu, do I have time for another question?
Dr. Datta is there.
Yes. Am I audible?
Yeah, you are audible. Any comments? Then Durjori can ask.
No, just I want to congratulate Rakesh for his very lucid and informative talks. He has covered all the aspects, and by the meantime, we know that it is not only a respiratory or viral pneumonia, but different cardiovascular manifestations have been elaborated by Rakesh. And Dr. Sinha can do his comment, what he was telling.
Dr. Sinha, please.
Yeah,
the last comment.
Rakesh, in view of your lecture, and thanks for pointing out there's a lot of sudden cardiac death, which could be due to coronary thrombosis. But in a previous lecture, we heard that using of oral anticoagulants, particularly rivaroxaban, is not exactly found to be beneficial. What is your personal practice on it? Post-COVID dimer, you give rivaroxaban or anticoagulants?
Yes. Now I believe in a practice. I say if your D-dimer is raised, you have at least moderate to severe COVID, you have to give Novak for at least 1 month. People have extended it to 6 weeks also. Now there is a strong belief, so the data is controversial, even you have a mild COVID, and if your D-dimer is slightly high, people start giving aspirin to all patients. A lot of physicians I have seen that they start giving aspirin to all the patients. But definitely if you have a moderate to severe, your D-dimer is high, I will give rivaroxaban because 10 milligram is a low dose. There's a very less bleeding complication. But in my practice, I will prefer to give for 1 month at least. And if there is a high comorbidity, it's a diabetic, I will extend to 6 weeks.
Thank you, Dr. Rakesh. Thank you.
Thank you very much.
Sir.
Dr. Rakesh Yadav, Dr. D.P. Sinha, and Dr. Shivananda Datta. We move to the next session. It is management of STEMI in COVID era in India. To chair this session, we have Dr. Gilbert Jakaria and Dev Datta. You are there? Devdatta Bhattacharya. Otherwise, Dr. Dipankar Mukherjee. Dipankar. Okay, Jayanto, you please start sharing your screen and go ahead with the presentation. Jayanto, you can start.
Good evening, everybody. It's a great pleasure for me to join this program once more this year. Thanks to Professor Go for making this informative program for us. My today's topic is management of STEMI in COVID era in India. Now, if you look at the burden of COVID, approximately 190 billion people have been affected worldwide, and the mortality has reached around 4 million. And India, it is around 31 million, and the mortality is approximately 4 lakh. Now, the exact statistics about STEMI we don't have, but the various studies have reported the cardiac injury is occurring in up to 25% of the patients with this disease. As already mentioned by Professor Yadav, that cardiac injury in COVID can occur in many ways, particularly AMI, be it STEMI or NSTEMI, myocarditis, which often simulates ST elevation MI, and that needs an isolation. It can be cardiogenic shock, tachycardiomyopathy, coronary spasm, arrhythmia, and vascular thrombosis. Now, the major impact has been on acute cardiovascular care, especially the AMI patients. Now, how does it do the STEMI? COVID predisposing to STEMI, it actually binds to the ACE2 receptors. As we know, it mostly affects the lung. It can affect the other organs like liver, kidney, heart, blood vessels. The direct vascular injury, it causes plug disruption and thrombosis and endothelial dysfunction. This is rather less common, but the cytokine release, which occurs in the second week with a cytokine storm, often leads to severe inflammation, hemodynamic instability, and thereby a demand-supply mismatch causing ischemia. Now, the mortality in COVID, in the pre-existing cardiovascular disease, if somebody has, it causes severe disease and even death. The case fatality rate may increase in diabetics to about 7.3% and in cardiovascular disease to about 10.5%. Now, the mortality in STEMI, it occurs in about 33% of the patients compared to the non-COVID situation where it occurs only in 11% of the patients. Now, the predictors of the mortality, it is worldwide, including India, the patients who need intubation, shock, patients who are within hospital, they develop the STEMI, patients who are diabetic and who are elderly. And they all need a longer hospital stay or ICU stay. And it has been found that 1 in 5 patients with suspected STEMI do not have any culprit vessel on CAG, and these could be explained by the coronary spasm or myopericarditis, which is very frequent, and also it can be a stress-induced cardiomyopathy. As already mentioned, the type 2, that is a demand-supply mismatch occurring the second week, is more common compared to the type 1 AMI. The atherosclerotic plaque rupture is less common. Now, raised troponin, 18 to 23% of the patients may have, and it may not always be related to coronary artery disease, and frequently it is due to myopericarditis. Now, if we look at how the COVID pandemic has affected our acute cardiology care, first, there was redistribution of the beds and wards to dedicated COVID-19 units. That has affected the inpatient cardiology capacity. There has been cancellation of the elective works, and it has affected the hospital stay of the acute cardiology patients who were not having COVID. Secondly, the patient, suppose a patient with cardiogenic shock and AMI comes to us and we don't have an ICU open for him, the recovery of the CTPS people or the patients were also affected. Secondly, the troponin elevations occurring in 18 to 23% of the patients caused a false positive ACS calls for we cardiologists, and often there were some unnecessary thrombolysis. Secondly, third point was that the less ACS hospital admissions, as we all know, due to the non-availability of the transport, which is very true in our country, where we depend on the local transports, the fear of COVID of the patients, and the fast contact with the medical personnel was also difficult. And finally, the healthcare workers, particularly in the cardiology sector, were much affected because of the close contact during transportation or echocardiography or during interventions. So the challenge is to revisit the present guideline of managing AMI and adapt it to the changed scenario of the COVID situation. Though my topic is on Indian guidelines, I have included 2 slides from ESC STEMI management. They are saying that deperfusion therapy should be considered within 12 hours of ST elevation in 2 contiguous slits. All patients should be considered COVID positive, and safety of the healthcare workers also they have insisted. What they have said is that from diagnosis from fast medical contact to deperfusion can be done within 120 minutes. It can be extended by another 60 minutes due to implementation of the protective measures. Target time if not met, then fibrinolysis can be done, and complete revascularization they have asked for rather than going for a stage procedure to make safe the healthcare workers, and they have asked for an LV angiogram rather than an echocardiography, again to avoid close contact with the patients. And COVID myopericarditis, suppose the patient presents with chest pain, significant ECG changes, and elevated cardiac enzymes. And if we see that there are no pre-existing cardiovascular risk factors, or the wall motion abnormality doesn't fit with a single arterial territory, and if we require, we can use the CT coronary angiography to rule out coronary artery disease, and this is very essential to rule out the myopericarditis. So we Indians, how do we deviate from the above guidelines and adapt to a further modified one? Now, suppose somebody develops STEMI outside hospital. We should prefer, rather fibrinolysis is preferred in our country due to the limited availability of the cath lab. Now, I have a data from non-COVID era that shows the different registries have shown that 40 to 60% of the patients only underwent thrombolysis, and 1 to 14% of the patients had primary PCI. So if that is the situation in these difficult days, how do we manage to have PCI for all patients? Secondly, a patient who develops STEMI within hospital. Suppose the patient is severely ill, having a severe COVID pneumonia. Are we planning for emergency PCI? It would be wise to have a multidisciplinary team approach, go for a fibrinolysis. That would be a better option. And secondly, to keep in our mind, the survival benefit of primary PCI over fibrinolysis is small, only a 2% absolute risk reduction in the non-COVID patients. So in the COVID with a high mortality, things could be worse. And finally, for the field fibrinolysis, we should go for a rescue PCI. Now, with this idea that in 2020, the Indian Heart Journal has published a position statement or document on AMI care management. What they have said, we should screen the patients who had a history of travel, contact with the COVID-19 patients, or fever or shortness of breath. They isolated the patients of low clinical probability. They should go with the non-COVID guidelines. In the acute AMI with confirmed or suspected patients, we should go for a primary PCI. It is preferred, and with necessary precaution and preparedness, keeping in mind the delay in the emergency medical service availability and transfer time to the proper PCI lab, which is not always feasible in our country, and secondly, significant risk of nosocomial infection for our healthcare workers. So the recommendations the Indian Cardiological Society has made is that hemodynamically unstable patient, primary PCI is ideal, especially if the COVID pneumonia is mild to moderate. Secondly, the PCI is desirable in failed thrombolysis and delayed presentation after 12 hours when the patient is still having chest pain. And these patients should have an isolated cath lab, minimum personnel, adequate PPE should be provided to them. Now, clinical decision to PCI should be a joint decision between cardiologist, clinician, and the patients. Now, regarding fibrinolysis, as we all know that fibrinolysis therapy provides rapid and easier deperfusion therapy and causing less staff exposure to infection. So thrombolysis is a prudent option, and especially in the hemodynamically stable patients. However, the patients who have a door to balloon time more than 60 to 90 minutes, or the STEMI is not anterior, here thrombolytic therapy is wiser and bleeding risk is low is also to be seen. The patients who are on mechanical ventilation or high flow oxygen generating high aerosols, again thrombolytic therapy is of choice. Now, another controversial statement that rather, I shouldn't say the controversial statement, it is a farm statement which has raised a controversy, is that patients who are thrombolized in the peripheral centers, the inter-institutional transfer has been discouraged in our guideline. Index facilities should stabilize the patient, and we need not transfer the patient unless it is required, and if required, teleconsultation should be done. But in contradiction to this, in some of our articles, like in JAPI, it has been said that pharmacoinvasive approach has been considered in some centers in our country. Now, a few checklists of the medications, like fibrin-specific agents are to be preferred over thrombolysis. Above 75 years, half-dose tenecteplase should be given. Clopidogrel loading dose shouldn't be given. Dose reduction for enoxaparin. Aspirin and clopidogrel have been well discussed, but we do not have much data on prasugrel or ticagrelor. ACE inhibitors can be safely used. Amiodarone with HCQ-less, regular monitoring of the QT interval is required, as like the antiretroviral viral therapies. And heparin should be given for a duration of hospital stay up to 8 days or up to revascularization. So in conclusion, fibrinolytic therapy is a wise option in Indian scenario. Primary PCI is reserved for hemodynamic instability, life-threatening arrhythmias in a background of mild to moderate pneumonia. Thrombolized stable patients may not be transferred from peripheral centers for further PCI if they are stable. Rescue PCI should be always be considered for failed thrombolytic therapy. Myocarditis mimicking STEMI needs identification because unnecessary thrombolysis should be avoided, and adequate protection of the healthcare workers should be of prime importance. However, the debate can continue because SCI, SEC, SEP, the consensus is still for primary PCI, pharmacoinvasive approach if primary PCI is not feasible, and fibrinolytic therapy, they have also asked for the lower risk patients like inferior wall MI or lateral MI without any hemodynamic compromise. Thank you.
Dr. Giver.
Oh, yes. Thank you, Dr. Jayan Shah, for a wonderful discussion on a very problematic subject. And as I can see, there are three basic areas when you are thinking about STEMI management in the COVID era. The three aspects are, one is the reduction in the acute MI admissions, which we showed in our last study of 41,000 patients all over India in 187 hospitals. We showed that there is a 35% reduction in acute MI admission. And largely this was because of the problem of lockdown and difficulty to reach a hospital in time. So much so that the hospitals in the big cities suffered more than the smaller cities where the reduction in acute MI admission was not very prominent. That is one. The second aspect is the management of whether which reperfusion strategy to be used. All the Western guidelines say that if you have PPE kit and if you have all the facilities, go ahead, because primary PCI is the best option for STEMI. However, in India, it is a heterogeneous country where the facilities differ from region to region, zone to zone, hospital to hospital. So unless we are very sure that we can offer primary PCI, if primary PCI still, even in India, should be the best choice of treatment in STEMI in terms of outcome and benefit. However, it has to be weighed against the facilities available, the options, the hospital. So it has to be a shared decision, and each hospital can form a protocol. The problem is that many hospitals in India have different protocols. Some hospitals, like very large hospitals in Bangalore, they do routine fibrinolysis, not primary PCI, and then go for early coronary angiography and, if required, angioplasty. That is the pharmacoinvasive strategy. But some other hospitals triage the patients. they decide if the anterior wall MI, go for primary PCA. If it is a young patient with MI, go for primary PCA. But all others do a pharmaco-invasive strategy. And some people routinely, irrespective of the nature, go for. So we are yet to evolve. We probably have logistic issues which vary from one place to the other. So each hospital and each region has to adapt and create a protocol suitable with their requirement, their facility, and their capabilities. That is what I think. Then the third, we are doing a study now, Dr. Santanagua, you remember, we are doing a prospective registry to find out which is the strategy employed by the major hospitals in India, and we'll get the results in another 3 to 4 months' time. And the third problem I find is that what happens to these COVID positive STEMI patients, whether they do badly, as depicted by many of the previous speakers, COVID positive STEMI patients, they do very badly. The NACME registry shows that the mortality for COVID positive STEMI patients who happen to be COVID positive, the mortality is 33%. But we don't find that. Our experience of fellow cardiologists say that the large number of patients, in fact, some of the big hospitals say that around 10% of patients with STEMI admitted to their hospital, they have COVID positive. And still they are doing fairly well. Their mortality is still less than 5% or 8% when they do the primary PCA or even pharmaco-invasive strategy. So probably the challenges in India are different, and I think we should adapt to our own requirement, our own capabilities, and considering all the logistic issues. Thank you.
Thank you, Dr. Giver. Incidentally, he is a pioneer in this field and was instrumental in publishing quite a few articles relating to COVID and different cardiovascular diseases, ACS, STEMI, etc. And it has been already published in Indian Heart Journal, and some ongoing registry is also going on. So thank you, Giver.
Oh, thank you.
Thank you very much. So we now move to the last session of this conference, the status of cardiac services in India during the COVID pandemic, to be taken up by Dr. Kunal Sarkar. And to chair the session, we have Professor Jyotirmoy Pal and Dr. Pinto. You are here. Brian? If Brian has not logged in, may I request Dr. Anjanlal Datta to chair with Dr. Jyotirmoy Pal?
Okay.
Thank you.
Thank you.
Kunal, it's your time now.
I hope I'm audible. Can you see my screen?
Yeah, we can see.
Yes.
Thank you.
Just Kunal, 1 minute.
Yeah.
Dr. Kunal Sarkar is just not a renowned cardiac surgeon in India or abroad, but his face is very much well known in India as one who is highlighting different aspects of COVID from the social and medical point of view. Dr. Kunal Sarkar has been with COVID, highlighting, looking into the different aspects, problems in Indian scenario, and I hope that his narrations about this particular topic would throw new lights and help us get more apprised with the problem. Dr. Sarkar, please.
Anjunda, thank you so much. And thank you to Dr. Guho Shantanuda for giving us an opportunity. And I think it is always left to the surgeon to bring the bad news to the table. My deliberations I'll try to share with you something which is primarily more economic than clinical, because all of you over the past 2 days, I see in the agenda, have had a very thorough and very stimulating clinical discussions. Now, what is the... Wait a minute. Why isn't the slide? Let us have a glimpse of the world as it is in terms of interventional cardiology and cardiac surgery. The global situation when we left the world in its normal state somewhere in January of, say, 2019, of 2020 rather, the world at its stood did about 1 million cardiac surgeries and about 7 million cardiac interventions. And out of the total 8 million cardiac procedures, the growth rate annually used to be 5% per year. And the growth rate in the interventional domain was primarily fueled through TAVR in Europe and North America. Coronary surgery, it was growing, especially in the Asia, and thanks to India, somewhere in 0 to 2% per year. And interventions, PCI did have a recorded growth of 3 to 5%. This is a rough state of the world. This is all true of sort of January 2019, January, February time. And Asia Pacific is the main theater of growth as far as cardiac procedures and interventions. But this growth was expected to plateau in 2 years. That is much before, these predictions were made much before the arrival of COVID. And let's see what happens after that. In India, we identified a time around 2006 or 2007 when interventions overtook surgery significantly. And by a thumb rule estimate, all of us know that we do not have very comprehensive data collection in our country. But the cardiac surgery numbers in India stand somewhere around 210,000. And I think the lab intervention stands somewhere around 800,000. Coronary bypass, as far as surgery is concerned, is around 50%. Cardiology, interventional cardiology, if you go to the industry and economic assessments given by various economic forums, out of the 8 lakh or 800,000 procedures done annually, we were still growing. We were growing at 5 to 8% per annum. And around 700 odd centers had 1,200 to 1,300 cath labs. So India's growth rate in intervention, both in terms of the facilities and in terms of the number of cath labs, was definitely impressive. I think one of the highest growth rates in the Asia Pacific region. What I think is, again, number-wise, it thumps the table, which is we have a rough estimate. I don't think you know for yourself either that cardiologists are supposed to be 4,000 to 5,000. In India, about 350 to 400 are added per year. And with the prolific increase in the number of postgraduate seats, it is perhaps foreseen that we may add up to 500 plus cardiology postgraduates annually. I think that is probably in the pipeline. And therein lies a danger. Before we come to the effect of COVID on the business and the procedures, I think in the very near future, with or without COVID, and more so with COVID, I think we are already in a situation where we are seeing a cardiological oversupply, because the number of undergraduate and the postgraduate production in India is increasing exponentially. But I will refer to the slide a little later on. This is something I've discussed in my recently published book at length, that the healthcare infrastructure is not really increasing in keeping with the healthcare personnel. Well, cardiac surgeons, honestly, have been limited because number of cardiac surgeons have been stagnant. We have not populated our postgraduate seats the way we should do, because goes without saying, you know the reasons why, that cardiac surgery does not have a queue of entrants, unlike cardiology. And at a conservative estimate, we have about 30% vacancy in CTVS postgraduate seats. COVID. Now, all of you know the graph. There's nothing new to tell you. And September 2020 is considered to be the peak of the first wave. 17th of September 2020 is the precise date when the first wave peaked. And in May 2021, sometime around 14th or 15th May 2021, is considered to be the peak of the second wave, which at a very, very conservative estimate was about 4 times bigger than the first wave. Now, COVID being, I think there is more or less medical consensus, sort of virological consensus that it is essentially a man-made disaster through the gain of function research. But what we have not got an insight into is that why was it released into the community in that particular time when it was. I think that part of the thriller is yet to be discussed. And I'm expecting some publications in the very near future that why were the lab doors open in September, October 2019? Why not earlier and why not later? Anyway, I'm sure a part of the serial, lot of the story remains to be told. There has been limited publications about what has been the collateral health damage from the outbreak of COVID in different parts of the world. As far as, kind of global or panoramic estimates are concerned, European Heart Journal in February of this year, I think this is a Danish work, and this Danish paper tells us that there has been overall about 5% excess cardiovascular mortality. But we have to remember that they are essentially looking at Europe. Now, if you invert the slide of the case incidence, what we saw a little earlier, you just invert it, you get some idea what effect it has on the kind of clinical and procedural front. But it is not a mirror inversion. The reason it is not a mirror inversion is the first wave, though it was 4 times smaller, had about 1.5 times more effect. Because the lockdown in India, it is now popularly believed that the lockdown in India was probably early by a year. Instead of March 2020, it should have perhaps come in March 2021. That's a different story. Now, the first wave, being a very stringent and very national lockdown for 78 days, it completely flattened the patient's access to sort of any cardiac care, cardiological, cardiac surgical, and this is primarily based on a survey which is done in the All India Institute, and I think All India Institute probably admits that they had a 90% reduction of their activity in that 78 days period. I think there were many places who literally shut shop and did nothing. When we come to the second wave, because second wave by that time the entire national game plan had changed. We did not have any national lockdown. 30 states of India had 35 different plans of how to mitigate the second wave. It was utter chaos. But what happened was, since it was a fragmented phenomenon, and second wave did not rush through the country in a kind of time linear function, because between the West and the East, you had almost 40 days, 45 days time lag. So different regions were suffering in slightly different times, separated about a month and a half. And the impact on the clinical activity that we saw was a little less. And it is roughly computed. These are mostly data you're getting from surveys by accountants and economic forums. What kind of data clinicians come up with, we have to wait for that. So it's about 90% during the first wave and around 70% during the second wave. As we just discussed, that I still consider the first lockdown to be completely miscalculated. It was nationwide, synchronous, severe economic effect. But one thing regarding the first lockdown was that perhaps India did not have any excess mortality as far as the first COVID wave was concerned. There was a thumb rule that, by having a lockdown for 78 days, our mean mortality from COVID, even if it was 1,500 a day, we were saving a net 1,000 lives from road traffic accidents. The second wave was a different story altogether. It was fragmented, no national lockdowns. There was some activity, but that was really traded off for very high mortality. And both the case incidence and mortality was conservatively about 2.5 times higher during the second wave.
Now, almost every hospital I know of, without exception, when we heard the footsteps of the second wave, almost everyone started to get ready by saying that look, we are going to maintain our services. There is no national lockdown this time, so we have to maintain both COVID and non-COVID activities. But friends, all of us have seen the flood in front of our eyes, and we were totally overwhelmed by the magnitude of the calamity. And whatever we planned at the beginning of the onslaught, by the time we came into the heat of the moment, we were completely overtaken by this phenomenon between about April to June 2021. I think that is this, whoever as a healthcare facility stepped into the arena had this unwavering experience between April to June 2021. Now, our experiences will have to be assessed in the background of what is really worrying is COVID or no COVID. India's healthcare infrastructure has literally been growing at a snail's speed. We have about little less than 70,000 hospitals, 43,000 being in the private sector. We have about little less than 19 lakh beds. About 11 to 12 lakhs are again in the private sector. But be it private or public, due to a lot of confusion, the absolute growth rate for a population which is still expanding at more than 1.5% has been pathetically slow. So the bed strength of the infrastructural strength of Indian healthcare remains essentially static. About COVID, the most interesting thing about all this sort of flurry of activities, we being overwhelmed, etc., if you look down each particular state of the country, there are 15 major states in India, 15 smaller states and union territories. I have looked at the clinical care capacity of each and every state, at least during the first wave. And I tell you something, if you look at the stated capacity of every major state in India, right, no state so far has used more than 50 to 60% of what we say is our built-up capacity, is our stated capacity, and that is most confusing. Because when the system, say in North America or United Kingdom or Europe says that we are overwhelmed, what they actually mean to say is they've actually used up at least 80%, if not 90% plus, of their available bed strength. But we got overwhelmed by using less than 60%. And that raises a very serious question that forget about the growth of infrastructure. Does the remaining 30 to 40% of the infrastructure, does it actually exist? If it did, then why did we not bring it out into play? Why did we not actually use that infrastructure when time was at hand? You need to have a concept, we carry all these emotive things about private and public and all these things, and much of these dialogue happens to be a wartime dialogue. But at peacetime, you need to have a kind of granular view of what happens in real life. Now, in private sector, 80% of hospitals do not belong to the large corporate networks. Corporate networks are obviously the likes of an Apollo, Fortis, Max, maybe Medanta, Medica in Eastern India, Narayana. So 80% of private hospitals are very alike the MSME sector of the Indian economy. And we have a lot of standalone infrastructure which are outside corporate hospital networks. And these hospitals took a big beating, and about 50% of their top line was shaved off in these two exposures of COVID. And almost each and every institute, without exception, is what you call EBITDA negative. Many of you understand what EBITDA is. EBITDA is basically a profit margin before you calculate tax, interest, so on and so forth. So the top line, which is the total turnover, was completely shaved off, and the profit margins was completely chewed up. And this will seriously affect their ability to survive. Once again, if I analyze down the line that what happens in cardiac procedures in India, you see 75% of all procedures. I'm taking both surgery and interventional cardiology together, happens in the private sector. About 25% happens in the government sector. And 80%, as we just said, 70 to 80% of all private facilities are small to medium scale. They do not belong to the large scale corporate. And 60% of the private, but you see, the private sectors, they may be about 20 to 25%, but 20 to 25% of the corporate hospitals, they control about 60% of the procedure. So a fewer number of corporate networks do a larger percentage of the procedure. Now, before COVID came and swept through our lives as we knew it, there was another disruption happening in India, and this was a non-virological disruption. And this non-virological disruption is that since about the late, say 2019, 2020, because of the competitive populism between the center and the state, the kind of patient breakup, a private sector was seen, changed quite abruptly over a period of year and a half. Because roughly what has happened is OUP means the out-of-pocket payments. The out-of-pocket, the so-called cash-paying patients were about 50%, 40 to 50% of an average hospital. You had a regular corporate and you had a low insurance. And in a matter of less than 18 months, there was a paradigm change in the way the hospitals, what kind of patients the hospitals saw. Low insurance expanded tremendously, and that was at the expense of the cash payments and the regular corporates. Now, yes, frankly, I think that means well in the long term for a healthcare of a country, but in the short term, the private hospitals have had a tough time or are still having a tough time in trying to cope with this new reality as it is in front of us. So from about 2013, 2014, I mean, not so much in our part of the world, in Eastern India, but especially south of the country, things were changing dramatically because interventional procedures and surgical programs were largely becoming a numbers game. So you had to be very good in having high inventory of moderate or low-paying cases. Now, many of us are familiar that of all the predictions that this COVID is going to have in the Indian economy, you have various scenarios from about a slight impact on the economy to a severe impact on the economy. The severe impact is about 8 to 10% shrinkage in our gross GDP. And as it stands at the moment, I think the severe outcome seems very likely. And these are some numbers, those of who are interested in the fiscal performance of hospitals. So what this slide basically means that when we come to assess the fiscal impact of COVID on hospital sector in the year 2021, all these numbers you see within brackets, 15 and bracket 10%, what it basically means is hospitals, especially the medium grade hospitals, would be in the red. So they're already pushed into the red with the COVID crisis. And these are more data. I won't bore you. It's rather late in the evening with it. There are a lot of parameters you can look at. You can look at EBITDA, you can look at the interest coverage, you can look at your cash receivable days, the cash position, etc. And the summary is, it's like looking at your mortality statistics, clinical outcome, the fiscal outcome. Basically, you can summarize this slide by saying bad news. That's what it is. Was Corona a cushion? A lot of hospitals, especially multi-speciality hospitals, either willingly or forcefully, they were participants in the COVID program. And did the high admission of COVID patients help? Did it help them to see through this sort of a roller coaster ride in terms of financial effect? I think once again the summary answer is no, because there was rate capping in most states. hospital remains because COVID had a lot of critical care load, lot of pharmacy load, lot of rate capping. There were no procedures. There were no implants. There were no procedures. And that is where the revenue intake of the private sector depends to a large extent. And at the end of the day, it was a lot of hard work, a lot of people, a lot of casualties, 1,500 medical lives lost at the end of it. But the private hospitals continue to remain in the financial doldrum. There were few hospitals. There were few hospitals who managed to tide it over better, and the very few hospitals I've mentioned, a few of them over here, because they got involved in the ECMO program. The ECMO program was very challenging, back-breaking, high disposable costs, high manpower, intense workload. We probably run in Medica, Kolkata today, the largest ECMO program of Asia, and that is completely managed by cardiac critical care. There was KIMS Hyderabad, MGM, Medanta, Priti Vinayak, Amri Kolkata, Apollo Kolkata, and these hospitals, with a lot of hard work, did make up from some of the Were we the only country in the world which had the downturn from COVID? Not really. This is a financial snapshot of what's happening in the United States, that overall cardiac practices in the United States are going through exactly the same problem. And Europe is a different kettle of fish because they have only expenditure in their healthcare system. They're not very revenue conscious. We will get to know of it when Germany releases their data. Not a lot of German data is available right now. It made a big difference to training as well. And I found out this paper, which Dr. Guha, Shantanu is one of the co-authors, its impact on cardiovascular training and care. If you haven't read it, have a read of it. Professor Yadav and Dr. Guha, I think, are also mentioned over here. And they make a very important point in this paper. Cardiac surgery in India was struggling but surviving. And the reason cardiac surgery still had a comparative growth rate was that we had very low population penetration. And as the population accessibility to cardiac surgery was improving through the medium pain and the low pain schemes, India was one of the fewest geographies in the world which showed increase in cardiac surgery numbers with better access to healthcare. But again, cardiac surgery took a tremendous hit during this. I think the graphs, you can superimpose the graphs for cardiac surgery and cardiology, but the impact during both the waves, height of both the waves in cardiac surgery was far worse. And the cardiac surgery personnel, the doctors who were involved in cardiac surgical practices, took a big hit, I think more so than cardiology, because if you compare numbers for numbers, a far larger proportion of surgeons and surgical teams are involved in cardiac surgical programs in a fee-for-service model. I think they took a back-breaking hit during both these experiences. And all this turmoil was happening. I've discussed this in my book at length. 2019 was not a very happy year. 2018, 2019 was not a happy year, especially the second spell of the NDA government, because there was a lot of confusion about who's controlling healthcare. There was ever-changing policy. There were 10 states in India trying to usher in public healthcare. The central government wanted to usher in private healthcare. There were high aspirations, budgets were inadequate, and doctors across the country, there was severe increase all across the country in public protests and outrage against doctors, because doctors were actually carrying the cross of the national confusion. So even at the height of the pandemic, forget about what happened before, forget about all we have heard about 1% of GDP being spent on healthcare and all that. How serious are we about healthcare even when the fire is fierce? Even at the height of the pandemic, we have all seen across our television screens the finance minister coming and announcing various tranches of economic stimulus, about 50,000 crores or 40,000 crores. And I did a rough maths, and my rough maths told me that about 5% of all the economic stimulus that was given to the national economy in terms of the pandemic came to healthcare. So that is how serious we are as a country, as a government of healthcare. 5% of assistance came to healthcare at the height of a pandemic. Will private healthcare survive a third wave? This it makes no difference to government facilities because they are largely financially unaccountable. They will go on come wind or high water. We don't know really that what a third wave will look like. I was just listening to a lot of experts, data analysts, data modelers all over the world. Some people are predicting a blip, some people are predicting a bump, and the others are saying no wave will come. We need a lot more local data and local intervention. The vaccination gap between promises and reality is becoming very worrying. But God bless us, if we do have a mammoth third wave, then this will be a crippling blow to standalone hospitals. I am advising 3 such hospitals at this point of time. And I tell you from experience that apart from a kind of larger chain with whom I'm engaged most of my times, I'll tell you the medium scale enterprises are having a tough time to survive. And if we have anything which is even half the magnitude, the impact that the second wave had, I think 10% of the smaller or the medium scale interventional units will become very, very, very vulnerable. The recovery of the economy of a country, the activity of a country in general, and the world overall depends upon, at this time, there is only one variable, and that variable is the efficiency of the vaccination program. We are not doing brilliantly, we are doing something, we are not doing brilliantly. We are going at about 50% of our desired rate. And these are the 3 kind of projections. The upper green line of recovery is should you go hammer and tongs with your vaccination. We have an example in front of us, rather we have 2 examples in front of us. We have Israel and United Kingdom. Israel, United Kingdom is following the green line. They have opened up, they are seeing more cases, they are not seeing increased hospitalization or mortality. And so far, the going is good in those 2 countries. The central projection is where you have a kind of so-so kind of vaccination. Europe probably falls within that line. The Middle East, a part of Central Far East may fall over there. And we are afraid that we are following the lower part of trajectory of economic recovery because our vaccination is just at about half. We wanted to do 90 lakhs to 1 crore a day to get us to about 60% population vaccination by July, August. So we've missed the target and we are about half of our speed. So that is a major source of worry. If we have one comfort, it is really a little bit of a sadistic pleasure. The sadistic pleasure is from the 4th Sero survey, because the 4th Sero survey tells us that 50%, 69.8% is the overall antibody prevalence. So probably God has given us a lot of vaccines for free over there. So that may save us a little bit. Time will tell. So for the time being, friends, I think we have to be holding our hands. The larger infrastructures needs to come together and do a lot of caring that will be needed. Otherwise, a lot of the small and medium scale players who are out there in the field will find it very difficult in the months ahead. So in the meantime, let's keep our masks on, pray well and pray hard, because we do not want the unpleasant experiences of another wave yet again. Thank you, and thank you all for the opportunity. Thanks.
Thank you, Dr. Sarkar, for his nice deliberation. Not only the impact of COVID on cardiovascular outcome, also on the economy. You have described nicely in the broader aspect. Just 1 and 2 point to explain. Really, in the COVID period, non-communicable disease management got a setback. Because when the COVID pandemic struck India, India was not prepared, and India used all the infrastructure prepared for the non-communicable disease. This is one part. Another part is, in the COVID period, we all physicians, we have observed patients prefer the conservative management because they are afraid to go to the hospital. That you mentioned the corporate hospital for any intervention. They prefer Dr. Saab give the medicine, we'll stay at the home. So this is the time to analyze what is the outcome of medical therapy versus interventional therapy in a cardiac patient. Because this data, if we do the in-depth analysis, can give a light how much intervention is really needed for the cardiac patients.
No, I think if you allow me one comment, Jyotirmoy, I think that study has to have a third arm. The third arm is no treatment, second arm will be medical management, third arm will be intervention.
Yes.
Because I honestly think, we need to do a lot of soul searching, because many a times, like in West Bengal at this point of time, our policies on public transport is completely faulted. We are denying patients at appropriate moment access to healthcare the way they should have. And I think, we cannot pretend. This is not the time to have a study on medical, just say between treatment and no treatment. I think about 80% of people just perish without any treatment, without access to any form of healthcare.
Yes, not only for the transport, all the economic condition, the inaccessibility, fearness for to come to the city areas, all these factors have played a role. So I think in the post-COVID period, we should analyze what is the real outcome, what happened to these patients. Thank you, sir. Thank you. Any other question from any or comment?
Kunal, thank you very much for talking on a subject in a different way. A welcome change for all of us. It was an administrative approach, fiscal policy, government policy, failure, not making the expectation fulfill. All these factors are there. But as Jyotirmoy pointed out, to a certain extent, I find another factor is that while the mortality of COVID was around 2 to 4% overall, and the cardiovascular mortality remains high, 10%, 12%, 15, 20%, even then, many of the patients, they were reluctant to go to the hospital because they might get COVID. So the chest pain patient, they suppress their symptoms. The breathing difficulties, they suppress, and they wanted to stay back home. And that was a very important factor from medical point of view as to why the COVID scenario has changed so miserably in terms of treatment and outcome. Because more patients died because of lack or absence of treatment rather than from incomplete treatment because of the fear.
Yes, sir. Yes.
Okay, Kunal, thank you very much. We have exceeded the time.
Thank you, Shantanu.
Thank you very much for a welcome change, rather, in the words of Anyanda. I will also say this is a welcome change because we discussed science today and now we heard something other than science. Thank you for giving the insight. Incidentally, this was the last program of this conference, and we are coming to an end of this UCD 2021. But before I conclude, I need to announce the results of the yesterday's case presentation competition, where All India Institute of Medical Sciences, New Delhi, were the winners, and Sri Chitra Tirunal Institute for Medical Sciences and Technology were the runners-up. And today in the morning, in the quiz competition, again, the All India Institute, New Delhi was the winner, and LPS Medical College, Kanpur, they were the runners-up. So, as every good thing
carries all the prizes.
Yeah, the case presentation, there is a cash award of 60,000 for the winners and 45,000 for the runners-up, and for the quiz 50,000 and 30,000.
Right.
So let us conclude this year's UCD and with a hope that we will be meeting physically rather than virtually in the next year in the UCD 2022. That is our fervent hope, and we really and sincerely wish that we can meet physically and organize the conference in the next year. You have anything to say?
No, I just say আসছে বছর আবার হবে।
আবার নতুন করে ভালোভাবে হবে।
But I again propose, as I said in the yesterday,
we can have a hybrid format.
We will have a hybrid because the acceptance is much more online. Many people can at least partially can attend, and that's help.
At least we can have a hybrid format that we'll discuss and think over.
Yeah.
So, good night.
Thank you, Shantanu. Thank you, Soumitra. Thank you all.
Good night.
Here for an
and
excellent.
Goodbye.
Thank you. Fantastic program, and all the participants did really. I mean, perhaps the Shantanu is a motivating factor for everybody. Everybody gives more than 100% when it is Shantanu's program.
ওরকম লেগে থাকলে কে না করবে।